Amnish. Hello. Pankaj. Pankaj. Hello.
Hello, sir. How are you?
I'm good, Pankaj. Can you hear me?
Yes, sir.
It's okay.
Yeah,
Clarity.
all fine.
Okay. Is Avnish there? Hello.
Checking, sir. Checking.
Pankaj? 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 हेलो
हाँ जी सर.
पंकज, ये अगर डेलीगेट्स को क्वेश्चन पूछना है तो हाउ डू दे आस्क?
Sir, they will go to auditorium and there is a tab. They
Okay.
can just click that tab and type their question over there and just click the submit button. Right, sir?
Okay, ठीक है. We'll start by 8:45, okay? Hello? Hello?
हाँ जी सर.
We will start by 8:45. Sharp 9 o'clock, first lecture should be ready.
Right, sir.
All lectures have come
Yes, sir.
and everything has been loaded and you are aware of the sequence, isn't it?
Yes, sir. Yes.
Yeah.
My colleague is there. Hello. He is handling everything, sir. He will play.
Alok?
He is in washroom right now, sir.
घनश्याम सर, ये इनोग्रेशन 8:45 पे करना है सर?
अरे सर एक दो हेलो
Avnish, I'm coming, Avnish.
अच्छा,
You have logged in as a panelist, no?
यस सर
Actually, आपको अवनीश,
हाँ सर,
हाँ बोलो।
मैं कह रहा हूँ सर 8:45 पे करना है, क्योंकि अभी प्लेटफॉर्म में 20 ही लोग हैं, मैं बैकएंड देख रहा
चलेगा, 20 लोग रहने दो, 25 लोग रहने दो।
हूँ, क्योंकि हमने 1 मिनट से भी कम की वीडियो बनाई है इनोग्रेशन की, तो 9 बजने में 2 मिनट पहले ऐसे करते हैं, थोड़े लोग आ जाएंगे।
ठीक है, काम करते हैं, 8:50 को शुरू करते हैं।
ठीक है, 8:50 हेलो, 8:50 करेंगे, उसको डाउनलोड कर ले वीडियो।
डन।
ठीक है।
श्रीनिवास सर का वीडियो तो मतलब, हेलो अवनीश,
हाँ सर,
श्रीनिवास सर का वेलकम वीडियो है ना?
हाँ वो तो सर प्लेटफॉर्म में कोई फ्रंट एंड से आएगा, यहाँ पे नहीं दिखेगा वो, जैसे कोई फ्रंट एंड से आएगा तब आएगा वो।
ठीक है। Okay, we'll stop the. अवनीश, हेलो।
हाँ सर, हाँ सर,
सारे सारे वीडियोस आ चुके हैं ना?
हाँ जी सर, हाँ जी।
हम लोग जो बात कर रहे हैं ये भी सुनाई दे रहा है क्या लाइव
हाँ
डेलीगेट?
सर, अभी सुनाई देगा, इसलिए ना जैसे ही लोग आ जाएंगे फिर बंद कर देंगे।
ठीक है।
सर आज के सारे वीडियोस आ गए हैं।
आज का तो पूरा सब एवरीबॉडी एंड सारे फैकल्टी को लिंक चला गया ना?
हाँ जी सर, हाँ जी।
ठीक है। एंड हाउ डू द डेलीगेट्स आस्क क्वेश्चंस इन द चैट बॉक्स? हेलो।
हाँ सर, जो क्वेश्चंस तो ना काफी सारे आएंगे, बट जो इम्पोर्टेंट क्वेश्चन होंगे रिलेटेड टू स्पीकर, हम उनको प्रमोट कर देंगे, तो जो स्पीकर होगा ना वो देख पाएगा कि क्या क्वेश्चन आया, तो वो जवाब दे पाएगा वहीं पे।
हमको दिखेगा क्वेश्चंस?
हाँ जी, हाँ जी, हाँ जी।
क्योंकि अगर कोई स्पीकर को नहीं दिख रहा है तो वी विल आस्क द स्पीकर।
हाँ हाँ हाँ।
चैट बॉक्स में डाल देंगे ना अपने।
हाँ, चैट बॉक्स पे वही, जैसे सर जूम में होता है चैट बॉक्स चलता है ना, उसी हिसाब से है।
ठीक है।
Morning, Shyam.
Morning, Srinivas.
I am in the cab going to the hotel.
We are live, Srinivas.
Yeah,
We are live.
we are
We are live, sir. We may start the proceedings.
Okay. Good morning, everybody. And on behalf of the team of Hyderabad Intensive Care Symposium, me and Dr. Srinivas welcome you all to the 8th edition of the HICS. Though we were hoping for a physical gathering, because of some logistic compulsions, we had to not only change the date but also go virtual. Nevertheless, the essence which has made HICS one of the most popular programs in critical care in the plethora of events has been the scientific content and the quality of the speakers. And we are very happy to say that for the first time, apart from our regular speakers who have been there with us for the last many years, we were also able to get in some international faculty from Australia, UK, Nepal, Sri Lanka, and also delegates from across the world. And I hope that, as usual, as it happens with every HICS, this year also we are going to have a very interesting 3 days of learning. And please feel free to post your queries in the chat box. We will the faculty will be available live to answer your questions and queries. With that, I again welcome you all to the 8th edition of Hyderabad Intensive Care Symposium, and wish all of us have a great learning over the next 3 days. Avnish, can we proceed with the...
Sure, sir.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Good morning, all. I welcome you all to the HICS 8th edition. And today we start with the first what COVID years taught us. The first lecture is going to be by Dr. Raymond Savio on biomarkers. He is the lead consultant at Apollo Proton Cancer Center, Chennai. I would like Dr. Raymond to start. Thank you.
A very good morning and a hearty welcome to the 8th edition of Hyderabad Intensive Care Symposium. I am really happy to meet you all online and kickstart this day with a seemingly light topic, but something which has profound implications for the future, the science of biomarkers. So whether you like it or not, the future is going to be all about relating some form or other of a measurable biomarker to every stage of health or disease or therapeutics or whatsoever. It's got to be in a measurable manner. Okay, so well, yes, that seems pretty idealistic. I do understand that there are several hurdles that come in the process of translation of a biomarker all the way from the bench to the bedside. But was that how things happened during the COVID years? Not at all. Okay, things were really peculiar, rather. In fact, nothing went through the so-called usual process or the so-called regulatory pathway. It was like every single biomarker that was being proposed was being literally exploited. Okay, we were going around doing a whole bunch of investigations. Sometimes we didn't even know how to interpret so many of these. Okay, so I guess in a nutshell, the COVID years have rather taught us how best not to do so many things. Okay, so yes, while I was looking up PubMed for literature for these keywords, COVID-19 and biomarkers, I was stunned to see the number of publications for these keywords alone. Okay, so maybe if the keywords are refined or increased further, and again, this is just the PubMed search. Okay, so I'm sure the volume of publication is going to be a lot more. Look at it, something like 7,600 and odd trials just about COVID biomarkers. Okay, and I call them volume of literature, not wealth of literature, because by and large, they are all very low quality data. You know, anything gets published. All of them were just retrospective observations, very non-controlled data, very, very heterogeneous population. I know different biomarkers being done at different time points in the disease, different kinds of assays being used, different kinds of cutoffs being used, so many non-specific behavior. You know, so there is no kind of a meaningful what do you say, recommendation or a guideline that you can derive from any of this. Even today, at the end of it all, with so much of publications available, well, yes, we do have some insight into how these biomarkers perform, but there is nothing dogmatic that has happened out of it. If we can quickly revisit the diagnosis, which is itself at least 20 odd years old, look at that. A biomarker is defined as a characteristic that can be objectively measured and evaluated as an indicator of maybe normal biological process or a pathological process or even a pharmacological response to therapeutic infection. So the key thing over here is that it needs to be measurable, and it can be virtually anything. Okay, it can be part of health, it can be part of disease, it can be part of therapeutics. You know, it can be from the histological background, radiological background, biochemical, physiological. It can be virtually anything. But the fact here is that it has to be measurable. Okay, so the first thing, therefore, we learned at the end of these COVID years, because we had a whole bunch of them, didn't we? A whole bunch of biomarkers from all of these fields. Yeah, so we realized that a biomarker can virtually be anything, but it needs to be something that is measurable. And it is also something that cannot be used in isolation. It needs to be something that needs to be coupled with clinical assessment. Okay, and therefore, with this never-ending, plethora of pathophysiology, because I just told you it can be anything along the cascade of a pathophysiology, and now we know that COVID is not an isolated respiratory system disease. It is a disease. It is a multi-system disease. Okay, so we can have biomarkers corresponding to so many of these. So fundamentally, COVID is now we understand a complex interplay between the coagulation system, the inflammatory system, and the immune system. So we have a whole bunch of these hematological, immune, inflammatory processes. And then because there is ultimately organ dysfunction happening, you can have virtually any of the organ-specific biomarkers, and there's a lot more. Interestingly, see, biomarker can also be something so simple and physiological as an SpO2. As long as it's measurable, it's fine. Okay, a CORADS is a biomarker. Any other specific ultrasound characteristic of COVID lung could be a biomarker. Okay, can agesia be a biomarker? No, because it's not measurable. Okay, so likewise, there is a lot more coming up from the field of metabolomics also, but I'm not sure if the disease is still going to remain the same. So with this plethora of biomarkers, another interesting thing that we realized is that as against the traditional biomarkers which we were used to by that time, say procalcitonin, cardiac troponins, maybe NGAL. See, these are all predominantly, or at least our behavior was primarily to use biomarkers for either diagnosis or for following up treatment. Okay, but here during the pandemic years, we realized that they had several fold other applications. It's not just diagnosis, it's not just following up of therapy. In fact, apart from clinical bedside applications, there were so many others like regional policy making, national policy making, bed prioritization, triaging practices, so many. So we just realized that biomarker can be anything and it can fit its role into virtually any sort of field. And therefore, we have these bunch. How many are there? Maybe 7 categories of biomarker or 7 biomarker types that we came across by during the pandemic year. So either trying to give us some sort of an assessment of risk, like, for example, D-dimer and neutrophil lymphocyte ratio. Again, I will not be able to go into the details of each one of these biomarkers and their implications. That will be beyond the scope of this particular lecture. We have diagnostic ones. The moment you see that, you kind of nearly narrow in on the diagnosis or something that helps you monitor progress of the disease or monitor therapeutics. Likewise, prognostication, typically CRP, and then predictive scores. A high HS-TROP-I or LDH would predict the likelihood of developing a cardiac disease or an ARDS, respectively. Alternatively, pharmacodynamic biomarkers, which help us either initiate or follow up on therapies. So many of these came into force. And what we realized is, naturally, what was happening was whenever the patient would come to an outpatient or an ICU or even the wards, all of these used to be done as a bunch together, almost like a package, half of which we didn't know how to interpret. And the rest of it were invariably adding on to the cost of care. And again, unwarranted therapy. So, something like even an asymptomatic patient who would come, gets an IL-6 measured, IL-6 high, gets a tocilizumab. Okay, a high CRP, but whereas maintaining normal SpO2, not breathless, lands up in the ICU. Okay, so we realized all these wrong practice by the time we were towards the fag end of the pandemic year. So we realized, or we rather learned, that it is imperative to understand the underlying mechanism and then go ahead utilizing the biomarkers. Okay, so an example I would say, when you are ordering a lymphocyte count, it would be nice if you understand why we are ordering it. Okay, lymphocytes have, by and large, the largest number of ACE2 receptors on their surface. So there is greater viral invasion. It lyses the cells. Okay, so there is lymphocytolysis. And this in turn releases so many of the cytokines and interleukins. That is again going to lead on to lymphocyte apoptosis. While all this is happening on one side, on the other side, there is impaired production of lymphocytes. Because, say, the cytokine storm suppresses lymphoid organs or atrophies lymphoid organs. Again, lymphoid organs don't perform too well in the presence of metabolic acidosis or lactic acidosis, So this kind of a knowledge is what we expect with handling of each one of these biomarkers. And this we did realize at the end of the pandemic years. And with so many varieties and types of biomarkers, naturally, we have a whole bunch of clinical applications, a never-ending list again. Helps us with early suspicion of diagnosis, confirmation of diagnosis, classifying disease severity, and accordingly triaging patients, framing hospital policies, ICU admission and discharge criteria, identifying the ones at high risk, rationalizing therapy, like, for example, using D-dimer to find out who would benefit from what kind of pharmacoprophylaxis. Okay, assessing response to therapy, again, probably using D-dimer to assess response to anticoagulation, or using IL-6 levels itself to again see the impact of tocilizumab. Again, none of these are foolproof. Okay, I'm just giving you a few random examples, none of which are based on solid evidence or recommendation. Likewise, even predicting outcomes. So there were a whole bunch of clinical applications, and we started to realize that biomarkers are very powerful tools. However, they do not come without any pitfalls. Like I already told you, everybody who would come to an OP would get all of these tested. Okay, and then based on that, there were so many of unwarranted hospitalizations, unwarranted therapies, also over-reliance of any one particular biomarker. IL-6 alone is high, the rest are seemingly okay. Still, patient gets a tocilizumab, or CRP is high but then doesn't fit with the clinical picture, patient lands up in the ICU. All those things did happen. So adverse effects of unwarranted therapy. Many of those who who landed up getting tocilizumab probably didn't need that, but rather landed up facing the infection complications following that. Okay. And ultimately, there is an escalation of cost. And not just that, not only that we were ordering all these things, the public were themselves walking around with reports of all of these. Okay, so it was such a chaotic environment, and I only pray it just doesn't happen again. So we realize that even though they are powerful tools, this is something that is not to be used in isolation. Okay, a comprehensive approach to patient care involves a sound clinical knowledge, a bedside assessment, and incorporation of measurable biomarkers, and should ultimately amount to some favorable impact in outcomes. So, yes, we did have an enormous body of evidence, but then, like I told you, all of it was retrospective, low quality, very poorly standardized investigation. So the practical downside was probably a lot more than the so-called volume of evidence by way of publications. The most important was that there was considerable lack of standardization. Okay, every single center would use different kinds of assays. Nobody knew what exactly was supposed to be the cutoff. We didn't know at which time point what biomarker was to be done. Okay, so complete lack of standardization, but we would start associating it to available evidence. Okay, similarly, lack of validation, lack of verification, typically what biomarkers go through the process. None of that happened. Over-reliance on any one single biomarker, like that was already spoken about. Confounding factors. There are so many reasons why, say, CRP would be high, why procalcitonin would be high. So there are so many reasons why biomarkers will be non-specifically elevated. And yes, limited availability. Not all centers had all of these. And we already spoke about the non-specific nature. And the most fundamental practical flip side to using COVID biomarkers around that time was lack of understanding of the underlying mechanism. Why were we doing this? With this, what were we supposed to do? How do we follow up? All that was so irrational so many of the times. And thus, I strongly feel that, well, we've spoken a lot about so many of these biomarkers. There are some of these position statements, I would say, not strong recommendations or guidelines, so many of these, but it's really time for us to have all of these COVID biomarkers re-evaluated. And typically, talking about traditional biomarkers like, say, procalcitonin or NGAL, which I always keep talking about, this is the usual pathway for a biomarker development. We are not going to talk in detail about this, but it is very, very clear that none of our COVID biomarkers went through any of these. Where was the verification? Where was the validation? Okay. So, I do understand it takes years for this process. Many of the so-called biomarkers that go through this pathway never see the limelight. All that is agreed. And during a pandemic, anything can happen. All that is also agreed. But then I suppose we need to reevaluate our thinking of the so-called bunch of COVID biomarkers, even if not through this sort of a tedious process. Somewhere, some kind of verification, some form of validation needs to happen. And while all that is in the background, you will be surprised. Just look at the kind of molecular and genetic biomarkers that are in the pipeline from the field of metabolomics. Only thing I'm afraid is the disease profile would have completely changed by the time any of these see the limelight. So in a nutshell, if I've not exceeded time, have we learned anything about biomarkers? Has the pandemic years taught us something about biomarkers? Definitely yes. Our understanding of biomarker science has definitely improved like never before. We came to understand that biomarkers are a fundamental part of the physiological or a pathophysiological process. Only thing is it needs to be measurable. And it is a powerful tool, however, something which should not be used in isolation. Like I told you already, the patient approach needs to be comprehensive. Okay, there should be a clinical background to it. We can only supplement the findings with biomarker science, and then there needs to be data or input from radiology and various other biochemical parameters. So therefore, it makes sense only when there is an understanding of the underlying mechanism, like I told you. And well, yes, of course, remember all biomarkers need to have reasonable standardization and validation. We need to know what assay we are using. We need to know the right time point for doing a biomarker. The typical example is an NGAL. Again, I won't be able to go into details. And we need to have a reasonable validation, not based on retrospective trials. And in a nutshell, using biomarkers requires very sound clinical and scientific approach. So with that, I would like to conclude my talk, and thanks a lot for your kind attention. I'm sure you have an amazing feast of information out there for you. So have a wonderful time at HICS. Thank you.
Thank you, Dr. Raymond, for a wonderful lecture on biomarkers during the COVID times. So another topic we come to is coagulation, which was a very frequently monitored tool during our COVID pandemics. For this, we have Dr. Abhinav Gupta from Royal Free Hospital, London. And over to you, Abhinav, sir. Please start.
Good morning. I'm Abhinav Gupta, one of the consultants working in Royal Free Hospital, London, and greetings from Royal Free Hospital. And thank you very much for inviting me, Dr. Samvedam, and HICS team to talk on COVID. And COVID reminds me of this movie, Avengers, that came in 2019, in which one of the characters, Thanos, whenever he used to snap, half the universe would turn to dust. One of the earliest papers that came on increased coagulopathy in COVID was from Gattinoni, and where he described that only around 20 to 30% of critically ill patients admitted to ICU had features of ARDS. The remaining had ventilation perfusion mismatch due to clots or thrombosis in lungs. And a lot of papers, they came from Wuhan, China. Some of them published in Lancet, where they described that 90% of hospitalized COVID patients had coagulopathy. And it increased significantly when it was associated with an increase in dimer levels. And we've seen that COVID is associated with microthrombi and also increased incidence of PE and stroke and MI. So the entire coagulopathy milieu, I would classify into 3 pathways. And these 3 pathways are: the first pathway, the destruction of vascular endothelial cells, and it activates hypercoagulability and hyperinflammatory immune response. So we all know COVID infection, it affects ACE2. Now ACE2 actually keeps a check on angiotensin 2. So angiotensin 2 creates a procoagulant environment. And ACE2, it keeps a check by degrading angiotensin 2. So COVID-2, when it affects the respiratory alveoli, and they cross through the alveolar endothelial barrier, and they start the destruction of endothelium, vascular endothelium in the lung capillaries, and they also affect the ACE2 inhibitors, as we just discussed, to decrease the angiotensin 2 levels. And then it initiates the immune response. We've seen the hyperimmune response activates the complements, and these complements and these cytokines, they further initiate coagulation. It can also, meanwhile, initiate the third pathway, hypercoagulation. So okay, let's go back to basics for a second. Is there are 2 pathways. One is intrinsic pathway, and the major pathway is the extrinsic pathway, which is initiated by the tissue factor, and all these lead to the generation of thrombin, and the thrombin leads to the generation of a fibrin clot, and thrombin also activates the platelets, leading to what is commonly described as a thrombin burst, right? So what happens in COVID? So COVID, because there's a destruction in vascular endothelium, it exposes the collagen fibers and also activates the tissue factor. So we've seen the tissue factor activates the extrinsic pathway, leads to the generation of thrombins, also activates the platelets and leads to a thrombin burst. And there's a formation of a, a component with along with factor 13 and 1 milligram factor to initiate the intrinsic pathway. And this intrinsic pathway along with the extrinsic pathway leads to generation of thrombin to form a clot. Now bear in mind that the clot formation is also kept in check by the antithrombotic agents, and one of the major antithrombotic agents is plasmin, which degrades the clot and leads to the formation of fibrin degradation products. And one of the most commonly used fibrin degradation product that we measure in the lab is D-dimer. Right. What does COVID do? COVID is it downregulates the thrombomodulin, which leads to a decreased generation of activated protein C, and the intrinsic pathway goes unchecked. Right. It also upregulates the plasminogen activator inhibitor, which inhibits the formation of plasma, and as a result of which there's increased fibrin formation, increased clot formation. But again, the metabolism of plasmin is hampered and leads to increased D-dimer, because simultaneously there's a increased fibrin degradation products as well. So what do we measure? The first lab indicator we see is a higher D-dimer. The remaining may occur as well, may or may not. Right? Is clotting product dysfunction, that is prothrombin time, platelet count, and fibrinogen levels. They may or may not, but they are not strong indicators. But D-dimer is definitely a very strong indicator. Extensive clot formation. One of the examples is in this slide. Is this gentleman had 3 times thrombectomy, and every time came with a significant MCA clot, and this was a clot that was taken out. And the histopathological slides, it showed that there's a prothrombotic state with a platelet fibrin rich clot on histopathology. I was very keen to compare it with sepsis, the pathways, and one of the papers was very clear in that. Is the similarities were, as we all know, as we've seen, is high von Willebrand factor, high CRP and thrombomodulin, elevated D-dimers and fibrinogen, and endogenous activation of fibrinolysis, leading to D-dimer formation. But what are the differences? We've seen in the pathway that it goes through vascular endothelium damage and hyperinflammatory immune response and generation of hypercoagulation pathways. So sepsis rather cause consumption of clotting factors, but the features of consumptive coagulopathy or the elevated PT and DPTT is quite late in COVID, and it is increased resistance to fibrinolysis in COVID patients. There's often an entity known as long COVID syndrome in patients with COVID, and they've seen a sustained prothrombotic change. And even the hypercoagulability state has been documented to be prolonged for as long as 4 to 6 months, and it has been documented because of sustained elevation of plasminogen activator inhibitor and factor 8 levels, and also a sustained epithelial damage. Now the incidence is very low. It could be as low as generally around less than 3%. So it all depends on the condition of patient, and it all depends on the institution protocol and the individual opinion on whether you would like to continue for heparin for a longer time. Basically, it depends on the lab values and the condition. And what do we give? Heparin is a standard recommended agent that has to be given in all these patients, unless contraindicated. One of the earlier studies, it was a very famous study from investigators of REMAP-CAP, Active, and ATAC investigators. Combined, they published a study in NEJM, in which what they suggested was, if the patient is non-critically ill patients, such as a patient in the ward, the strategy should be to give therapeutic dose of anticoagulation, as it to reduce the chances to reduce morbidity and mortality. However, if the patient is admitted in ICU, the therapeutic anticoagulation did not offer any significant advantage as compared to the usual care thromboprophylaxis. So basically, rather the higher dose therapeutic dose anticoagulation led to an increased incidence of bleeding, though not statistically significant as seen in this study, but what they suggested was continue with the usual care thromboprophylaxis. The reason they gave was that the COVID has already developed, it is too late to alter the consequences because the disease process has already been established. And one of the more important reasons is that the therapeutic dose anticoagulation can exacerbate alveolar hemorrhage, leading to significant bleeding, and mainly because of marked pulmonary inflammation. So in FICM and Intensive Care Society in the UK, they came up with an intermediate pathway. Okay, let's give them an intermediate dose, not the full anticoagulation or the standard prophylaxis in ICU patients, unless contraindicated. Let's continue with intermediate dose. But there were subsequent studies, Inspiration trial, Rapid trial, HAP COVID trial, and most of these trials, they suggested continue with the standard prophylactic heparin. Do not aim for therapeutic or intermediate dose. So again, it was interpretation, and every institution has their own protocols on how much heparin to be given. But the general consensus is that the prophylactic dose should be continued at least. So we were still wading through troubled waters and trying to see the light at the end of the tunnel, basically. Now there was another issue that was cropping up, and that was the cases were coming up because of vaccine-induced clots. Now vaccine is safe, and the incidence is very low. The incidence is around 3 to 4 cases per million per year in unselected population. But it's just so that people are aware of, in case you see a patient, is the vaccine-induced immune thrombotic thrombocytopenia. That's a term that is being used. And to define it, it is basically a syndrome with thrombosis, along with mild to severe thrombocytopenia, and most importantly, a positive PF4 heparin ELISA. And in all these patients, the D dimer is markedly elevated. So in all, it should meet all these 5 criteria. A is COVID vaccine should have been given. Features of thrombosis would be there. Decreased platelet counts, and most importantly, positive HITS ELISA screen, PF4, and markedly elevated D dimer. So it can be classified into unlikely cause to a definite cause based on D dimers and HIT ELISA. So whenever ELISA, if ELISA is negative but you have remaining features, continue treat as standard venous thromboembolism. Do not jump to the diagnosis of VIGT at that point of time. But if you're seeing that the patient is presenting with thrombosis, always be careful and continue your assessment. And always maintain a very high degree of suspicion, especially when the patient is presenting with headache and visual changes, shortness of breath. In all these patients, go for the routine lab analysis, CT plus venogram. And how do you treat that patient? Is the recommendations were IVIG over 2 days, a gram per kilogram. Avoid all forms of heparin. and you should be giving something for clots, right? So go for alternatives like agatroban. We use agatroban in our institution, or rivaroxaban or fondaparinux, and continue this therapy for at least 3 months. Warfarin is supposed to be a bit of procoagulant when started initially, and aspirin, they are at the moment not recommended. And avoid platelet transfusion unless the patient is severely bleeding and the platelet count is very low and you're at risk of bleeding. Steroids have been given, but no definite recommendations, but steroids have been used. A great recommendation has been for plasma exchange, and if the facilities are there, go for plasma exchange. Occasional recommendation for rituximab and early intervention whenever you see such a patient. But having said that, the incidence is very low, and it's just to keep an eye on it. And there is more problem of risk of death and serious outcome of COVID-19, including thrombosis, if the rather than thinking about a VITT. So COVID-19 is a bigger risk for blood clot. So vaccines, as I said, has been safe, and they have been recommended. Hundreds of millions of people, they've received vaccine, and the usual road is give vaccination and not go through the COVID road where sometimes the journey stops early. Thank you very much, and hope you enjoy the rest of the conference. Goodbye.
Thank you, Dr. Abhinav, for a wonderful lecture. And in the same series, we would like to invite Dr. Sumesh Arora, who is a senior intensivist at Prince of Wales Hospital, Randwick, Sydney. And he's going to talk about a very important topic which we learned during the COVID, that is immunomodulation. So over to Dr. Sumesh.
Good morning, everyone. My name is Dr. Sumesh Arora. I'm an ICU specialist from Prince of Wales Hospital in Sydney.
Dr. Sumesh, you can start.
I will be talking about what has COVID taught us. Good morning, everyone. My name is Dr. Sumesh Arora. I'm an ICU specialist from Prince of Wales Hospital in Sydney. I will be talking about what has COVID taught us about immunomodulation. I would like to thank my friend Dr. Srinivas Samavedam for giving me the opportunity to do this talk. I declare a potential conflict of interest. I run a little website known as gotheextramile.com, which provides MCQ in critical care medicine. I declare that I do not draw any salary or remuneration from quiz time in critical care and gotheextramile.com. The first question as we talk about COVID-19 is whether it is a human pathogen at all. We know that COVID-19 is caused by a SARS-CoV-2, and it is a coronavirus. And indeed, coronaviruses are well-established human pathogens. Almost all of us, within the first year of life, will get infected by one of these or more of these of coronaviruses. These are known human pathogens. However, in the last 20 years, SARS, MERS, and lately COVID-19, they have jumped species and started to cause human disease. These outbreaks have proven that zoonotic coronaviruses, they are capable of successfully breaking the species barrier and infect the human beings. In order to understand the immunology and immunomodulation of COVID-19, we first have to understand the structure of the virus. COVID is caused by the SARS-CoV-2 virus. It is an enveloped virus. On the surface, it has multiple proteins. The most important of these immunologically is the spike protein, which also helps the virus enter the human cells. And in addition, there are hemagglutinin, envelop M protein and E proteins. These are the structural proteins. And there are multiple non-structural proteins coded by the genetic material of the virus. Is SARS-CoV-2 a new infection in humans? And the answer to that is yes. Prior to COVID-19, SARS-CoV-2 was not known to have caused infections in humans. And yet, the case fatality of COVID-19 is only around 1% in unvaccinated individuals. And this is a testimonial to the effectiveness of the human response immune system, that we are able to effectively fight a previously unknown human infection. That's quite remarkable. Right, so what happens when the SARS-CoV-2 virus enters the human body? You know, SARS-CoV-2 wants one thing and the human body wants the opposite of that. What does the virus want? Virus wants to bind to the human cells, enter them, divide there, and when it has divided, get out of the cell, and during which process it kills the human cells and repeat the same thing. Human body, on the other hand, it wants to get rid of the virus. As soon as the virus enters the human body, its innate immunity starts to work. The virus is eaten by the antigen presenting cells like the dendritic cells or the macrophages. And these antigens, these cells then present the antigen to the CD4 cells or the helper T cells, which proliferate, activate the B cells or the cell-mediated immunity, which destroys the virus and results in mild or no symptoms, and the virus doesn't replicate and doesn't infect any other person. Virus wants to replicate and spread. Human body wants to kill it, don't let it spread. It's a race of arms. Most of the times the human body wins, but sometimes the virus does. In general population, prior to the vaccination, the case fatality rate was approximately 1%. Right. So let's visit how the virus works in the human body from the point of view of the virus first. Okay. So the spike protein on the surface of the virus is quite an important protein there. It helps to bind to the surface of the human cells. Now, many human cells contain angiotensin convertase enzyme 2. Spike protein and the ACE2 work as a lock and key. A couple of cofactors are involved to support this entry. But as soon as the entry, the lock and key join, the virus gets internalized. And once it is internalized, it is in safe haven. It does not get exposed to the antibodies or many other human defense mechanisms that could control the spread of the virus. And inside the human cell, there is nutrition and there is the human ribosomes and other machinery available for the virus to make proteins for itself. Okay. Can we modulate or immunomodulate, as the title of this talk is, can we immunomodulate the entry of the virus in the human cells? Yes, possible. As soon as the structure of the spike protein was available, it was possible to create some monoclonal antibodies that would bind to the spike protein and prevent its entry into the human cells. The names of these monoclonal antibodies, some of these are here, and there are a few others which were commercially available. However, attractive as this strategy may sound, not a great strategy, because number one, when the virus has entered the human body, the person is asymptomatic, and these drugs are expected to work only when someone is just been infected but has not started to develop symptoms. And secondly, the spike protein, it divides, it mutates rapidly. And indeed, many of these drugs which were working for the original strains of SARS-CoV-2 are now ineffective against the Omicron strains. Therefore, attractive as it may sound, immunomodulating the entry of the virus into the human cells hasn't quite lived up on its promise, right? Now let's visit this story from our point of view, the human point of view, the self point of view. But before we go on to look at the innate immune response and adaptive immune response to SARS-CoV-2, we would like to revisit what we would have learned in primary medical school, the microbial associated molecular patterns and pattern recognition receptors. Okay, so what are the microbial associated molecular patterns? Right, now humans and bacteria or viruses, we have evolved together over millions of years, right? Just like a little child knows not to touch a hot object because it will damage the tissues, the cells in the human body, namely neutrophils, macrophages, and many others, they innately know, even in a newborn, that there are certain chemicals, when they enter the human body, they are not good for us and they need to be destroyed. Those cells are neutrophils, macrophages, etc. And they recognize the proteins on the surface of the viruses or bacteria which are highly conserved. For example, lipopolysaccharide of the gram-negative bacteria, or peptidoglycans of the gram-positive bacteria, flagellin of the flagellated bacteria. These proteins are easily recognized by neutrophils, macrophages, and many other cells. And these proteins are in general known as microbial associated molecular patterns, MAMPs, or pathogen associated molecular patterns. Complementary to the MAMPs, the human bodies or neutrophils and macrophages, they have receptors for MAMPs. These receptors are known as pattern recognition receptors. They are available on the surface of neutrophils, monocytes, and dendritic cells. And when MAMPs and PPRs interact, the macrophage or neutrophil know that those belong to a virus or a bacteria, and they activate a process to kill those that possess those chemicals. This is a little video which demonstrates how a macrophage will engulf a bacteria. Okay, some of the most widely known PRRs are like toll-like receptors and nod-like receptors. Okay. So when the in SARS-CoV-2, how does this work? In SARS-CoV-2, we talked about that SARS-CoV-2 is a new pathogen, but SARS-CoV-2 still has some similarity to other coronaviruses, and those similarities result in some parts of SARS-CoV-2 act like the MAMPs, and they are recognized by the PRRs, like toll-like receptors on the surface of some of the human cells, and some other PRRs in the cytoplasm of some of the cells. So, how does the innate immunity work? So MAMPs on the surface of the SARS-CoV-2, they're detected by PRRs. This results in release of interferons. Interferons have broad antiviral effects. Release of interferons prevent viral replication. It should be noted that this is an early response to infection before the symptom starts. If the interferon response is adequate, it will result in mild or asymptomatic disease, as we will see a little bit further in this coming slides. Right. So if the interferon response is timely, meaning early and adequate, it will result in inhibition of viral replication and the disease would be mild or none at all. The other possibility is that somehow the virus evades the interferon response. This results in unchecked replication for a long time, resulting in a delayed or severe interferon response. And when that happens, this results in what is proverbially known as the cytokine storm, which may damage the host or human body in its own right, resulting in severe COVID pneumonitis or ARDS in many cases. So if innate immunity works quick, mild disease. If it doesn't kick in early, severe disease. Okay. Now, if interferons are so important, can we give interferon to prevent severe COVID-19? Well, potentially yes, but this has to be given really early while a person is still asymptomatic. And as a result, when that early phase, the diagnosis of COVID-19 is very difficult. Interferon therapy is very expensive. So pragmatically speaking, early interferon therapy is not a good solution, just like preventing the entry of SARS-CoV-2 into the cells by monoclonal antibodies against spike protein doesn't work. Similarly, interferon therapy, unless it is given really early, doesn't work. If there was a biomarker for COVID-19, something like a troponin for the heart, maybe in high-risk groups like kidney transplant recipients, early interferon therapy may be of benefit. Right. The part 2 of the story from the point of view of the human body is the development of the adaptive immunity, which is a cell-mediated immunity and antibody-mediated immunity. Right. Now, before we go on to discuss those, let's do a little bit of a revision of how this immunity works. This picture has been taken from Guyton's textbook of medical physiology. In the human body, there are cells which specialize in presentation of the antigens to the helper T cells. Now, we've talked about neutrophils and macrophages taking up the viruses and breaking them to their structural components. Then these cells, plus some other cells known as the dendritic cells, which are quantitatively the most important antigen-presenting cells, they bring those proteins on their surface and present them on a platter to the helper T cells. These helper T cells after that will initiate an immune response which effects by multiplication of killer T cells and multiplication of B cells to form virus-specific antibodies and virus-specific killer lymphocytes or CD8 lymphocytes. Okay, so antigen-presenting cells like dendritic cells, they present the antigen to CD4 cells or T helper cells 1. This results in release of some chemicals which are generically called cytokines, which activate CD8 cells, which usually would work by killing the infected cells which have the virus component on the inside. T helper 2 cells, on the other hand, stimulate B cells, which release in the antibodies, which neutralize the soluble virus or which is there free in the plasma and the interstitial fluid. Okay. Now, this is a generic representation. How does it work for SARS-CoV-2? SARS-CoV-2 enters the human body. SARS-CoV-2 is taken up by macrophages. It then destroys those virus and break it down to its structural proteins, present them on its surface, activates the CD4 cells. CD4 cells in turn activates CD8 cells, which are the mediators of cell-mediated immunity. CD8 cells, specific for the virus, they proliferate, and then they recognize the cells infected with the virus through recognizing the proteins on the surface of these infected cells. Now, these proteins may be similar to what are colloquially known as heat shock proteins and similar danger-associated molecular patterns, and they result in apoptosis or necrosis of the infected cells. The other role of the helper T cells is to stimulate the clonal expansion of the B cells, which form plasma cells, which form antibodies, and these antibodies neutralize the virus. Most of these antibodies act against the spike protein. Okay. A little bit detail of what CD8 cells do. They act against multiple proteins on the surface of the virus, on the cells infected with the virus, and the neutralizing antibody is generally against spike protein. Antibodies are also formed against some other proteins of the virus, but usually those are not neutralizing antibodies. So far we've discussed the virus enters the body. If it enters the cell through ACE receptor, it divides, destroys the cell, spread. If it's taken by the macrophage, macrophage breaks it down, it presents these virus components on its surface, stimulates CD4 cells, which stimulates CD8 cells and the plasma cells, or the B cells, sorry. Now, by all means, SARS-CoV-2 is a new human pathogen. We've talked about it. It never caused human disease during its evolution. How come human body possess the genetic information to develop antibodies against spike protein? I have to confess that while I was preparing for this talk, this question was on my mind, and I was desperate to find an answer to this question, and I'm glad Dr. Samavedam gave me the opportunity to do this talk, because I would have never found. And I think in this answer lies the true genius of the human immune system. Now, in humans, there are only a few thousand genes for antibodies. But when the antibody heavy and light chains are produced, the genes are spliced in a variable manner and multiple combinations are possible. And as a result, a few thousand genes can form millions of combinations which code for antibodies against millions of antigens. And these antigens include the SARS-CoV-2 spike protein, and it may work against it because it shares some similarity with the other coronaviruses. In future, let us say there is a pandemic from a virus which is unrelated to any virus that have ever infected humans, we may not be so lucky. Right. What failures of the immune response result in severe disease? So if there is inadequate and delayed interferon response or heightened viral replication, this will result in exaggerated delayed response, which will result in excess activation of the immune system. And when there is a lot of virus and the activation of the immune system happens late, a large amount of cytokines are produced, which results in what is proverbially known as cytokine storm. Very hard to diagnose. Anybody who's very sick will share a number of features with cytokine storm. And level of many cytokines and interleukins would be high, but doesn't help in making a diagnosis. So we use surrogates like lymphopenia, raised D dimer, CRP, and ferritin. Now, can we make a statement that there is severe COVID, this results in cytokine storm, or there is cytokine storm, so there is severe COVID? What comes first? I suppose in some cases this is true, and in others this is true. No one answer fits all. Sometimes the chicken comes first and other times the egg. Right. In view of the time considerations, I think a detailed discussion of the cytokine storm is outside the scope of this talk. But an article published in NEJM in 2020 on cytokine storm give a very good philosophical overview, and I would recommend it to all listeners. And indeed, during COVID pandemic, we saw that glucocorticoids have become an important component to partially inhibit the cytokine storm, because cytokine storm in itself results in human damage, and use of certain other drugs like tocilizumab, which is a soluble interleukin-6 receptor antibody, or a genus kinase inhibitors like baricitinib. While these may reduce damage to the host from inflammation, they also reduce the protective immune response, and opportunistic infections do occur. And we all saw infections from many fungi or multi-resistant organisms which develop in the patients who received combination of glucocorticoids and tocilizumab or baricitinib. The case for steroids is strengthened by some recent trials, including the recently released Cape Cod trial in HICS2023. And in future, we may see more combinations of steroids and other such drugs to use in severe pneumonia, not only related to COVID. In future, I anticipate mutations of the virus will result in more waves of COVID. And the host response, however, will be different now because more people are vaccinated and a significant proportion have had COVID. We may get markers of early diagnosis, and we may get markers for cytokine storm as well. Thank you very much for listening to this talk. Bye-bye.
Thank you, Dr. Sumesh, for a wonderful lecture. So after this, we come to a question and answer session where a few of our delegates have asked some questions. One of the delegates has asked question to Dr. Raymond, and he wants to know what are the biomarkers which he uses in general for his sick patients.
Sorry, could you please repeat that? What are the biomarkers that are used?
In general for your sick patients, which are the biomarkers which you use more commonly for your sick patients, apart from
COVID?
Routine.
Okay. See, so that's exactly what I was talking about. There is no such thing as general biomarkers for general sick patients. Okay, it is what question you want to answer using a biomarker. Okay, so if I am having a patient who has features of say sepsis, okay, but I don't have a marker towards an infectious source, or we are still searching. And if you want to make sure, or if you want to confirm if it's a bacterial infection that's lingering, maybe procalcitonin would help. Likewise, if you want to answer a question that let's say in culture negative sepsis, you have started off with a procal high, right? And you want to know if you are on track, you want to know if you are safe with the antibiotics, you want to know if it's good time to stop antibiotics, I would do a procalcitonin to answer that question. Okay, an 80% reduction in procalcitonin from baseline, yes, I'm doing good, I can stop antibiotics. Okay, so likewise, we need specific questions, and accordingly you choose the biomarker. Likewise, let's say CRP again, in malignancies, right, is a marker of increased inflammatory activity. So you want to know the disease severity, fine, CRP. Likewise, NGAL isn't so commonly used, but then when you want to make sure, see, even before creatinine rises, creatinine is probably the last to rise in AKI. if you want to know already if there is an evidence of tubular damage, that is when you would like to use an NGAL, right? So it needs to be very specific. There is no such thing as general biomarkers for sick patients. It depends on what question you want to address. The frequently used ones in any ICU is, of course, pertaining to infection. I told you procalcitonin. Some people use NGAL, some people don't. Likewise, even radiological scores, I told you, for example, even CORADs can be considered as a biomarker. Biomarker is not just a biochemical test. It can be a radiological indicator as well.
Thank you, Dr. Raymond. The next question is for Dr. Sumesh. So the question is, do you think that these studies in immunomodulation can be used for therapeutic strategies in future? Dr. Sumesh.
Hello. Thank you for, can you hear me?
Yeah, we are able to hear you.
I can hear you. Perfect, thank you. I can turn my video on if you like, but it seems like it has been disabled by the host. Okay, so the question is that if we would be, may I ask if you could please repeat the question?
Yeah, the question is, do you think that these strategies, these immunomodulator studies, they can be used as a therapeutic strategies in future? Can you use it as a therapeutic strategies in future? How do you derive your therapeutic strategies based on our immunomodulation understanding?
Look, I have a feeling that we almost certainly will have therapeutic strategies based on what we know how the immune system works in COVID. If you were to look at the way the virus, the vaccine for COVID-19 has been developed, the Pfizer vaccine, for example, it is a state-of-the-art, work. And of no doubt that a large number of immunologists were involved in no doubt a large number of immunologists were involved in its development. Like it is now possible to have the RNA of the virus modified, injected in the humans for it to activate, to be taken up by the human cells, and then for those cells to use the viral mRNA to form proteins, and then for that protein to stimulate an immune response, which results in the viral vaccine, which results in the antibodies against the spike protein. I mean, it's a remarkable feat. Similarly, the step of entry of the virus into the human, most vaccines that we've had so far, they are systemic vaccines, meaning they have to be injected, whereas the virus enters the human body through mucous membrane route. So just like polio vaccine, I suppose in future there would be some vaccines which provide either a live attenuated virus or such thing directly at the mucous membranes, so inhaled route, resulting in development of mucosal antibodies against the virus. I suppose the first step that the virus enters the human body is, the spike protein finding the ACE2 receptor and somehow reducing the entry of the virus into the human cells. That's something which is desirable and requires probably also what Raymond was just talking about, having biomarkers for early infection, so that before the virus have had a chance to replicate extensively, if there are biomarkers which can tell us that, okay, infection is about to develop, and then in high-risk subjects, for example, renal transplant recipients, the entry of the virus into the human cells may be reduced. Most of the medications which FDA approved these days, 3/4 appear to be monoclonal antibodies of, one sort of the other. And I suppose the future of antiviral therapy perhaps lie largely in immunotherapy rather than chemotherapy, so to speak.
Sumesh, Good morning, Dr. Ghanshyam here.
Good morning.
Morning. Immunomodulation has always been very, very attractive, and we do know that immunology plays a major role in intensive care. But many of the therapeutic strategies where immunomodulation was attempted, always has given us disappointing results. Whether it's sepsis, ARDS. Why do you think so?
Well, I suppose, as a therapy, immunology is in its relative infancy, right? Until I suppose 70 years ago, we did not even know that what is DNA made of, right? So, and it is only now that we are able to, see how the DNA, how the antibodies really are produced, and with the development of new technologies, for example, CRISPR in 2010, for which Jane Doudna and Carpentier won the Nobel Prize 5 years ago, it is now possible to remove any little slice of DNA from one organism and put another slice of DNA and produce the desired proteins. I think we have more tools at hand now than we have had ever before, and indeed, more therapies are undoubtedly on the horizon. Having said that, this is an intensivist talking about likely progress in immunity. Maybe it's more hope than knowledge of that this is going to happen.
Thank you, Suresh. Sumesh. Mithilesh, over to you.
So thank you, Dr. Sumesh. So now we come across the first plenary session of HICS, and the topic is phenotype of critical illness. And the speaker is Dr. Ram Rajgopalan, who is the professor and head of the Clinical Services, Department of Critical Care Medicine in SRMC, Chennai. Over to you, sir.
I begin with a couple of apologies to Srinivas and his colleagues. Number one, I'm not wearing the uniform that is required of a legitimate lecturer. And two, I'm using a template that is not what has been standardized. I have to apologize for the fact that the quality of my graphics doesn't come out any better if I use anything else. Okay, the purpose of my talk is going to be to introduce you to the idea of phenotypes in critical care. And as I said, it is a very technical concept. And as a consequence, I am going to take a layman's approach. Not that I understand any of this concept very well, but I'm trying to simplify it as far as is possible so that we don't get turned off. For me, the very process of trying to discuss this issue was threatened by my ignorance of the concern about what is called artificial intelligence. And as I would always say, I traditionally would retreat to my basic comfort of natural stupidity. But actually, I tried very hard and did try to read the literature. And what I will do right now is to provide you a very clear and simplified kind of understanding of the ideas of phenotypes in critical care. The two conditions that we deal with, sepsis and ARDS, have been classically associated with some degree of a decline in mortality. But as you see in sepsis, at least over the last several decades or so, the reduction in mortality has only been partial, probably related to the changes in methodology that we have incorporated in the intensive care unit. But there is still a very large residue of mortality that is dismissed off as host factors, and we don't try to look at them seriously enough. Likewise, when you look at the survival in ARDS, over a long period of time, there has been a stability after the initial reductions that we've seen in mortality. But this has been primarily because we have reduced the iatrogenic complications related to ventilator-induced lung injury, but we have not found effective therapies at this point in time. I think we need to understand these two very clearly, because a lot of what we're dealing with in terms of phenotypes is probably to provide you with some answers for these two issues. The traditional definition of disease has always taken the Ostlerian kind of format, in which diseases are defined on the basis of the principal organ system in which the symptoms and signs manifest. And this allows some kind of homogenization of the entire process and develops a so-called syndromic approach to the disease, which minimizes the number of subsets and the choices that we need to make as physicians. But unfortunately, this has a tendency to overdiagnose the similarity of the individuals, and as a consequence, does not allow for individualized therapy in most circumstances. We extend this Ostlerian ideal even further to diseases that are not limited to specific organ structures, such as sepsis. And by doing that, actually, we are creating a certain degree of oversimplification. This idea of the fact that we are dealing with very heterogeneous conditions with a homogeneous kind of a description of these underlying conditions has been sort of illustrated by the clinical trials that we've seen in sepsis and ARDS in the last several decades. For instance, if you look at the early goal-directed therapy, which was such a successful treatment in 2001, was subsequently beaten down in multiple other trials, primarily because of the very strong differences in the patient groups that we were dealing with. Likewise, you see a similar kind of a hero drug of 2001, Dotricogen alpha, has been relegated to the trash can by within a matter of even 5 years. It probably is a good reflection of the heterogeneity of the groups in which these drugs have been tested. The ARDS is not very different. For instance, if you look at the benefits of PEEP, we find that while the oxygenation dramatically improves with the application of higher amounts of PEEP, the survival doesn't seem to be affected. And this is probably, again, a reflection of the fact that ARDS is a very heterogeneous disease, with many of these populations being tested, having both recruitable and non-recruitable lung. And as a consequence, the benefits in one group may overcome the harms in the other group, and the net effect is not very visibly seen. So it becomes a very clear concern that the heterogeneity of patients and affects their response to therapy, and the wider inefficacy of many treatments, despite a strong physiological rationale, is probably because of this heterogeneity. And likewise, the therapeutic success that we see in one sample population is usually not replicable in another. We recognize this heterogeneity very well, even as early as 2006, when we started dealing with sepsis and the PIRO concept of identifying specific risk factors for predisposition, infection, response, and organ dysfunction was something that was clearly illustrated, and the feeling that we should subdivide our patients along these lines so that we can get better outcomes in these patients when we apply it to homogeneous kind of situations. But unfortunately, this was not taken any further. But we have lived with this idea. We understood that when you're dealing with heterogeneous disease, that we need to find some way in which we can subdivide the patients into what we may call subgroups. And this is best illustrated in the ARDS subgroups of mild, moderate, and severe ARDS being classified on the basis of the PF ratios. While clearly there is a difference in mortality between these subgroups, it appears that the treatments that we can give can also be responsive in certain subgroups and not in others. But I think we need to understand that subgroups are effectively artifactual. The word subgroup is something that we can use for a generic division of patients, not on the basis of specific changes in biology or function, but just broad characteristics. And the classic PF ratio that we use in ARDS is a classic identification of a subgroup. While it may be an independent predictor of survival, the problem is it is a very poor discriminant. You have to remember that PF ratios are affected not by one condition in the lung, but a whole variety of conditions, starting from the lung disease to vascular disease to changes in VQ matching, and even to the therapy that we will provide, the ventilatory mode and the kind of positive and expiratory pressure that we will be applying. So these are poorly discriminant kind of ways in which you're subdividing these groups. Again, it is also something that there's a significant crossover. So if we define our PF ratios and say something below 200 is going to be severe. Okay, what happens to the differentiation between somebody with 199 and another with a 201? It doesn't give you the kind of distinction between the subgroups that we are dealing with. What is even more important is there is no time-based stability of these subgroups. It is very likely that the oxygenation can worsen over a period of time in a given patient. And it doesn't necessarily imply that this is a very specific group that will respond or not respond to therapy. It is just an implication of the time at which you picked up the patients. Likewise, a migration between subgroups can be extremely common by the therapy that you apply. PEEP can make a change in the subgroup of the patient in terms of the PF ratios. So very clearly, what we have recognized is our ability to differentiate patients with heterogeneous conditions into subclasses has been very naive. What do we do right now? We have switched to an idea or a concept of what we would call as phenotypes. In biology, I think we need to be very clear. Phenotypes over here is basically an expression of your underlying genotype after it has interacted with certain epigenetic processes and the environment. And this is not what we're talking about when we're talking about phenotypes in medicine. In medicine, when we say a phenotype, or if you were to be a purist, a subphenotype, is a single or a combination of disease attributes, what we call as the phenotypic traits, that describe the differences between groups of individuals in terms of their meaningful outcomes. That is, a phenotype will distinguish between whether you live or you die, whether you respond to a therapy or you don't. And this could include a wide range of conditions that is seen in the box on the left. It can be clinical, it can be symptomatological, it can be related to pathological or even biochemical kind of parameters. I think we need to understand that this is what we mean by phenotypes. So the question that you might ask is, how is this any different from a subgroup? The subgroup, as we say, is an arbitrary description of different types of patients, but not necessarily based on their clinical prognosis or in terms of how they respond to a therapy. The phenotype, on the other hand, is something that attempts to do this a little bit more clearly. So to very clearly show you what we saw in the PF ratio example, where there was no discrimination, a phenotype attempts to be highly discriminant, not only of the differences in mortality, but also of the differences in the way an individual responds to specific therapies. And these distinctions are very clear-cut. There is no crossover and there is no overlap in these distinctions. There is a very significant amount of temporal stability that these phenotypes are characteristic of a patient, irrespective of the time at which you pick up the patient. And there is very minimal migration between one phenotype to another or one subgroup to another under these conditions, despite the treatment that is provided. Ideally, the data for such should be obtained prospectively from large randomized controlled trials. Let's just look at the process that is used to derive phenotypes. Okay, before I go on to this, I think this is also equally important when we talk about the discrimination of the phenotypes. It has to have the ability to discriminate between an individual or a group that has a low risk of dying versus a group that has a high risk of dying, what we would call as a prognostic discrimination, and the inclusion of the patient in one or the other group is what we call a prognostic enrichment of the data. And in contrast to that, you can also demonstrate with a phenotype which has a very similar absolute risk of mortality, but the differences in their response to therapy, where there is one which will have a significant reduction in their risk with a specific therapy versus another in which the reduction in risk will be very significantly lower. This is what we call a predictive enrichment. The existence of both prognostic and predictive enrichment is characteristic of phenotypes. Okay, let's go on to how we go through this process. And this I will take as just one example. So obviously, when you want to derive a specific phenotype, we need to pick the relevant variables. Very typically, we would like to pick clinical and laboratory measurements that are routinely available to most of us. Okay, and preferably something that can be extrapolated to general practice once it has been identified as being useful. The traditional statistical methods can be used, especially to make sure that highly correlated variables are excluded. And then ultimately, you may use artificial intelligence kind of methods in one of two ways. They can be used to identify what are called atypical variables. Typically, most of us would, presume the association of, say, ARDS outcome with, say, age, severity of infection, the underlying hemodynamic changes. But there may be variables that we do not know, and this can be identified by artificial intelligence methods through what is called unsupervised deep learning. Or the other aspect that we can use artificial intelligence under these conditions is to extract from the databases, particularly from the medical records, non-coded portions, what we call as data mining. This combination of the use of AI methods will probably enhance the quality of the selection of variables that we need to include in the study. The second aspect is something that we probably should understand. Very typically, when we try to look at an association of a variable with an outcome, we try to do what we call multivariate analysis, in which we identify what are called very independent predictors of outcome. These are usually a single parameter that will be the best correlate of outcome. The intent of phenotyping is not to identify this kind of a best variable alone, but to try and identify a large set of variables that may be associated very commonly with an underlying class of patients or a phenotype. So the primary principle that you use over here is not to use the multivariate methods for an independent predictor, but basically to identify indicators that will cluster together to identify a group of patients with a classic characteristic, or what you call a phenotype, to identify the individuals who share common characteristics, allowing them to be, what you call as distinct clusters or classes. And the process that we're using over here is what we call as a cluster analysis, which is something that you will see constantly in studies related to phenotype assessments. The process will be usually like this. You define the problem that you're looking at ARDS, and you're looking at subphenotypes in ARDS that are going to be associated with poor outcome. You select the variables, okay? As I said, this can be either clinical choice, or you could use an AI method of data mining or machine learning to get these variables selected. Then the secondary process is to decide on a very classical clustering analysis method. One of the very popular studies in sepsis has used what is called an optics method, which is an artificial intelligence kind of a method. But it doesn't matter. It can be done in either by artificial intelligence methods, or it can be done by routine latent class analysis, which is a statistical method that is available. Once you decide on that, you identify the number of phenotypes, but you need to see how many phenotypes you can divide it, the patient. And you should be very careful about this, and this is usually done by a process of goodness of fit that is necessary. Once the phenotypes have been identified, they go through a process of sensitivity testing, and ultimately confirming the performance in other data sets. And this is going to be rather subjective. The number of phenotypes and the selection of the indicators can be reasonably subjective. And it is quite important that many of these have to be retested under conditions that are, independently evaluated. Okay, and more important is, while a phenotype is actually a subgroup of patients, it may be very similar to the Apache subgroups or the SOFA-based subgroups that you may have. And you need to demonstrate very clearly that these phenotypes are not just a restatement of the traditional clinical subgroups, but they are probably something that have a higher value in terms of the prediction of both prognosis and in terms of patient responses to therapy. And this is quite important. Let's just go to issues related to sepsis. Typically, we'd like to say that sepsis is associated with your response in an infection, rather, is going to be the extent of sepsis that you're going to develop. And that is going to be very dependent on your underlying genomic structure. But unfortunately, as much as genomic identification of different groups of sepsis responders are available, it is very clear that other influences, like the epigenetic influences and the sequence variation of the genomic structure, are quite important. And ultimately, you cannot just use genomic variations to determine the outcomes alone, or at least not at this stage. So we'd rather use the expression of this genomic structure in classic physical attributes that we'd like to talk about, or what we call as the phenotypes. And in this sense, this particular paper is a earth-shaking, probably a very relevant kind of a paper. This study done by Seymour and his colleagues was basically an attempt at phenotyping patients with sepsis. What they did was a retrospective analysis of a large database, not only which was a clinical database from the UPMC, but also the data that was derived from multiple randomized controlled trials. Okay, they go through the process of selecting variables, and here they were very clear that they didn't want to pick any unusual variables. They very classically picked very routine clinical variables, and they used a method of clustering that was decided by an artificial intelligence algorithm. Then ultimately, they derived the phenotypes, okay, by a specific methodology and verified if their methodology was appropriate or not by an alternate analysis. They identified 4 phenotypes of patients with sepsis, and then they used statistical simulation to see how these phenotypes identify the benefits, I mean, not only the survival, but also the potential effects on therapy that patients may have. Let me just show you this a little clearly. So what did they see from the data that they derived? They were able to identify 4 phenotypes, what they call alpha, beta, gamma, and delta over here. Okay, and they were very classically very different between each other. This graph is attempting to show you what I show you on this little table over here. The alpha phenotype usually had very few lab abnormalities and very little in terms of organ dysfunction, and distinctly different from the delta phenotype, which is classically associated with greater severity and elevated lactate levels, a low blood pressure, which is very characteristic of the delta phenotypes. The phenotypes in between, the beta was dominantly with chronic disease, and the gamma was typically one which is associated with severe inflammation. And what they saw in this basically was the fact that these 4 phenotypes were very good predictors of mortality. This is what we would call as prognostic enrichment. By dividing a septic patient into one of these 4 phenotypes, we were able to demonstrate that the short-term mortality, both in hospital and 60-day mortality, was significantly different between these groups. But the first thing that you would always say is, oh, maybe there are differences, but is it because these different groups have different, severity of illness markers underneath? And can this difference be identified by, say, very routinely looking at your Apache scores or your SOPA score? This again, this study looked at, and what they saw was the distribution of Apache scores was very similar across all phenotypes. So it doesn't look like the phenotypes distinguish the mortality differences on the basis of the severity of the underlying illness. And as a consequence, it is very clearly something that is superior to the standard methods of judging the severity of illness. The second thing that you see, and absolutely convincing, is the fact that each one of these phenotypes had a very classical characteristic which was verified in multiple databases in terms of the inflammatory cytokine production. So it looks like each of these phenotypes is probably some reflection of the underlying genomic differences that you see in these patients. And it is very clearly an indication that these phenotypes mean something from a biological perspective as well. This is probably the most interesting. In this particular process, they used a simulation. They used what is called a Monte Carlo simulation of changing the concentration of phenotypes in a specific study that was negative. The EGDT studies that showed absolutely no difference, because the process study basically, it showed no difference in the process of EGDT. they made a simulation in which they changed the frequency of the different phenotypes. And they saw that if they increase the alpha phenotypes, okay, the tendency to benefit was probably to some extent seen. On the other hand, if they increase the delta phenotype, you are exaggerating the tendency towards a negative outcome. Or in other words, they were proving very, very clearly that the outcome in given studies is very dependent on the underlying phenotypes of patients that you're going to be seeing. In a mix of patients where there is quite a variety of phenotypes, it may be likely that you may not see any kind of a genuine benefit. But if you can change the phenotypes to characteristics that will be benefited by the early goal-directed therapy, like we see with patients who have a dominantly alpha phenotype, okay, under those conditions, it does translate into benefit. These kinds of simulations sort of bring to the forefront a very clear understanding that the phenotypes have the ability to make a judgment about the prognostic variations between these groups on the basis of their frequency. Similar kind of process has been done in patients with ARDS. This is not the same kind of parameters, but a very similar kind of a process differentiates two kinds of patients with ARDS, what is called as a P1 or a hypoinflammatory kind of a group, and a hyperinflammatory or a P2 group, which was derived from a retrospective analysis of two randomized controlled trials. And what is very interesting is the differences between these P1 and P2 groups clearly is associated with a difference in mortality. The P1 or the hypoinflammatory groups in multiple studies seems to show you a lower mortality in contrast to the hyperinflammatory kind of groups. And this prognostic enrichment is a very useful indicator that this is a good phenotype for phenotypic discrimination that we can be using. Additionally, you can also see the predictive enrichment or the effect of therapy in these clinical trials. For instance, the benefit of PEEP, which was broadly absent in the study, is very clearly identified once you divide the patients into different phenotypes. So, for instance, in patients with the P2 or the hyperinflammatory phenotype, the administration of a high PEEP was associated with a lowering of the 90-day mortality. And in contrast to that, in patients with the hypoinflammatory kind of a phenotype, the administration of PEEP was associated with a higher mortality. So very clearly, it makes a distinction between the individuals who will respond to PEEP and individuals who will not respond to it. Likewise, you can see a similar kind of effect with these P1 and P2, for instance, in the fluid response. This is derived from the FACT trial, which didn't show any benefit of restricted fluids. But again, here you can see a clear-cut distinction in the hyper and the hypoinflammatory in terms of the directional change of their mortality. And interestingly, simvastatin, the ACE inhibitor that is claimed to have some benefits in ARDS, has also been tried. And likewise, you can see a very clear difference in the patients with the hyperinflammatory, okay, where the simvastatin is associated with a reduction in mortality. But what is very interesting is when this was extended to another statin study, the SAIL study, it was unable to show you that difference, suggesting again that these phenotypic differentiations are not always perfect and that there may be some intrinsic contradictions because of these studies. And ultimately, I think we need to show the stability of the phenotypes over time. And this again has been demonstrated by a specific kind of analysis called the latent transition analysis, where they demonstrated in two different trials that the phenotype that were present on day one, 93% of patients with a phenotype 1 on day 0 were also in the same phenotype at day 3. Very similar kind of outcomes with the phenotype 2. And in the two studies that you see, the majority of patients remain in the phenotype that they were initially assigned. Again, suggesting that these phenotypes are a good way to subclassify these patients. Besides these complex methods that use a lot of parameters, people have used what may be routine respiratory parameters or gas exchange parameters. And here was a physiological phenotyping that did not include any biomarkers or any other clinical parameters other than the respiratory mechanics or a gas exchange and variables that we were seeing. And here again, you are able to identify two different phenotypes. A phenotype 1, which demonstrates non-recruitability, and contrast to another group that demonstrates recruitability. And there is a clear-cut differentiation in terms of their mortality between these two groups that you see. Likewise, if you look at the therapeutic responses, it also appears that these two subgroups, the phenotype 2, seems to respond in a very distinctly different way to the application of, PEEP or recruitment processes in terms of the change in the lung volume and change in terms of the reduction in dead space and change in terms of the improvement of the PF ratios, suggesting that there's a very clear differential response to these phenotypes, and the application of therapy that can be based on the phenotype is absolutely essential for determining outcomes. Etiological phenotyping is another recommendation on the basis of the fact that we know that the physiology of extrapulmonary ARDS and pulmonary ARDS are distinctly different, and probably by using biomarkers that are distinctly different in these two subgroups, we may be able to phenotype them. But at present, there is no evidence to suggest that that is the best kind of an approach. Along those lines of etiological phenotyping, another absolutely stunning kind of evidence that we have had is the kind of association of COVID pneumonia with both steroid and immunosuppression, which you have not seen in virtually any other version of ARDS or pneumonia. And this again seems to imply that there is a very strong predictive enrichment on the basis of the clinical, on the basis of the etiology alone. So when you really look at all of these features, if you really look at the phenotypes that we have derived right now, are they highly discriminant? They appear to be. Are there very clear distinctions between groups? They appear to be. And this seems to be something that we have determined in many studies. But unfortunately, the data related to the temporal or the time-related stability and the therapy-related stability is sort of lacking. And unfortunately, the worst part of it has been that most of this data has been derived from retrospective studies and has never been prospectively validated or tested in randomized controlled trials. So very clearly, before we jump on to saying we're going to be using phenotyping for the differentiation of subgroups of patients in ARDS or in sepsis, I think we need to understand the limitation very clearly. We are not very clear about the biological mechanisms that are elicited by some of these phenotyping groups, particularly if you're going to be using an artificial intelligence kind of an algorithm. The entire process may be extremely opaque to most of us. And secondly, when you look at the process of identification of the subgroup, we don't have a rapid method, say, for instance, the use of a biomarker to differentiate the subgroups or the phenotypes of patients. And as a consequence, it can be quite complex. And remember, most of these trials have been done in a retrospective kind of a fashion. The biggest discomfort for you and me as a common man under these conditions would be the fact that even knowledge of the factors that have been included doesn't allow us to identify the clinical phenotype unless we possess access to the algorithms that have been used in these clinical trials. And unfortunately, these algorithms are not routinely available to the common user. And until such a process occurs, it is going to be very difficult for us to justify the use of phenotypes, or even for the matter, derived phenotypes in the majority of our patients. The other problem has been the fact that most of these phenotypes are derived with very complex kind of methodology, multiple parameters and multiple biomarkers being included in them. And can we make it simple would be the biggest concern. This has been implied by at least one clinical evaluation, particularly of the ARDS parameters, which has shown that just the use of 3 or a 4-factor model, which include interleukin, protein C, bicarbonate, and whether you need to use a vasopressor or not, can identify the patients in one risk group or the other with a same degree of certainty as the broader algorithm does. But even this is a little problematic because the routine availability of biomarkers in a rapid assay is something that is going to be quite a limiting factor for most of us when we're going to be using the phenotypes. So ultimately, when you look at it, we talked so big about these phenotypes. The question that we would ask is something that any parent who's been driving their child on a long distance can empathize with. And the question that they will ask is, are we there yet? As soon as you get into the car, they will always ask, are you there yet? And very, very clearly, we are nowhere near that. I think we need to spend a lot more time in trying to improve our understanding of phenotypes. Until we do that, I think we still will be using conventional methods. Thank you very much for listening.
Thank you, Ram Rajgopalan sir, for a wonderful lecture. And now we come to the next session. The next session is Know the Newbies. So in this, the first session is going to be on cardiac power output, which has emerged as a new monitor in the patients with severe cardiogenic shock or advanced heart failure. And it is useful to predict mortality across the broad spectrum of the patient. I invite Dr. Manish Bharti, Senior Consultant Intensivist at Sharda School of Medical Sciences and Research Center at Noida, to put more light on this topic. Welcome, Dr. Manish.
Good morning, namaste. I'm Dr. Manish. I welcome you all in the HICS8 Symposium. At the outset, I would like to express my thanks and gratitude to my dear friend, Dr. Srinivasan Samvedam and Dr. Ghanshyam for giving me this opportunity to be here with you and sharing my insights related to this topic, which is cardiac power output. In the next 15 minutes, I'm going to share this topic, which otherwise has been rarely spoken into any intensive care meeting. However, if you see, this topic has a huge relevance when it comes to the contemporary cardiac intensive care practices. So, my dear friend, here we go. So, cardiac power output, this is not a new tool. Actually, the first description of this tool has been given as early as in 1990 by Ten et al., where he has studied almost 28 patients and their response to dovitamin therapy. The reason I'm sharing with you that although this tool is not so new, however, his role has been now well elucidated in the contemporary cardiac intensive care practices. Through this tool, we are trying an honest attempt to make the hemodynamic better. Not only we are going to make it better, we are also through these mechanisms, we are going to translate into the patient outcome as well. The first and foremost, the question which we should ask is why we need this kind of a new tool. The second question which we are going to answer is what is CPO, cardiac power output? The third thing which we are going to learn in this presentation is that CPO, although is very important in the present contemporary cardiac intensive care, but this has to be seen in addition to the existing metrics which are available through the invasive hemodynamic parameters, through the invasive hemodynamic monitoring. Obviously, we are going to study the supporting evidence and the clinical relevance of this tool and many other associated tools in the contemporary management of cardiogenic shock, especially in the setting where the patient is requiring MCS and without MCS as well. Now, why we need this, or why we needed actually this kind of an assessment tool. And now, if you can see in the slide, almost in a typical cardiac intensive care unit, which has been taken up from the circulation, if you can see that almost 66% of the cases in cardiac ICU, they are typically of cardiogenic shock, which means 2/3 of the patients will have cardiogenic shock in a CCU. And out of this 66%, almost 50% of the cases, they will be having ischemia in origin. Why I'm talking about ischemia is so that The ischemia is something which you can revert, you can actually revascularize, you can catheterize and do some intervention to make them salvage. The cardiogenic shock has a huge mortality burden. 50% of the cases, they are going to die in the first 30 days, the short-term mortality. If you see, despite of having so much of advances, as we have gone through the shock trial, the IBP shock 2, where IBP has been promulgated, and the Empress, where the role of impaler has been elucidated in a patient with severe cardiogenic shock, still they continues to have a high mortality of 50%. This 50% is not only in short term, but also even if you follow them up for a year, you find that they don't survive, despite the use of mechanical circulatory assistant. Obviously, to fill this gap, we needed some better methods of not only the assessment, but also to intervene. The role of CPO has been given in 1990 by Dan. However, the biggest impact has been through this paper, which was the shock trial registry, which was published in 2004 in ACC. And what they came with the conclusion that out of all the parameters which they had, the CPO has the strongest hemodynamic correlate of outcome in cardiogenic shock. However, it needed the right higher catheterization in order to pick up and measure this data. Through this paper, they have shown that clearly the CPO emerged as the winner in all the possible analysis. This was the one which has the strongest impact, the measurable strongest impact on the survival of the patient. You can see in this diagram, on the x-axis we have a cardiac power output, on the y-axis we have cardiac mortality, in hospital mortality. When the CPO is less than 1 watt, you can see how exponentially the mortality in hospital has got risen. So obviously we needed better parameters to bridge this gap. We needed something to be very specific, sensitive. We wanted to assess, like the fluid responsiveness. We know that the patients in a cardiogenic shock, they are sick, they are going to die. Obviously, we need better way of making an assessment for them. We have studied a lot when it comes to fluid responsiveness. We wanted something like fluid responsiveness. Can we have a cardiac responsiveness through which we can actually elucidate and understand whether my patient needs fluid or inotrope or vasopressor or mechanical circulatory device? And even if we are using them, how the patient, they are responding to that intervention is also something is of extraordinary importance. We want to make everything well cited through the evidence, not just pragmatic driven. Where we are right now. Right now we have the direct metrics which are available. Obviously, they are based on the PAC, the pulmonary artery catheters, like CVP, pulmonary artery pressures, pulmonary capillary wedge pressures, mixed venous oxygen saturation. But what we are interested in this presentation are the indirect parameters like CPO, the PAPI, which is known as pulmonary artery pulsatility index, the CVP by PCWP ratio, SVR, and PVR. We are not going to discuss all the parameters. This 15 minutes, I can only do the justice onto the CPO and the PAC-based data, but they are the most important cornerstone of your assessment on which you're going to guide your intervention. So what is CPO? CPO is the pumping ability of the pump. The heart is nothing less than the hydraulic pump. The pump has to function. Not only it's a machine which is going to convert the mechanical energy into hydrostatic energy. This hydrostatic energy is going to be reflected in terms of the cardiovascular flow and the pressure. So the cardiovascular flow is basically the cardiac output, and the pressure is basically the mean arterial pressure. We have measured, I'm going to tell you how, the resting CPO, which means when I'm at rest, 1 watt is something which we all have. When we are under the stress or we are exercising, stress could be physiological or pathological. Under the stress, a normal nave heart can increase the cardiac power output by up to 6 watt, which means from 1 to 6, almost 5 watts, they are extra recruitable, which are available for us. However, in the disease like CHF, AHF, and cardiogenic shock, we have seen that this recruitable reserves steeply goes down. So how to measure? The CPO is basically nothing. It's a very simple concept. You just have to multiply the MAP and the cardiac output divided by 451, which is a constant. The point which you need to remember is that if your patient is having a high right atrial pressure or the CVP, then you have to see the second equation into the consideration, MAP minus RAP into CO by 455. For the initial equation, we believe that the CVP is not significantly high, which is around 0 to 3 or 0 to 4 maximum. So it hardly make an impact. But in case if your patient is having right ventricular failure, you can expect the CPO has to be adjusted for the RAP. The CPO in most of the studies has been found when it is less than 0.53, especially the most important paper, the shock trial registry, which I have just spoken, it reflects with the in-hospital mortality. This was the paper which I was talking about. In the first slide, this was a benchmark paper which has given you the basics foundation pertaining to cardiac power output. This was published in 1990 in the British Medical Journal. Now, obviously, to obtain the cardiac power output, your patient need the Swan catheter. So to obtain CPO, you have to swan the heart. Now, the point which I wanted to impress upon that when you're going to swan the heart, you also need to know and you also need to profile the various pressures like right atrium, right ventricle, PA, PCWP, the pulmonary artery systolic and diastolic pressure. And I'm going to let you know in the next few slides that how, when you know all this pressure, including RA, RV, PASP and PADP, PCWP and cardiac output, we call it as a complete hemodynamic profiling. The point which I wanted to impress upon at this slide is CPO is an important adjustment tool, but it has to be seen as a part of complete conglomeration of the hemodynamic profiling. And in order to obtain the reliable CPO, there has to be an invasive right heart catheter, which is nothing less than the Swan catheter. The point here is that because the Swan-Ganz catheter has gone down, the reliability through which you are going to obtain the CPO has also suffered. Nevertheless, you can obtain CPO with the help of non-invasive cardiac output monitoring, but it's not going to be very reliable. All the dedicated cardiac centers, they replicate this information of CPO on the basis of your invasive catheterization. So CPO is not all enough. We need complete hemodynamic profiling. Need of the hour, as I discussed, is a cardiac responsiveness, which I've spoken, complete hemodynamic profiling, and thereafter the appropriate intervention on the basis of your profiling, whether my patient has a problem with the SVR, the PVR, or the mixed venous oxygen saturation, the PSV pressures. Then on the basis of this, I have to take an intervention apart from the newer metrics like CPO, the PAPI, and the ratio between the CVP by PCWP. This has been well elucidated in this paper, which has been published in 2020. Dr. Rishad Guerin has done the maximum work. I would like to acknowledge the work which Dr. Guerin and Dr. Saxena has done. They are the maximum impactful work which has been done on this subject. And what they came with the conclusion, when you have a complete hemodynamic profiling, then you have the least hospital mortality. And it is very important to initiate this hemodynamic profiling on the basis of the PAC-derived parameters, even before the initiation of MCS. There's another paper which has got published, which is values on the hemodynamic monitoring in cardiogenic shock in a mechanical circulatory assessments. Everybody has a studied CPO without MCS. But Dr. Saxena et al., including Dr. Guerin, they have also studied the relevance of this parameter, the CPO, apart from the complete hemodynamic profiling, which I have spoken, which include your CVP, the right, which is your right atrial pressure, the right ventricular pressure, the pulmonary artery systolic and diastolic pressure, the cardiac index, the cardiac output, the and your PCWP. That actually is a complete set of variables which you are supposed to study and take the decision on the basis of this. He has given this 5 phenotypes, the clinical phenotypes, extremely important. They are nothing, although less than the representation of the Forrester classification, the 4 quadrants. What they have added is the pre-shock normotensive hypoperfusion or the pre-shock hypotensive normoperfusion, which are the 2 important variants which you normally see even before there is a classical cardiogenic shock. So these are important things. I encourage each one of you to go through with this paper. This is going to help you. And my dear friend, just if you can look, they have given you that on the basis of PAPI, your CVP by PCWP and the CPO, how can you define these clinical phenotypes? The fate of pulmonary artery catheter has declined a lot. in the last 30 years. They have said in this paper almost from 30 to 45%, what it used to be 40 years back, it has gone down to 4.5%. However, it has seriously encouraged us to reflect that when you're talking about all these parameters like CPO, you need to have a reliable method of an assessment as well. So it has clearly said that there is a significant place of this PC catheter, especially in the management of most complex shock. However, the careful selection of your patients, the correct implantation technique so that you can avoid those kind of gross mechanical errors, the meticulous analysis of the data, which has actually suffered. We know how to swan, many of us, but the interpretation is really crippled among the the healthcare colleagues, and thereby the intervention, which is dependent upon your interpretation, also suffer. So these things, they must remain to be a part of your teaching, your understanding, and your practice, because if it is clearly understood, it has a strong impact to change an outcome. I want you to focus on this red line, which clearly has said that the higher the number of vasopressors or the vasoactive drugs, lesser will be the survival. So if your patient is on 3 vasoactive drugs, you can expect the mortality of almost 60 to 65%. If your patient is on 4 vasopressors or 4 vasoactive drugs, you can expect that the 80% or 84% they are going to die. That actually reflects that in patient, when you find that the CPO is less than 0.6, or even if it is less than 1, and there's no point of just bombarding the heart with the pharmacotherapy, because somewhere this pharmacotherapy is counterproductive in them. So I'm going to study this case in the next 2-3 minutes. We have a 67-year-old man who's a diabetic, hypertensive, hypercholesteremic, chronic smoker. Post-CABG, he came with a chest pain, droplet positive. In short, he was having ACS. His BP was initially normal. Yes, now we have to go into the classification, but it is definitely less from 140/70, what used to be baseline. But his perfusions are not bad. So he was due for the cardiac catheterization. Later in the day, he got worsened, tachycardic, BP further went down. He went into poor urine output, poor perfusion markers. The shock team got activated. The PA data, which has been now on your screen, is definitely sensitive cardiogenic shock. But if you see the CPO is 0.5, which means he is very poorly placed in terms of his prognosis. And these kind of cases, they do worse. So they do need urgent MCS. The PAPI, which is more than 1.5, which is although beyond the scope of this case discussion, but it helps you in understanding whether RV is contributing to the cardiogenic shock or not. So once you have this complete hemodynamic profiling, it's easy for us to understand that the patient had a complete cardiogenic shock with predominantly LV failure phenotype, because the CVP, the CVP, PCWP, they were perfectly okay. Definitely the SVR was on the high side, so they need more of some inodilator. Because the CP was poor, they indicate poor prognosis, and it warrants early MCS or mechanical circulatory device. And in this kind of cases, LVADs, which improves the left ventricle unloading. So what are the strategies which work in this case? Now, this is something which is going to be my last slide. The strategies which has worked in a patient who are having a shock, more specifically the cardiogenic shock, early diagnosis. So we need both clinical and hemodynamic criteria. Surprisingly, European Society of Cardiology in 2016 has taken off the hemodynamic criteria to qualify the patient as cardiogenic shock. And it's coming up again that we should include this as a part of your routine assessment. Not only just knowing the clinical early diagnosis, we also have to do early hemodynamic profiling. Why we need to do early hemodynamic profiling? Hemodynamic profiling is going to help you in understanding the cardiac responsiveness, that what should be given to my patient, and whether it's an inotrope or a vasoactive vasopressor or a vasodilator or the fluid, depending upon the invasive catheterization, invasive data which you're going to obtain from the right heart catheter. There has to be a structured, dedicated shock team. The shock team where the role of intensivists now cannot be undermined. Right? And this has been a game changer when it comes to the patients who are having a cardiogenic shock. This is taken from all the evidence-based practices and the early use of MCS when your patient is more in terms of your vasoactive therapy, especially when it is crossing more than 1, and your CPU is less than 1 cardiac profit output, it's time for you to ring the bells and think whether my patient qualifies for early placement of mechanical circulatory device, rather than when the patient is in an impending doom or the extremis stage. Obviously, now you are going to guide your stratification and your prognosis. So my dear friends, I would like to end my presentation with that the success of intensive care is not therefore to be measured only by the statistics of survival, as if each death is a medical failure. Rather, it has to be measured by the quality of life preserved or restored, and by the quality of dying of those in whose interest it is to die, and by the quality of human relationships and the interaction which are involved. So thank you, my dear friends. Thank you for making the difference in the field of intensive care. And thank you everyone for your patience listening. Bye-bye.
Thank you, Dr. Manish. It has been a wonderful lecture. And with advent of new mechanical circulatory support devices and the use of PA catheter, the monitoring of cardiac power output has also become one of the very important predictor of mortality and the patient's recovery also for hemodynamic monitoring and therapeutics. So it is a very nice lecture, Dr. Manish. Very nice. We'll go for the next lecture now. So next lecture is going to be on the recent studies which have shown that the double sequential external defibrillation, it has got a better survival from the hospital till discharge. And Dr. Gunjan is there, who is the chief intensivist at the KJ Somaya Medical College and Super Specialty Hospital. She is going to take us on this topic, double sequential external defibrillation. Over to you, Dr. Gunjan.
Good morning, friends. I'm Dr. Gunjan Chanchlani from Mumbai, and it is my pleasure and a privilege again to be a part of HICS, the most awaited conference of the year. So today my topic is double sequential defibrillation, also known as double sequential external defibrillation. And this is definitely the way in the future, and it involves application of 2 shocks using 2 defibrillators nearly simultaneously. Refractory ventricular fibrillation. It literally means giving 2 shocks, that means 720 joules monophasic to shock a ventricular fibrillation arrest as 3, or you could say a 360 times 2 shock. So the problem that we all know that the major cause of out of hospital cardiac arrest is ventricular fibrillation and ventricular tachycardia. And defibrillation is the most important strategy for survival in patients who have arrest due to ventricular fibrillation or ventricular tachycardia. And despite the best attempts, we know that the survival is less than 50%. And currently our guidelines say that in refractory cases, amiodarone may be tried. There is not much research in this to improve the survival for many, many years. And though we still have trials which related to eCPR, which are going on. So approximately 20% of the cardiac arrests initially present as a shockable rhythm, predominantly ventricular fibrillation. And of these, 20% will remain in ventricular fibrillation even after 5 shocks, despite standard resuscitation attempts that are being used. So double sequential external defibrillation gives an alternative defibrillation sequence to this patient in refractory ventricular fibrillation. And the goal is to provide an extra tool to convert a refractory ventricular fibrillation either by increasing the energy or in changing the vector of the defibrillation attempt that we do. So what is refractory ventricular fibrillation? So not defibrillation, fibrillation. The refractory ventricular fibrillation is a persistent, uninterrupted ventricular fibrillation that will not break despite defibrillation attempts and despite the medicine administration. So the indication for using a double sequential defibrillation is in a patient who has been in refractory ventricular fibrillation and has received at least 3 defibrillation attempts, either by an automated AED or by a regular defibrillator, manual defibrillator, and he or she has been administered epinephrine and an antiarrhythmic drug during this process of resuscitation, and despite this continues to be in ventricular fibrillation. So the basic principle of using double sequential defibrillation is that the left ventricle, which is often the origin of the defibrillatory wave, thus lies posteriorly, and a shock which is delivered through these anterior pads, which are placed on the anterolateral aspects, do not have a sufficient impact on many parts of the left ventricular. And that is perhaps the region which is not accessible to the anterolateral pad placement. So that is why the fibrillation which arises in this area will fail to terminate. So a change of vector from the anterolateral to the anterior posterior may result in a better termination of the fibrillation. So the pad placement here, there are two sets of pads which are placed, and one set is placed in the regular anterolateral, as we can see in the figure here, and another set of pads is placed in the anterior posterior position. The general concept or the physics involved in this scenario is that there is now two directions of energy flows that are happening through the heart, and which are in the near simultaneous time frame, so that more and more of myocardium is getting converted or is getting covered at the defibrillating attempt, and this helps or encourages cardioversion. Generally, they use two shock vectors, as we have shown, with two sets of defibrillation paddles, and the first set is applied in the regular manner, that is in the anterolateral locations which we usually apply, and the second is applied in the anterior posterior manner, or in the other option, that is one pad lying anteriorly and the other posteriorly. Before we go ahead, we need to understand what is vector change defibrillation. So vector change defibrillation basically just involves the change of vector of the defibrillation attempt. So here it involves, instead of anterolateral, when the vector change defibrillation is applied, a paddle is placed in the anterior posterior placement, and this will cause more amount of voltage to pass through the posterior part of the ventricle, where most of the myocardium or the left ventricle myocardium lies. And this change in the vector path will include the interventricular septum, and thus may require lower energy to defibrillate. And different pathways, use of different pathways can increase the current density in the lowest voltage areas after the standard shock, and this has shown to benefit in some circumstances in some previous studies. So how does this attempt actually work? So when the defibrillation fails to terminate a ventricular fibrillation, this fibrillation this failure is basically because the fibrillation often starts to resume or often starts to restart in the region where the current could not reach, or where the lowest voltage and the current gradient could reach in that region of the myocardium. And we all know the anatomical location of the left ventricle, which is a posterior structure, is that region of the heart that is farthest away from the direct line which joins the standard anterolateral electrode or the pad placement or the paddle placement that we have of the defibrillator. So this results in some part of the left ventricle not being adequately defibrillated, and this has the potential to restart the fibrillation. So this is again exacerbated by conditions in patients who have left ventricular hypertrophy or who have dilated cardiomyopathy, who often have higher chances of going into a cardiac arrest. So this vector change defibrillation thus results in a change this results in a higher voltage gradient being delivered to this posterior aspect of the left ventricle compared to the standard anterolateral pad placement, which increases the potential to terminate the arrhythmia or completely terminate the arrhythmia. The double sequential external defibrillation provides the same theoretical benefit that a vector change defibrillation provides, but with the additional influence of the increased energy being delivered by the second defibrillator shock. It has still remained uncertain what really benefits when a double sequential and external defibrillator is used, or defibrillation is used, whether it is the vector change alone which is working, or is it a combination of the pads which are placed in two different vectors, so that when the current is provided simultaneously, this current has a homogeneous distribution throughout the myocardium. So it is possible that the double sequential external defibrillation, that this instantaneous electrical current that is provided, which causes complete refractoriness of the myocardium, and this could probably cause or the complete myocardium gets is in the refractory period, and that causes eventual restoration of spontaneous circulation or restoration of the regular rhythm. Also, there is a possibility that the first shock which is delivered in this simultaneous delivery of two shocks is probably the first shock acts as a conditioning shock for the second shock, so that there would be a stronger defibrillation or a more defibrillation of the complete myocardium. Also, it has been shown there is a consistent 10 to 20% drop in the impedance in the patients in the trial during the vector chain defibrillation during the anterior-posterior placement of the shocks compared to the impedance which is measured when the anterolateral defibrillation attempt was done. Thus, it suggests that the anterior-posterior shock delivered energy is more effective as compared to the standard shock delivery. So the history of using double sequential external defibrillation goes back to 1986, where animal studies had proven its effectiveness. And in 1994, David Hawk reported on his experience with 2,990 patients and in over 5,000 EP studies, wherein sustained VT or VFib were induced in 30% of the studies. So five patients failed to convert with the use of single shock after 7 to 20 attempts of giving defibrillation, and the sinus rhythm was restored in all of these 5 patients with double sequential shocks being delivered within 0.5 to 14.5 seconds interval of each other. Then came the most important trial, which is the dose VF trial. Which is a dose VF trial, which is a cluster randomized control trial, which is a crossover trial with 4 Canadian paramedic services, and these included all the treated adult out of hospital cardiac arrest patients who presented in ventricular fibrillation and received a minimum of 3 consecutive defibrillator attempts. Each emergency medical service was randomly assigned to either provide standard defibrillation or a vector chain defibrillation or a double sequential external defibrillation. And these all agencies would cross over to an alternative strategy after a 6-month period. About 152 patients were enrolled in this trial, with 89.5% of the cases receiving the defibrillation strategy that they were randomly allocated to. 93.1% of the cases received a vector change defibrillation or double sequential external defibrillation prior to their 6th defibrillation attempt. And this pilot study found no safety concerns. And there was a termination of ventricular defibrillation seen in 82% of the patients with vector change and 76.3% of the patient with the use of double sequential external defibrillation, as compared to only 66.6% conversion or termination in the standard group or standard technique of defibrillation. There was return of spontaneous circulation in almost 40% of patients in whom double sequential external defibrillation was given, and 39.3% in vector chain defibrillation, whereas only 25% had a return of spontaneous circulation where only standard defibrillation attempts were given. This safety that was seen in the study paved the way for the dose VF trial. So it concluded the dose VF protocol is feasible and safe, and the rates of termination of the ventricular fibrillation or the return of spontaneous circulation was higher in the vector chain defibrillation and in the double sequential external defibrillation than in the standard defibrillation. At the same time, in the same year, there was a systematic review which was published, which also included this pilot study, which had 4 cohort studies, 3 case series, 1 case control study, and a prospective clinical trial, which had a review of double sequential defibrillation for refractory ventricular fibrillation cardiac arrest. The authors considered all studies to have serious or critical risk of bias, and that is the reason why they did not perform a meta-analysis of all these studies. However, they found no difference in the terms of the neurological outcome, in terms of survival to hospital discharge, in terms of survival to hospital admission, and return of spontaneous circulation or termination of ventricular fibrillation or pulseless ventricular tachycardia between use of double sequential defibrillation or the standard defibrillation strategy. Thus, they concluded that the use of double sequential defibrillation was not associated with improved outcomes from out-of-hospital cardiac arrest. They suggested that further high-ended or high-quality evidence is needed to answer this important question. Thus, in 2020, after the systematic review, the AHA guidelines said that the usefulness of double sequential defibrillation for refractory shockable rhythm has not yet been established. However, at the same time, after the release of the pilot study, the dose VF trial protocol was planned, and this was planned as a 3-arm cluster randomized trial with repeated crossover over the 3 years. The patterns of shock will be the same as was in the dose VF pilot study, which we discussed earlier. The primary outcome would be survival to hospital discharge, and the secondary outcomes would be termination of ventricular fibrillation after the first shock, first interventional shock, that is the first delivery of the first double sequential shock, termination of ventricular fibrillation inclusive of all interventional shocks, and the number of defibrillation attempts which would be given to obtain the return of spontaneous circulation. So they included all cases of refractory VF or pulseless VT which did not respond to 3 standard defibrillation attempts which was given between 2 minutes of standard cardiac resuscitation. So 6 Canadian paramedic services were included in the trial, and the trial was planned for 3 years between 2018 to 2022, and all adult patients with out-of-hospital cardiac arrest. And the design included a 3-group cluster randomized trial with use of 3 types of defibrillation as we discussed previously, and all the teams would cross over for every 6 months to use a different defibrillation strategy. So this is a trial which is hot from the press, and it is published in NEJM in December 2022. So in this study found that there was 67.9% of witnessed out of hospital cardiac arrest, and 58% of them received bystander CPR. The baseline of the baseline characteristics in all the 3 groups were similar in terms of the median response time being less than 8 minutes in all the 3 groups. The time to first shock, duration, and the number of shocks before the return of spontaneous circulation were all similar in the 3 groups, and the return of ROSC was less than 15 minutes in all the 3 groups. The dose of amiodarone given, the epinephrine or lignocaine given was also similar in all the 3 groups. The sample size was approximately planned to be around 930 patients. However, because of the COVID pandemic, it was not considered safe to continue with the trial, and that is why only 405 patients were included in the analysis. And these 405 patients also included the 150 patients which were from the pilot study. So in the analysis, 405 patients, including the ones from the pilot study, were included. So the trial found that in the 3 groups, that is in the vector change group, in the standard group, and in the double sequential group, there were approximately 136 patients in the standard group, 144 in the vector, and 125 patients included in the double sequential group. And the primary outcome, that is the survival to hospital discharge, was significant in the patients was greater in the patients, significantly greater in the patients whom vector change defibrillation and in whom double sequential defibrillation was used for refractory ventricular fibrillation. So this number was 13.3% in the standard group, 21.7% in the vector change defibrillation, and 30.4% in the double sequential group. The termination of ventricular fibrillation was significantly better in the double sequential group, but was non-significantly higher in the vector change group, with 79.9% in the vector change group and 84% in the double sequential group, and only 67% termination in the standard group. The return of ROSC was again significant in the vector change and the double sequential group, and neurological outcomes till hospital discharge. So they attempted to see the neurological outcomes only till hospital discharge, which was again better in the double sequential group as well as in the vector change group. However, this was significant only in the double sequential group. However, as you see, the number of patients which were included in the study were quite small, and this survival to hospital discharge that was found to be significant may actually be an overestimation or a false positive error. also it was seen that in the vector change defibrillation group, the fragility index was quite higher. That means if there would have been one extra death in this group, then instead of being a significant primary outcome, it would have been a insignificant or a non-significant primary outcome. I don't know. So sorry. So to conclude, this definitely was a very good study. It had a very strong study design and the cluster crossover design to decrease the potential for any contamination between the intervention groups and in the standard group. So the cluster crossover design with the randomization really helped. The performance of high quality CPR, which was employing both the manual and the automatic external defibrillators, near complete outcome assignment, inclusion of patient-centered outcomes, all these made the study a very strong study design. However, also it is important to note that there were not many exclusions or not many attritions from the groups, and all the patients who were included in the study were analyzed. However, this trial had to be terminated early, and it makes it a highly underpowered study. And also, the external validity of this trial is quite unsure based on how the CPR protocols are or how the training or the skill of the team is in different countries and in the different continents may vary. Okay. This being a highly underpowered study, it may also have overestimated the results, and maybe future studies may prove it otherwise. So will I use double sequential defibrillation? Yes, probably I may use it, but we need to remember that it requires 2 defibrillating machines to be used simultaneously. Also, the changing the position of the patient to apply the anterior-posterior paddles may decrease the amount of chest compression time that we give, and of course, it requires more manpower to use it. So yes, I will use it in refractory cases for sure if the patient has if the whole structure or the infrastructure permits me to use it. But at the same time, while we are using double sequential defibrillation, we should not forget the basic principles of CPR, that early defibrillation is a key component of return of spontaneous circulation, and chest compressions have to be continued immediately after the delivery of the defibrillating shock. Do not forget the principles of high quality CPR, that you need to push hard, push fast and minimizing the interruptions. You need not stop bagging and move 15 feet away when we give defibrillation, and use the double sequential attempt after the third failed standard defibrillation attempt. Whether it is simultaneous or sequential, though it is called sequential, it is actually simultaneous delivery of 2 shocks at a gap of less than 1 second with two sets of paddles placed in 2 different vectors. Thank you.
Thank you, Gunjan. Moving on with the next talk, I invite Professor Dr. Subhash Prasad Acharya from Nepal. Over to you, Dr. Acharya.
Namaste. I would like to thank Hyderabad Intensive Care Symposium for giving me this opportunity to talk at the prestigious symposium. These are my conflict of interest. I have no disclosures to make. Ischemia reperfusion injury underpins the damage of myocardial infarction, stroke, and other conditions complicated by interruption of the blood supply to the tissues. Strategies to limit the duration of ischemia have achieved substantial health gains in myocardial infarction and to a lesser degree in stroke. We have achieved minimum door to needle time. So what next? One such approach is ischemic preconditioning and its variant, remote ischemic preconditioning. Ischemic preconditioning describes the phenomenon whereby transient, brief periods of ischemia confer protection against a subsequent prolonged and injurious period of ischemia. It can be local, which occurs when the preconditioning stimulus is applied to the same organ or tissue that will subsequently sustain the ischemic injury, or remote, which refers to a stimulus applied to a distant organ or tissue which then protects against the index ischemia. For example, the preconditioning stimulus might be a suprasystolic blood pressure cuff on an arm or a leg, which then confer myocardial protection against subsequent ischemia. Post-conditioning occurs when there is a staged reperfusion, for example, in the setting of balloon angioplasty. The first paper describing preconditioning with ischemia was by Murray et al. In 1986 in the Circulation, where in this they studied on dogs where they applied occlusion for 5 minutes followed by reperfusion. This was done repeated 4 times and followed by prolonged period of occlusion. This was the preconditioned group and the control group. And in the 40-minute occlusion group, they could show that the preconditioned group has a lesser infarct size than the control group. This is the 3-hour study group, which was not significant. This ischemic preconditioning confers protection, which expires after a few hours. But subsequent studies show that it can be recovered approximately 24 hours later, and this second phase of protection can last up to further 72 hours. Ischemic preconditioning, but now has not been able to progress to a detailed clinical applications. Let's see this paper published in 1990, where they did a similar study where they occluded for 5 minutes followed by reperfusion and then followed by a prolonged 60-minute occlusion. And they found that the ischemia zone in relation to the area at risk are much more lesser in the preconditioned group rather than the control group. This was another publication in 1990 where they similarly performed 5 minutes of occlusion, reperfusion, followed by prolonged 40 minutes of occlusion. They could see that the lactate level was lower. Similarly, the glucose 1-phosphate, glucose 6-phosphate, and alpha-glycerol were all lesser in the preconditioned group than in the control group. This was the first study about remote ischemic preconditioning. Here they applied the ischemia in a remote vascular bed and checked the infarction area at the heart. And they concluded that brief period of ischemia in the remote location, they protected the virgin myocardium from the subsequent sustained coronary artery occlusion in the dog model. The area necrotic is lesser in the ischemic preconditioned group than in the control group. This was another study published in Circulation in 2002, where they provided transient limb ischemia and checked for the infarction size, which was significantly lesser in the preconditioned group rather than the control group. So this is the timeline of the studies. The first study is by Murray et al. In dog, where they preconditioned the left antedescending and checked the infarct size from the LAD. In 93, Presling, they studied the, they did the preconditioning the left circumflex and studied the LAD. And then this was the rabbit model in 93, where they preconditioned the kidney and checked the size at the heart, LED. This was in 97, where they preconditioned by applying the tourniquet at the hind limb and then check the infarction size at the heart. This was in 2006 when this was applied to patient children undergoing congenital cardiac surgery. The ischemia preconditioning was applied in the upper limb and checked the effect on the heart. And this was in adult in 2007, where upper limb preconditioning was applied in patients undergoing elective CABG and then check the effect on the heart. Then this was another study where they combined the ischemic post-conditioning and remote per-conditioning, both, and applied this and over various groups, and then they operatively they sectioned the heart and looked and found that in the control group, the area, necrotic area in respect to area at risk was much more higher than the other groups, other preconditioned group. So with commonly applied conditioning protocol, IPC is superior to per and post alone. This was another study published in 2011. This is a review article which discussed about the mechanisms of per conditioning, and they showed that once the trigger is applied, there is communication by means of humoral, neuronal and systemic ways, and which protects the target myocardium. This was the pathophysiology that has been proposed. RIPC by brief period ischemia, they activated protein kinases, stimulates neural, humoral and systemic pathways. Neural and humoral through circulating factors by G protein coupled receptors and kinase pathway, they stimulate mitochondria and act at the potassium and the MPM PTP, and they offer the first window of protection. Whereas the systemic pathway through various mediators, they offer second window of protection. This was a review article published in 2019, which discussed various methods, protective modalities, including ischemic conditioning, pharmacological and physical intervention, and their application timing, cellular target and intracellular targets, and discuss various mechanisms. These are the common circulating mediators of ischemic conditionings that has been identified so far. Interorgan protection was also confirmed by the observation that preconditioning stimuli applied to the small bowel or kidney reduce the infarct size in the heart. The demonstration that remote ischemic preconditioning could be activated merely by brief periods of limb ischemia simplified the logistics of inducing human ischemic preconditioning in animals and humans. Moreover, RIPC activated by limb ischemia protected from experimental ischemia reperfusion injury in humans. Then these were started into clinical trials in human studies. This was published in 2010, where they performed human coronary artery bypass surgery. But to the disappointment, it did not offer any benefit in the remote ischemia perfusion group and control group in terms of cardiac troponin, cardiac index, and the required dose of ionotropes and vasopressors. This was another systematic review and meta-analysis published in 2012, where they studied 17 studies and tried to identify the advantage of ischemic conditioning, but concluded that it's still experimental and not part of accepted treatment protocols. There was not enough evidence to recommend the routine use of RIPC, and larger trial are needed. So what are the clinical trials that have been done after that? So this was the CRISP study, in patients undergoing coronary percutaneous coronary intervention, where they applied a remote ischemic preconditioning, but they found that at 6 years, the incidence of major adverse cardiovascular events and cerebral events were less in the remote ischemic preconditioning group rather than the control group. This was another trial which studied the preconditioning with post-conditioning, but they also concluded that they did not improve clinical outcomes in patients undergoing cardiac surgery. This was another study which studied the RIPC, its effect on mitochondrial function and microRNA expression, which they concluded that RIPC preserves mitochondrial respiration in the right atrium, and also the incidence of post-operative atrial fibrillation was significantly higher in the control group rather than the RIPC group. This was another study, another trial published in the stroke, where RIPC was applied as an adjunct therapy to thrombolysis. These are the baseline data, and these are the findings which did not show much significant difference on the salvage infarct size or infarct progression as measured by MRI in 3 months. However, when they adjusted for severity of hypoperfusion, they demonstrate an increased tissue survival after 1 month, which suggests that pre-hospital remote ischemic preconditioning may be somewhat neuroprotective. This was another repair trial done in patients with renal transplantation. Was done at the NHS in UK, and they showed that in the RIPC group rather than control, the effect, the GFR are significantly higher at 12 months. Done by various methods, at 3 months and 12 months, GFR was significantly higher in the transplantation patients. This was another study which combined remote ischemic preconditioning with insulin or exenatide to check for infarct size in pigs. They concluded that the combined therapy with remote ischemic conditioning and GIK or exenatide, they are superior than the intervention when administered individually. This was the RIP heart study published in 2015 in patients undergoing undergoing heart surgery. They applied RIPC and a SAM RIPC in almost a similar number of patients, but did not show any benefit in these patients. Another study, the ERICA trial, published in 2015 in NEJM, in patients undergoing cardiac surgery, which also which studied the major adverse event, but which also failed to show any change in improvement in clinical outcomes in patients undergoing RIPC. This was another study which checked the application of daily ischemic conditioning in acute MI, but this was also a disappointment and not a significant study, where remote ischemic perfusion preconditioning did not significantly impact the primary endpoint of improvement of left ventricular ejection fraction at 4 months. So the current status, this is the latest publication in 2019 in the Lancet, the Quanti2 ERIC PPCI trial, which studied the effect of remote conditioning in patients with STEMI undergoing primary angioplasty, but they also failed to show improvement in clinical outcome, which was cardiac death or hospitalization at heart failure. None of them were significant. another study, Combat MI, they also studied the effect of combination therapy of remote ischemic conditioning and exenatide, but this was not significant in those two groups. Infarct size was similar. So they concluded that neither RIC nor exenatide or its combination were able to reduce the infarct size in STEMI patients when administered as an adjunct to PPCI. This was another study which was started in 2011, but still recruiting patient, results not available yet. Maybe this will give some more knowledge on atrial fibrillation patients, on atrial fibrillation after CABG. So for now, the take-home message is RIPC harnesses a powerful innate protective mechanism against ischemic injury, which have been documented in various animal models and even humans. The mechanism is yet not fully understood, but has shown promise in some studies. No major trials have been able to demonstrate the advantage of RIPC or the effect of RIPC to reduce the incidence or impact of clinically important consequences of ischemia reperfusion injury. Thank you very much. I'll be happy to take any questions. Thank you.
Thank you, Dr. Subhash, for such a wonderful and exhaustive presentation on RIPC. So now we'll go for questions in this session. My first question is for Dr. Manish. The question is, in absence of pulmonary artery catheter, how can you calculate CPU? Is it possible, or how do you calculate it?
Thank you, Dr. Mithilesh. Am I audible?
Yeah, you're audible.
Thank you, Dr. Mithilesh. Thank you, Dr. Ghanshyam and Dr. Srinivas for having me here. You know, Dr. Mithilesh, this concept of CPU has been prescribed with respect to the invasive data. But yes, many of the papers which has got published, at least in the last decade, they have chosen non-invasive cardiac output monitoring as well to translate this information. The problem with the non-invasive cardiac output monitoring is the reliability and whether you can replicate the same reliable data with the passage of time. So that is something which we have to see. But yes, if you see the papers, they happen there with the non-invasive cardiac output monitoring as well.
What I would like to ask is that it is used mostly in the patients who are very sick, like a severe significant cardiogenic shock or patient on mechanical circulatory device. In those patients, there is a continuous flow. So there is no pulsatile flow. In that scenario, monitoring cardiac output by the pulsatile methods becomes little difficult. So in that scenario, is it absolutely required to put a pulmonary artery catheter to measure the cardiac output and then for the cardiac power output monitoring?
You are talking about the cases who are on mechanical circulatory assistance?
Mechanical circulatory support, those patients where there will be a continuous flow, not a pulsatile flow. So in that scenario, our regular cardiac output monitoring, which based on the pulsatile flow, may not be accurate. So in that scenario, is it mandatory to put a pulmonary artery catheter for better or more accurate results?
You know, Dr. Mithilesh, I never thought about this question, to be very frank. So I'm going to learn from you, in fact, at this point. So never thought with respect to the patients who are having a non-pulsatile circulation, how the things are going to be. So I'm not sure about this answer. So I think I need to check it before, I should give you a definite answer on this one. But yes, for sure, if you talk about the patients who are on IABP, the patients who are on LVADs, and all those left ventricular assisted devices, there the papers definitely has been there, for the CPU. And in fact, Mithilesh, these are the cases which need CPU assessment. Because what kind of a patients who need the CPU? Not the patient who is just on, the minimal dose of inotropes or vasopressors. The cases of CPU, actually, if you see, they have been prescribed with the patients who have been the sickest, right? The patient who are requiring on 2 or 3 doses of your vasoactive therapy, or the patient who is actually due for mechanical circulatory assistance. But when the patient is on veno-RTDS ECMO, when the patient is having a non-pulsatile circulation, I never thought into that perspective ever. But yes, for the patients who are on any other assisted devices like your LVADs, your patient on IABP, there it should work. In fact, these are the cases which have been chosen for their, the interpretation and subsequently to guide the treatment as well.
Thank you, Dr. Manish.
Thank you, Mithilish.
My next question is for Dr. Gunjan. The question is that in rapid sequential external defibrillation, do you use monophasic or biphasic?
Mithilesh, Gunjan is not logged in. I think she is busy at her school. She's gone to a school to attend the PTM. She said she's going to log in later. Actually, there's one more question from one of the delegates, Dr. Ramesh to Dr. Gunjan. Is there any change in LV function between different defibrillation? Dr. Gunjan would have been the best person to answer that, but speaking purely physiologically, the longer the time that the patient is going to be in ventricular fibrillation, the higher the chance that the LV is going to suffer. So purely going physiologically, it would make sense to try and get the rhythm back as early as possible. So whatever methods are available, if you can get the rhythm back, probably the damage or the the impact on the LV function would be minimized to that extent. If any other panelists would want to comment on that, please feel free. Manish, your thoughts?
When Sham asked me the question related to the CPO, I would be the better person to answer CPO, not the double sequential.
Okay. We will get back to these two queries. We'll check with Dr. Gunjan and get back on these two queries.
Thank you.
Thank you so much, Manish, Dr. Subhash, for being here.
So now we come to the next session, which is view, counter view, and consensus. There are various various areas in critical care medicine which are gray areas where we have our views, some counter views, and that's why a consensus approach is required for better understanding and for the better patient management. So today in this session we have Dr. Supradip Ghosh, who is the head of the Department of Critical Care Medicine, Fortis Escort Hospital at Faridabad, and counter view is going to be by Dr. Arindam Kar, and who is the Chief Intensivist at HN Reliance Foundation Hospital. And the consensus will be achieved by Dr. Manoj Singh, who is at the Apollo Hospital, Ahmedabad. So we'll start with the view with Dr. Supradip Ghosh, and it is going to be on fluids.
Discussing about my viewpoints on the conventional approach to fluid resuscitation. I hope in the next 10 minutes I'll be able to convince you that even the conventional approach is changing its paradigm altogether. And in future too, as the evidence grows further, our conventional approach will be changing further. Let's first start with why do we give fluid for resuscitation purposes. In cases of hypovolemia, whether it is because of absolute hypovolemia, for example, like cholera or hemorrhagic shock, or in presence of relative hypovolemia because of profound vasodilatation and capillary leak, there is a decrease in the stress volume, leading to a decrease in the mean systemic filling pressure, venous return, and subsequently cardiac output. We give fluid boluses, intravenous fluid boluses, with an aim to restore the stress volume and mean systemic filling pressure, thus improving the venous return and cardiac output, with an ultimate goal of improvement in the tissue perfusion. Unfortunately, it is not true in all the circumstances that we have understood over a period of time. We know now that in half the patients of septic shock, which is a classical case of distributive shock, where there is a profound vasodilatation and capillary leak, half the patients, half of them that do not respond to fluid bolus. And from the Andromeda Shock 2 trial, we have understood that the fluid responsiveness or the patient's response to fluid will decrease further as the patient progresses in the septic shock. Very often, this hemodynamic improvement with septic shock is very transient, and we know that the ultimate aim of improvement of tissue perfusion is dependent on delivery of oxygen, which in turn is dependent not only on the cardiac output, but also on hemoglobin and SaO2. which is very important for patients with hemorrhagic shock. We know in certain types of fluids, there may be some acid-base disturbances. Fluid resuscitation, too much of them can produce coagulopathy and hypothermia, again, in patients with hemorrhagic shock, which is very, very important. And we know now that after certain time, the patient goes to refractory shock, where further improvement in macrohemodynamics with fluids or without fluids may not make any change in the microvasculature. So it's a dilemma. In fact, in a study from Africa called the FEE study, where we can see in certain circumstances, especially in those African children, boluses with albumin or saline can actually increase mortality both at 48 hours and at 4 weeks. But of course, we need to revalidate this study in more advanced countries and in adult septic shock scenarios. We know now that there are a plethora of data that excess of fluid is not good. One of these studies, where the retrospective analysis of the vast data has shown that the patients who received the maximum number of fluid, the quartile of patients who received the maximum number of fluid, they had the highest mortality, both at 12 hours and at day 4. And we know that fluid overload can lead to from raised intracranial pressure to ARDS to raised intra-abdominal pressure and so on and so forth. So we are cautious. We have learned from over a period of time that too much of fluid is not good, but at the same time, some amount of fluid is required. But how do we decide when to give fluid or not to give fluid? Based on these, we now know that there are plethora of parameters which are available, which can be utilized for deciding whether our patients will respond to a fluid bolus or whether our patient's cardiac output will increase with fluid bolus. And this has been suggested by the recent intensive care medicine, this surviving sepsis campaign guideline, where the author said that we suggest using dynamic measures to guide fluid resuscitation, though this has a weak recommendation. And we had moved forward. We now know that many of our patients, they actually should not be given fluid because just based on the fluid responsiveness, because there is something called fluid tolerance. Even if the patient is fluid responsive, we know that if the patient is not tolerant to fluid, that means if the patient can harm to fluid, then we should not give fluid. So, like based on clinical criteria, and of course, today's period, it is the ultrasound days where we have a plethora of data where we can find out the LV function, RV function, the bleach profile, the VAXAS data from which we can decide whether our patient will be harmed by the fluid resuscitation. We know that the vasopressors also has a role, and vasopressors there is a strong interaction between vasopressors and intravenous fluid. So, in fact, the norepinephrine, which is now the first line agent for adult septic shock patients, norepinephrine can increase the PMSF itself, and it can increase the venous return and cardiac output. We know that low diastolic blood pressure is not good for our patients. If the diastolic blood pressure is too low, less than 50 millimeter of mercury, maybe we should start norepinephrine along with the fluids. We know that early vasopressor can reduce the overall duration of hypotension, and not only that, it can also hasten the process of reversal of shock. It can also potentially reduce the overall cumulative fluid balance, which we know now that cumulative fluid balance may be harmful to our patients. But does it mean that we should give only vasopressor to our patient? No, not at all. Many studies have shown that giving vasopressor only can actually produce vasospasm, leading to microcirculatory failure, as we can see from these retrospective studies, where they have shown that too much of vasopressor is not good. And as the vasopressor dose increases, the mortality also increases. But they have conveniently shown us that if the patient received around 1 liter or 2 liters of fluid, increasing dose of vasopressor may not produce that much of increase in mortality. So what does it mean? So we have seen a changing paradigm. What was the conventional treatment during the REVER study, where we can see the patients in the control group have received almost 3,500, 3.5 liters of fluid compared to around 5 liters of fluid in the EGDT arm at 6 hours, though both of them received 13.5 liters of fluid at 72 hours. Compared to that, if you see the recently published Clover study, the patients in the liberal fluid arm have received only 2.3 liters of fluid at 6 hours post-randomization. So compared to 3.5 liters, the conventional arm of Clover study has only received 2.3 liters of median fluid volume. And at 90 days, the overall liberal fluid volume received was 3.5 liters compared to 13.5 liters at 72 hours in the REVER study. So of course, in the REVER study, because of the early resuscitation with fluid, they could show a decrease in the mortality in the EGDT arm. Compared to that, in the Clover study, because we have now already realized that restricting or giving a more rationalized fluid is better. So they could not see any difference in mortality in the further restriction of fluid. So coming to the conclusion from my type, from the conventional approach. One, the first thing is there is a paradigm shift in the conventional approach itself. Now we, the intensivists, are realizing more on the physiological rationale and clinical evidence behind fluid resuscitation. And we are deciding our fluid based on these two things. Secondly, we now know that there is no need of a large fluid bolus. A bolus of 4 ml per kg, probably a reasonable volume in the initial stage. We have understood the importance of starting judiciously the vasopressors early, especially in patients with low diastolic blood pressure and with a diastolic shock index of more than 2.3. We know to use fluid responsiveness parameters and fluid tolerance before further fluid boluses. And let's not forget, the resuscitation fluid is only 6.5% of overall fluid volume received in a ICU patient. So it's not only the resuscitative fluid volume, it's also the maintenance and replacement fluids which needs to be considered while prescribing fluid in the intensive care unit. So ladies and gentlemen, it is important that we should follow our conventional approach, but our conventional approach should be based on a scientific rationale. And we have understood from our data over last more than 2 decades that it is important to give fluid, and we must give fluid in most of our patients who requires it. But of course, we should be using our physiological rationale and clinical evidence for further prescribing our fluid, even in the conventional approach. Thank you very much.
After Dr. Supradeep's conventional approach to fluid resuscitation, we come to Dr. Arindam Kar's conservative approach to fluid resuscitation. Welcome, Dr. Arindam, and over to you.
Hello, everyone, and thanks to the HICS organizing committee for inviting me for this interesting topic, that the conservative or restrictive fluid therapy itself. And I'm Arindam Kaur. I'm presently working in HN Reliance Foundation Hospital, Mumbai, and I also work at a lot extent for the Indian Society of Critical Care Medicine. And I'm not going to give you a symptoms of healthcare debate, right? I'm not going to shout or all others. And one way you are immune to it because it's an online program format. Otherwise, we love to fight with each other. But here we both actually agree to us one certain point. And normally, if you see the Graham's hierarchy of argument or a debate itself, is that I'm not going to go to the bottom of the pyramid by doing all those bad stuff. Rather, I would go for where I can put up counter argument, or rather refuting the central point that the fluid itself is a drug and it has to be restrictive to be useful. So I will come to that point eventually. And I would start with this slide that you need to understand that there are a lot of myths regarding fluid therapy, that not all septic patients are hypovolemic. If you have a lower preload, it may be cardiac cause. Not always you have to give fluids. Many of the surgical patients can be, you are hypervolemic even. Sepsis doesn't cause a lot of insensible loss unless there are other factors too. And in edema, you don't have to give always diuretics. You may have to, at times, improve the other functions. And to understand a proper use of fluids and misuse of fluid therapy, you need to understand the Stirling principle and the importance of glycocalyx and fluid therapy. In fact, the concept of the original Stirling theory or the Stirling concept has now got into a revised concept where you have, this is a normal endothelium and this is the luminal side where the glycocalyx is intact, and this restrict the movement of fluids, and only the movement of other larger molecules can happen through these pores or through the larger pores, which can carry through the overall endothelium itself. But when you have a disease process, or when you have when these glycocalyx differ in between tissues itself. So if you see in this disease process, where we call the capillaries leaky, or the leaky capillary syndrome, we say, all the inflammations and sepsis, all releases cytokines, and this deranges or damages the glycocalyx itself, and the capillary becomes leaky. So this is a concept you need to understand, that not all fluids would be retained, and the retention within the vascular space or going into the interstitium, coming back from the interstitium, this all depends on not only the pathological state of the patient, but also what sort of fluid we are using, but the most important factor, what amount we are using. So that's why we need to understand that this is an hyperbolic curve. So in the normovolemia, which also depends on how much is a normovolemia, depends on the procedures, the comorbidities, the hydration status of the patient, preparation of the patient itself. So if you underdose, then there is a risk of organ hypoperfusion and multi-organ dysfunction. And if you overdose, you have a risk of edema and all other complications itself. And these are the potential consequences of fluid overload on end organ functions. Every system is involved. So be it respiratory, where you have a wet lung and eventually reduction in the PF friction, others. You have a heavy gut with a reduced absorption, and even your the mucosal dysfunction itself, renal interstitial edema and higher interstitial pressure in the renal eventually can lead to renal, on the contrary, can lead to renal hypofunction itself, and a lot of cardiovascular, particularly fluid overload, myocardial edema, eventual myocardial depression can happen. And of course, we know that hepatic congestive hepatopathy, then raised ICP, these are all we know. But you also need to remember that a lot of fluid eventually also leads to tissue edema and pressure sores itself. And this is a concept where bolus fluid and what are the harm a rapid fluid bolus can cause, and eventually lead to cardiac dysfunction, multi-organ dysfunction, and refractoriness of the shock. Because a bolus fluid can cause a shearing injury to the glycocalyx itself, which is fragile due to the disease process and differs in different in the organ, and it leads to that leaking of the fluid from the intravascular space to the interstitial fluid. Bolus can cause vasodilatation, reduction in the adrenergic system. It can lead to hemodilution, elevated venous pressure with resultant decrease in the perfusion pressure gradients, as I showed in what happens in the kidney. The renal perfusion pressure goes down, and interstitial edema because of the leaky capillaries. It results inhibition of the oxygen diffusion between capillary and the cells itself, and all this leads to eventually a refractory shock, right? So we go for a restrictive fluid administration itself. So considerable emphasis has been placed on the identified predictors of fluid responsiveness, that is physiological or echocardiogram parameters such as stroke volume variation, PLR, or a velocity time integral to predict whether a fluid bolus will produce some improvement in the hemodynamic variable. But mind it, these are all macrocirculation predictors. And one rationale for these predictors is to limit fluid administration to situations where there is at least a possibility of clinical benefit. But administering fluid until a fluid unresponsive state is reached has never been shown to give some benefits, because each of the predictors of the fluid responsiveness is subject to major limitations. For example, stroke volume variation cannot be used in the context of lower lung volumes, or when the patient is breathing spontaneously, when there is cardiac arrhythmias or RV dysfunction. Even in the prediction of fluid responsiveness is accurate, measures to use judge the success or failure of the fluid bolus are global parameters. They don't look into the microcirculation itself. They are poor predictors of tissue perfusion, particularly when there is a coherence between macro and microcirculation is frequently lost, as in sepsis. To reduce fluid administration, the early use of vasopressors may be needed. Early applications of vasopressors has a potential to reduce the overall intravascular volume deficit by recruiting blood from the venous compartment while avoiding the detrimental effects of exogenous fluid administration. Delaying vasopressors use until fluid resuscitation has demonstrably failed to correct shock. On the other hand, may delay resolution and assumes that fluid resuscitation is safer than use of vasopressors. Who said that? Is NORAD more harmful than whatever giving 3 liters of fluid? I don't think so. This assumption is the contrary to the available data and may be driven in part by the resource constraint itself. So this is what we call a troll mnemonic, right? So to give fluid, first important is what is the type of fluid, whether you want to give crystalloid, colloid, balanced, unbalanced. What is the rate, right? Whether it's 4 or even and over how many minutes, right? Then your objective, whether you are trying to normalize the macro circulation, that means the arterial pressure, heart rate, cardiac output, or you are looking into the overall microcirculatory function improvement, which can be indirectly or directly measured by either lactates or by sublingual, your tonometry and all others, or even there can be microscopic video capturing on all others. And not only objectives, more importantly, what are the limits where you have to stop? So when they are increased in your central venous pressure or pulmonary vascular permeability index, or in your extravascular lung watering indexes, or achievements of the targets like SVO2, SCVO2, or the lactate itself. So that you have to know. So this is the troll mnemonic: type, rate, objectives, and limits. So while more restrictive use of fluid together with earlier use of vasopressors, if needed, may reduce fluid administration, it is unlikely that at times the fluid overload can be entirely avoided in critically ill patients. Because in ICU, there are a range of different sources which fluids comes in, right? And some of them are obligatory. For example, the dilutions or the vehicle of the drug, particularly if the patient is getting 4 or 5 antibiotics and others. Then nutrition, because the nutritional requirements are very high. Transfusion. So this is, so even if you want to restrict fluids, but there would be a lot of fluids eventually be given, and the very next day you can see the patient has got 3 liters of fluid. So that's what we call a fluid creep, right? So you can see, and this accounts for 33% of the all fluid intake, compared to only 7% is what we call the resuscitation fluid. So you remember that this creep, or maybe we can say unaccounted or thought of fluid is also very important. And besides restriction of resuscitation or avoidance of fluid overload is likely to require de-resuscitation, defined as active fluid removal using diuretics or ultrafiltration, an approach which shortens the duration of ventilation and ICU stay. Also, as at times, a time-tested method done by our seniors also, that co-administration of hyperoncotic albumin and diuretics itself may promote hemodynamic stability and diuresis itself. So that's an age-old practice, which is now again being recognized. So ongoing work is focused on 3 main areas: the restrictive approach to fluid resuscitation, involving early use of vasopressors if needed. So be proactive and be early to use vasopressors. The use of de-resuscitative measures to prevent and treat fluid accumulation following resuscitation, and the search for tools that may predict the patients who may benefit from fluid and those who do not, and also what are the endpoints of fluid resuscitation. It is thus time for fluid stewardship in the critically ill, where fluid should also be treated as drugs or therapeutic interventional agents. So we all have been aware of the concept of ROSE, where you use life-saving resuscitation phase in the beginning, what we call early adequate fluid management. That means you give boluses, and it is followed by optimization phase, which focuses on organ rescue or maintenance phase, and avoid fluid overload. It aims for neutral fluid balance. Then is your stabilization phase, which focuses on organ support or homeostasis. This is called a late conservative fluid management, which is defined as 2 consecutive negative fluid balance within the first week. And lastly, what we call the evacuation phase, which focuses on organ recovery, and it looks into that there is a no flow state, an active goal-directed fluid removal from the body, and a consistent negative fluid balance. So this is the Rhodes concept. So in resuscitation, the aim of fluid treatment is to correct the shock and achieve an adequate perfusion pressure. In the optimization phase, the fluid is administered according to the individual need of the patient and continuously reassessed. In the stabilization phase, we aim to provide the water and electrolytes and calories to replace the ongoing losses and to provide nutritional and organ support. And lastly, the evacuation phase, to remove the excess fluid, which will be frequently achieved by spontaneous dialysis as the patient recovers, although at times ultrafiltration or diuretics or both may be necessary itself. So this is a lovely chart. You can see that in the resuscitation phase, the question is when to start fluids. The fluid balance is definitely positive. The result is actually we achieve to save the life. The goals are to correct the shock, and the time frame is minutes. Where in the optimization phase, the question is when to stop fluids and the risk of fluids itself. The fluid balance is neutral. The goals is to maintain the tissue perfusion. In the stabilization phase, it is it's a stable phase. The cause is ischemia and reperfusion. The question is when to stop fluids and the risk of fluids. The balance is neutral or negative, right? And what we aim for 0 or negative fluid balance, and the time frame is days. And in the evacuation phase, which can be divided into 2 ways, is that the question is the benefits of unloading, when to start unloading, it days to weeks, and that the goals are to mobilize the accumulated fluid itself. And in the last phase, the second phase of evacuation, again, when to stop fluids. Risk of unloading is also a question now. And here, the goals are not only to mobilize fluid accumulation, but also side by side to maintain the tissue perfusion itself. So that's that. If you see in all the phases of fluid therapy, which is being now taught by everyone, including the International Fluid Academy, the group led by Manu Malven and all others. And if you see all the phases, most of the phases, the balance is either a neutral or negative. So neutral or negative. So that's why you can understand that we are moving towards more of a restrictive or conservative fluid management itself. So, and this is just like, as I was telling you, that the concept of fluid stewardship with an analogy between the antibiotic itself. So if you see, you have to go for the 4D, the drug itself, what should be the choice, what should be the dose, what should be the dosing, and when to de-escalate. So you need to know which of the fluid has to be given, what should be the dose, and as antibiotic, shorter duration, it has to be given for a shorter dosage and shorter duration. And lastly, after stabilization with early adequate fluid management, you have to stop the ongoing resuscitation and move to conservative lead fluid management and later goal-directed fluid removal. So not only goal-directed therapy, but goal-directed removal itself. So this is how the 5 P's of fluid administration. It all starts with the physician's participation in making decisions in related to fluid. That means we do a prescription, and the prescription engages just like a drug. You have to choose the fluid, you have to write, you have to give the dosage, you have to give the duration, and you have to be specific on the specific disease process itself. Then it goes to the prescription is sent to pharmacy and is checked for the inconsistencies by the pharmacist to get for a more holistic view. Then it is individually prepared for individual patients, where other things are also added on, particularly the electrolytes, micronutrients, and all others, and then sent to the patient for the delivery. The filled prescription goes back to the patient, and fluid stewards, that means maybe us and the nurse managers, should observe the administration, the response to the fluid therapy, and then debrief and give a feedback. And these are the trials, if you see, that where are the benefits of which sort of fluids and what sort of approach, whether there is a benefit on the restrictive approach. So if you can see that the FACT trial, for example, way back in 2006 done in US, no difference in mortality. Conservative fluid strategy improved oxygenation and lung injury scores and increased the number of ventilator-free days and non-ICU days alive. And this was done on over more than 1,000 patients. Let's see on the FEAST trial. This was done on 3,000 children. Fluid boluses increased mortality. No difference in mortality between saline and albumin boluses. So irrespective of colloid or crystalloid, boluses increased the mortality itself. Let's see the classic trial, which was done in Denmark in 2016 on 150 adults. Significantly less fluid was given to the restrictive group. Secondary outcomes like ischemic events, worsening of AKI, death, and all others favored the restrictive approach. Statistically significant result observed over worsening of the AKI itself. So that is the contrary of our thought process. Giving less fluid is actually improving the renal perfusion by reducing the renal interstitial edema and the pressure itself. 200 adults with septic shock presenting the emergency department, and this is done in a developing country. See, early resuscitation protocol increases the in-hospital mortality. So if you are giving more fluids and then not taking it out or restricting yourself early itself in your resuscitation process, that's going to harm the patient more. So the evidences are more and more compelling and coming from every different part of the world. I would ask you guys to look into, and you can see that is definitely you have to follow the salvage the patient, right? Assess and treat cause of instability, use echocardiography whenever it is required, have your limits and targets, right? So it has to be mutually exclusive. Optimize your therapy, but once your patient is stabilized, right, you go for a de-escalation. So that's where you can adopt a conservative or a restrictive therapy. So the key points are IV fluid administration is one of the most, if not the most common intervention in acute and critical care medicine. But much of the physiological theory on practice has been flawed. Go and have a look into it, the physiological rationale and basis of your thought process. IV fluids were established in clinical practice, licensed for use without robust investigations of their efficacy and safety. Although large, high-quality investigator-initiated trials have now provided such data related to its use, dose, duration, and evacuation. Crystalloid fluids should be used for first-line therapy in most patients. Buffered salt solution seems to offer benefits over normal saline and is now the preferred choice, provided the cost is not an issue. Albumin might be beneficial with patients with sepsis, cirrhosis, or infections, but albumin in hypotonic carrier fluid is contraindicated in patients with acute traumatic brain injury, strictly a no-no. Synthetic colloids, notably starch and gelatins, should not be used owing to their unacceptable safety profiles and lack of proven benefits, and strategies that restrict fluid administration might reduce morbidity and mortality, and larger trials are still needed to confirm this promising data itself. So now we know that less is more, and we more and more adapt the concept of minimalism, and that I would not giving you an advice, because I always advise people never to give an advice, but I will ask you to look for yourself and clear all your doubts. Thank you, and see you soon in person.
Thank you, Arindam sir, for such a wonderful lecture. And now, after listening to both the conventional view and the conservative approach to the fluid management, we need to have something which is in consensus. So for consensus, we have Dr. Manoj K. Singh, who is a critical care specialist at Apollo Hospital, Ahmedabad, and he's going to go for a consensus approach in fluid resuscitation. Over to you, Dr. Manoj.
Good morning, friends. Thanks, Srinivas, for giving me this opportunity to wind up a debate session. Although the crispiness of debate and the charm of Hyderabad is missed in an online platform, but I'm one of the very few lucky consultants who has almost appeared in all the editions of HIC. Thanks, Srinivas. It is like actually reading a critical care novel. Every year we evolve, every year you have given me a new task, and every year we have read and probably, hopefully, met all of your expectation. So my job is actually very simple, actually. Green, red, and blue, as you see. Conventional approach of fluid resuscitation has been spoken by Dr. Supradeep very well. And Arindam, our master blaster, has actually emphasized doubly by more slides, more time, and more data, telling that less is more. And here I am just sandwiched between the two breads, the green and the red, as blue, just telling you what the consensus is all about. See, for me, actually, there are a lot of challenges. And of course, you also will have tricky cases coming to you in your lifespan. So for me, if the pancreatitis was blue, where everything is so clear from day one, but what happened is when he develops an acute lung injury and high-grade fever on day 4, then blue is no longer blue. It may be little red, because I'm not sure, I probably might have to, give more. And if the same patient develops an acute abdominal compartment syndrome, he still can come back to green, as Dr. Arindam said. Sometimes gastroenteritis is a very clean subject. They're managed in ward. But what happens is, if he's found to have a case of cold mitral valve repair and on warfarin, and develops a coagulopathy because of sepsis on day 2, the case becomes very tricky. And conventionally, an elderly gentleman with 20% LV, moderate MR, comes to us with urosepsis on day one, very, very dehydrated, cold, clammy skin, So these are the areas where probably nothing works well, except wisdom, be on site, be on time, and keep an eye as a drug that it is IV fluid which is being given. It will be a double-edged sword, and it can actually cause harm rather than good. And it can cause good rather than harm when it is given judiciously. Similarly, my mixed feelings are with the current case. All such cases keep coming to us as intensive care. Sport potassium hemorrhage with acute kidney injury. What happens when she survives the surgery? The surgery, which is actually after delivery, that is C-section followed by obsterectomy and plus or minus the internal iliac artery repair, and develops anuria, and she has already received a massive transfusion. She is on dialysis daily and develops a new onset fever on day 5. So then there is nothing which is very clear, because those who made the fluids did not tell or did not get time to study individual complex scenarios. So life is always complex. It is not as easy as said by Dr. Supradeep or Dr. Arindam, or probably don't take my words also in the same color which I'm trying to show you. So all of us know that the intravascular volume has unstressed and stressed both chambers. The stress is the one which is returning the fluid back to the vascular system, and this is what happens when the compliance changes. So both the unstressed volume and the stress continue to dynamically change, and that also affects your plus or minuses of the fluid therapy. So with that, sit tight. There are so many lectures coming. We are only the second edition of this HICS8, I feel, the second talk in the day. So sit tight is the mnemonic. Again, a lot of mnemonics given by Arindam. So sit tight is a mnemonic which was published actually a few years back. So C means context, indication, targets, timing, amount of fluid, infusion strategy, very important, infusion strategy, type of fluid. In the area where we practice, generally everyone has a strategy of prescribing a fluid 100 ml per hour. I don't know where this number came from, as study volume is always 500 ml per for every case on ventilator. Respirator is always 18, and 100 ml per hour, I don't know where it has come from. It just comes and it is always hanged. And every nurse is very comfortable when fluid is written at 100 ml per hour. No one actually thinks about writing it as the N-acetylcysteine dose, which is given for paracetamol poisoning, like 150 ml per kg for 4 hours, 50 ml per subsequently. So such a prescription actually is what we are looking at. As intensive care community, the most sensitive community, the most actually worked committee for critical care patients, the most on-site patient-doctor relationship making community, we should be really now having individualized prescription in intensive care unit. The first thing after the targets, after the type of fluids you want to give, should be the strategy what you want to give the fluid over. So it should be prescribed like drugs, like a dose and a duration. It doesn't mean if the patient is on day 1 to day 5 as what I chose, those hypothetical cases, not hypothetical but real-time complex scenarios. And acceleration and deceleration speed as per need should be actively discussed, written, and actually the nursing heads should also be sensitized. If the fluid is written and not written, that prescription has to be audited, and always the clinician has to be asked back, sir, 500 mils are over, do you want to give more? So that proactive decision at the bedside should be actually provoked in all healthy intensive care units. As you see here, when you prescribe an antihypertensive medicine, always you tell the patient or the clinician or your pharmacist that this is the problem, hypertension. Here also you describe the problem that I am giving fluid for this, write it in the notes and specify the objective. The objective may be restoration of the absolute cause or the relative fluid deficit. Verify the suitability of drugs, what drugs you want to use. Write a prescription to start the drug. It should be written by medical doctor, verified by the pharmacist, blood bank or the registered nurse, and administered by the registered nurse. Monitor the therapeutic response, and it is again, as I said, a joint responsibility of yours and your team and the nursing person involved in the care. And there has to be an order written to discontinue. Order should be written by a medical doctor, administered by the registered nurse, and that is how a drug like IV fluid should be written in all the patients of intensive care unit. See this. So this is a very simple algorithm, just going step by step, because I'm just concluding both ways of Dr. Supradeep and Dr. Arindam. Which type of fluid? Because I have to arrive to a consensus. If you have to give high volume, you choose balanced crystalloid. If your chloride is more than 110, you use balanced crystalloid. If the patient is already hypoalbuminemic, consider albumin, especially the cirrhotics. Other cases, normal saline is actually good. With initial volume, obvious hypovolemia or losses, higher rate can be justified. High risk of fluid accumulation, as I told you, the patient with MBR coming with gastroenteritis and sepsis, you need to be very cautious. Other causes 10 mils per kg in 1 hour and then reassess. So they are saying 1 hour only. You don't need to write actually 100 ml per kg because the patient actually doesn't have weight even of 100 kgs. So that's what it is. How to assess the responsiveness? There are various tools. Patients on mechanical ventilation, you go by PPV or SVV. No mechanical ventilation, PLR and mini fluid challenge are more than enough. No cardiac output monitoring. You can have a trial volume challenge, the PLR, the mini fluid challenge, or the pulse pressure variation. High risk of fluid accumulation, never give repeated mini fluid challenges because, as you know, as very nicely said by Dr. Arindam, the reverse Starling equation also has to be taken into considering current era. If the patient is in prone position, the Trendelenburg maneuver or the end expiratory occlusion test can be seen as a subtle guide for fluid responsiveness. In other cases, PLR, mini fluid challenge, VT challenge, or the end expiratory occlusion should be practiced to assess the fluid responsiveness, and it should be written when you write the drug. You should also write as how you write noradrenaline prescription. According to MAP, you should write according to PPV, according to PLR, according to E-expo chest, or according to mini fluid challenge. You should write then and there only below the fluid column. Which criteria to decide not to give fluid? If you are managing a patient with ARDS, pulmonary artery occlusion pressure, lung water and permeability, the PF ratio, or the RV dilatation on the serial echo. Abdominal problem, development of intra-abdominal pressure should be the criteria not to give more fluid. In any case, cumulative fluid balance, again, it should not be done 8 to 8 a.m., which is being done traditionally in many intensive care units in India. You should actually do 4 hourly or 6 hourly because here fluid is really important aspect of the patient's dynamics and patient's outcome. And every organ, as very nicely said by Arindam, will respond to fluid overload in a very different way, and your Lasix will not work everywhere. Then comes CVP. So you should actually have your own signs where there has to be a big no. You should write, don't give IV fluid to this patient for whatever reasons the patient is in currently for the next 6 hours. Which are the therapeutic triggers? Outside the ICU, mean blood pressure is a good target. In the ICU, mean blood pressure above 75 to 80. Increase in cardiac output, mixed venous oxygen saturation, the PCO2 gap or the PCO2 by CO2 gap can be taken as a therapeutic target. That is enough. Now I'll stop the fluid. I will only give it as a food. So you sometimes give dextrose as fluid and you think that it is given as food. So remember, are you giving food or fluid is what you have to conclude. In hypertensive patients, the mean arterial pressure should be more than 80 to 85. And in any case, if there is poor capillary refill, mottling, urine output, lactate, these are the targets which you should continue to monitor. If you're targeting urine output, there is not a bad idea because it is very easily accessible and reproducible and easily monitored by the bedside nurse. Actually can be done every hourly rather than lactate doing every hourly. So whatever you are doing, you should actually clearly define the therapeutic endpoints. Then should fluid be removed? If the patient has been preload responsiveness showing this, do not remove the fluid. If there is no obvious accumulation, do not remove the fluid. If the patient is anuric or really there is no effect of the diuretics, do ultrafiltration. In other cases, yes, think about giving diuretics. So as said by Dr. Arindam, Rose, you actually can see where you gave extra fluid. So every step of resuscitation, optimization, stabilization, and evacuation, you should actually think about fluid as a drug and as a harm. So you can actually see every 4 to 6 hourly, what are you doing? If the resuscitation has ended, actually it is like code blue. If the CPR is ended, you actually wait for other things. You go on something else. You don't do CPR. So resuscitation is as sensitive as doing CPR. If the fluid is not required, you stop the CPR. That means you just stop the fluid. But by mistake, if it is still continuing in optimization, you actually have to slow it down. And when the patient is stabilized, just switch to antral feeding. And hardly a great intensive care unit, which we are actually looking forward, all of you as students and as colleagues, to look forward that we don't even actually end to actually even think about evacuation, because that the nature only has to evacuate. You don't actually need to remove by giving extra diuretics or doing ultrafiltration. If you've already taken care of the CPR well, and within, as I said, within 5 minutes of CPR, here it should be 5 hours of CPR. 5 hours of resuscitation is more than enough for actually maintaining the optimization. So as said by Sir William Brooke in 1831, when he actually designed and he actually invented the fluid when there was a cholera outbreak, what he said is the indications of cure are 2 in number. First, to restore the blood to its natural specific gravity. Second, to restore its deficit saline matters. So the first of this can only be effected by absorption, by imbibition, or by injection of aqueous fluid into the veins. So this was the beginning of IV fluid in the world, almost close to 200 years back. But what are we here for? If you see in all the prescriptions of day one of all the patients coming to the intensive care unit, except a pure MI case, all of us actually have a very, very knee-jerk response of prescribing IV fluid. It is like going to a general practitioner. We call it Khatline Batla. If you've got a bed in the hospital, you will definitely get an IV fluid. So please don't practice the Khatline Batla style. You actually think about what you are doing. If resuscitation is used, you actually have to end it like CPR. If it is given as a food, you actually continue parenteral till the enteral takes over. And remember, IV fluid is always a bridge. It's like ECMO. It's a bridge until a definite control of patient source for whatever reasons you are giving. Hemorrhagic shock, hypovolemic shock, septic shock. So fluid is only a bridge. It's not the therapy. It's not the boom. It's not the magic wand. It's a bridge until definitive control of patient source. So the need of fluid is sorted out. So with that, I thank you all. Thank you, organizers, and have a great day. Thank you.
It has been an exhaustive and a detailed discussion about the fluids, both the conventional approach, conservative approach, and the consensus approach. And I thank all 3 of the faculty, Dr. Supradeep, Dr. Arindam, and Dr. Manoj, for such a nice and elaborate discussion about the IV fluids. We don't have any questions on this. So we'll move on to the further next discussion, which is by Dr. Dhruva Chaudhary on how to optimize monitoring in ARDS. So ARDS has been one of the most important clinical situations which we feel on see on day-to-day basis in our ICUs, and monitoring is also very important aspect of that. Professor Dhruva Chaudhary, who is senior professor and head of the PGIMS Rohtak, is going to enlighten us on this topic. Welcome, Dr. Dhruva Chaudhary.
Good noon, my dear friends. Today, I shall be discussing regarding the optimization of monitoring in ARDS. It's a big topic, but I will try to cover it up over next half an hour, touching the basic principles of monitoring, which we must do in ARDS to provide safe ventilation. First and foremost, all of us know, but I think it's always important to re-emphasize what is ARDS. It is acute respiratory distress syndrome. And we know 3 things are extremely important: timing, imaging, and origin of edema. So within 1 week of known clinical insult to new or worsening symptoms, chest imaging, if you see a new bilateral opacities which can't be explained by effusion, collapse, or nodules, and origin of edema, respiratory failure, which cannot be explained by cardiac failure, fluid overload. What we have done in boiling is that it should be inability of the persons to maintain oxygenation at a PEEP of 5 centimeters. In fact, when I was doing my senior residency, my boss used to teach us that oxygen-resistant hypoxemia is ARDS. Over a period of time, we are seeing certain things which have happened. By and large, we are looking at it in terms of its severity in the classification of the oxygenation. Earlier, we used to take ARDS, which was the severest form of acute lung injury, and we used to define as ALI ARDS. And by and large, things in terms of quantification have remained the same. But now we have started saying is mild ARDS, moderate ARDS, and severe ARDS. And again, we look at the oxygenation, and the oxygenation in this, we look at it, arterial oxygenation, when it is divided by a fraction of oxygen given. If it is between 200 to 300 millimeters with the PEEP or CPAP of more than 5 centimeters, we say mild. If it is between 100 to, when it is between 200 to 100 to 200, then it is moderate, and severest form is less than or equal to 100 millimeters. But by and large, most of the ARDS, when they are having less than 200 or even 150, they tend to come into the category of severe, and less than 10, from practical purposes, will be of the severest form. But all this required blood gas monitoring. Somewhere in 2016, we saw a study being done in Africa to define ARDS more precisely in the non-invasive fashion. And that is what is called as the Kigali modification of boiling area. Everything rest is same except for 2 things. We don't take anything PEEP. It's actually day-to-day clinical practice. And during period of COVID, all of us used to the maximum utility. If we find out that SpO2 and FiO2 ratio, that means there we were leading and we were taking up oxygen saturation, pulse arterial, which was taken by invasive mean. Here we are looking at a pulse oximetry, which gives us the saturation, and it can also set the ball rolling how we should do monitoring, because today emphasis is less is more, and see what intervention should be done depending upon the monitoring, because that is the key on the basis of which we decide whether we need to increase or whether we are giving adequate ventilation, and whether the patient having adequate oxygenation without its or their adverse effects. So whenever you take any patients of hypoxemic respiratory failure, ARDS is a dominant cause of it besides others. There have been certain rules which have been set very clearly. All of you are very well aware about it. And first and foremost, which we know since ARDS net trial, is your tidal volume 6 to 8 liters per kilogram of ideal body weight. The formulas are there which are different for men and women. Also, it is important is that we have started realizing is that more may not be good. Therefore, an optimal oxygenation is somewhere we take between 55 to 80 millimeters, or we are extrapolating it to a saturation of 88 to 95%. When we are putting the normal ventilation is negative, but here we are putting the air inside through a positive pressure, so it has a potential to cause damage. Therefore, or cause a volume trauma, like if you are putting something in the tube, if you give too much, it can burst. Therefore, a safety check has been put into it by putting it up that if you are finding plateau pressures, which we see on the pressure time curves and in the volume control board, it should be 30 millimeters, 30 centimeters of water or less. When you're ventilating, additional thing is the carbon dioxide. Now, this carbon dioxide moves in and out and is an asset. And we all know that respiratory system is an important part of maintaining homeostasis in blood gas or the metabolic environment of the body. Therefore, the pH goal should be stay between 7.3 to 7.45. So certain acceptable amount of acidemia and certain acceptable amount of alkalosis is accepted, because if they go beyond this limit, they have the potential to cause alteration in homeostasis, leading on to cardiac dysrhythmias, and patients can die. Also, at the same time, when you're looking at the tidal volume, you need to give adequate space. We all know that these patients have a reduced compliance. Therefore, they have a hypoxemia in this setting leads to a very high drive. Therefore, when you're taking these patients on ventilator, adequate amount of respiratory rate needs to be put into it so that it goes more with the patient needs and requirement, and patient is not struggling with the ventilator. One of the fundamentals in the mechanical ventilation is there are two pumps functioning. One is that of patient, and second, what we have put artificially, and they need to sing the song in synchrony. If they don't do it, you can land up with the trouble, and there can be a lot of challenges. This is the standard management of ARDS, which I have taken from Annals of Intensive Care, published in 2019. And in the step letter fashion, if you will see it, that as the severity goes up, that we define by the PF ratios, that is PF to FA2 ratios. If that is less than 200, you look at a level of 2-3 things are happening at this point of time. You have to start invasive mechanical ventilation with sedation in intensive care. And we're trying to do and keep the tidal volumes low, starting from 8, keeping between 6 and 8. We also try to look at it, the pressure pressures, as I said, trying to keep it less than 30 centimeters and PEEP more than 5 centimeters so that adequate oxygenation is there, and keep on checking for hypercapnia, which, as I said, carbon dioxide tells us about the ventilation. And if you don't have and also is an acid, therefore you can cause acidemia if there is an alveolar hyperventilation is there. As the worsening of oxygenation is there, we start using more levels of PEEP, and sometimes the drive is so much that in order to cover it up, we also tend to give these patients neuromuscular blockage. And obviously the severest form which is not responding, there is a hypoxemia, hypercapnia. You start thinking in terms of veno-venous ECMOs. What is important is that there is an upgradation depending upon the severity. How we decide that this is a severity, that is where the role of monitoring is there. And also we need to see that we must keep it in mind that disease is in somebody, and that is called a patient. And if we are increasing or decreasing or manipulating the normal physiology or the maladaptive responses, then probably we need to also to see that there is a safety. Whenever there is an illness, you will find an adaptation, physiological, which must not be touched upon with. But when a maladaptation is there, and here in this case, we are seeing maladaptation, and the intervention which we are doing is trying to bring that maladaptation and give time to the tissue to the heal. But as you are also keep on putting the volumes inside of the positive pressure instead of the negative pressure, it itself has the potential of exacerbating the injury. Therefore, it is very important for us when we are doing, we need to balance between the risk benefit. Only then we shall be able to achieve our objectives and patients can be safe. In the meanwhile, we keep on trying to find out the cause of ARDS because it's a syndrome which has got clinical features and some physiological consequences. But what has caused it is important because definitive treatment besides managing ARDS comes from the disease which has caused it. Therefore, when you look at it, I am very sure it is clear to all of you. When we talk in terms of monitoring in ARDS, it primarily means that we are looking at it as it is a refractory hypoxemia, or as I said and started, my professor used to say, it is an oxygen-resistant hypoxemia. Therefore, the most important parameter is oxygenation. Therefore, you need to look at various indices of oxygenation, which we manage in these cases. And at the same time, as a risk-benefit ratio, we must not cause ventilator or induce ventilator-associated lung injuries. You may call it as villi or vali, whatever the name you want. And these two things are important. And at the same time, when you are giving it up, this lung is also much more prone to outside influences, including oxygen, which is a drug and should be treated because it has been found that it may cause or promote fibroproliferative and oxygen toxicity in this particular group of patients, much more than the patients who have a normal lung. So when you talk in terms of basic monitoring, we talk in terms of oxygenation, we talk in terms of ventilation. And for me, what is very important as a clinician, beside the machine is the clinical. So it's a combination of these three things which decides. when you talk in terms of oxygenation, simplest parameter, as the Kigali modification says, is a pulse oximetry. It is a non-invasive tool, and we try to keep it between 88 to 95. And whenever we do any intervention in ARDS, it gives us a fairly good amount of idea whether the intervention is successful or is a failure. The definitive answer comes to us from the blood gases, which gives us two information. One, metabolic, that is whether the ventilation is adequate or not. In that context, we get pH as well as carbon dioxide. On the other hand, it also gives oxygenation parameter, and we can calculate alveolar oxygen gradient. Is it increasing or going up or not? And it also gives us an invasive oximetry, which can sometimes be great help. And we try to look at saturation gaps, which tends to be less than 5%. That means things are fine. So it is important. It can also point to us if somebody is not improving hypoxemia, whether there is some underlying additional toxicity or not. And third, which is very vital for us today, nowadays, is monitoring respiratory mechanics. Quite a few ventilations today are dependent on the respiratory mechanics, which we need to monitor invasively or non-invasively. And some of the ventilators inherent in their algorithms or the AI, they are using it up, like end expiratory lung volumes, or you may also put it up as a functional residual capacity, as in GE ventilator. But for me, most important thing is the clinical parameter, which tells us whether patient is being ventilated adequately or not. So in the clinical examination, it is very important. Every day you look for the discomfort, agitation, somnolence, whether person is fighting with the ventilator or not, and whether there is an abdominal paradox or not. And obviously, it is equally important to know cardiopulmonary effect, that is the heart rate, blood pressure, and obviously, when the person is on ventilator, you look at the respiratory rate, how much, at what rate it is there, and there is a synchronization is there between the ventilator or not, or the person, as I said earlier, fighting with the ventilator. So continuously keep on monitoring and reassessing the patient. So it is the patient, ventilator, monitor, blood gas. That's how we go up. But BGA, to an extent nowadays, is being replaced by more of a non-invasive ventilation. And one of the most important parameters in those happens to be capnometry and pulse oximetry. When the patient is on ventilator, tendency is to monitor volume, pressure, rate, saturation, as I said, that we do with the pulse oximetry. Intermittently, if you change parameters or there's a deterioration and things are not clear, or there is a hemodynamic challenges because of which pulse oximetry is not doing well, we need to have blood gases. And also hemodynamic consequences can be in terms of low blood pressure, and lastly, patient comfort and synchronization. Because there are two pumps, they need to work in tandem, in togetherness, in coordination. Otherwise, we can have a challenge. This is all of you know, the peak pressure, the plateau pressure. The peak pressure tells us the total pressure in it. It includes the airway pressure and the plateau pressures. And plateau pressure, when we look it up, it taken as a surrogate for alveolar pressure. And we all know that in patients of ARDS, it is the diseases in the alveoli. Therefore, it tends to go up in these patients. Another parameter which we commonly use and discuss in the patients is a PEEP, which is a positive end expiratory pressure. Instead of touching the baseline, it touch it up, and we create a new baseline above which it is there. So it tends to help and improve oxygenation and prevent alveolar collapse at the end of expiration, which is the resting position of the respiratory system. In this condition, what we see, there is a decrease in the compliance or increase in the elastance. As a matter of fact, compliance and elastance are inverse to each other. If compliance is more, then you will see elastance is less. If elastance is high, compliance will be low. So here you will see elastance is high and compliance is low. So the pressure goes up, but the difference between the P peak and P plat is not high. That means this patient does not have too high airway pressure, which is a normal pressure. Whereas in obstructive airway disease, it is the pressure difference between peak airway and your blood pressure, which tells us airway pressure and can guide the monitoring. Here it is a P plat, which is a sacrosanct for us to ensure safe delivery of gas or the pressure to the patients. And we can calculate on the bedside the static compliance, which is simply VT, VP, and in this case, we call as a static compliance is the PEEP light minus PEEP. When we didn't have these monitors or monitoring devices or the curves in ventilators on the bedside, we used to calculate. So it is a delta, it is the tidal volume delivered by the pressure which is there applied, because PEEP is the baseline, plant is one which we are monitoring. Hence, you can calculate the static compliance on the bedside. When you're looking at an oxygenation, my dear friends, you look at serial arterial blood samples to assess partial pressure of oxygen. Similarly, you can also take as SpO2. We take universally, in these cases, non-invasive targeting SpO2, as I said before. However, what we are seeing is today, a lot of intervention have started coming up. So what we find up is that the patient is a hypoxemia and has been put on the, and has come to us, it is fitting with the mild to moderate one. Beyond PA to FiO2 ratio is more than 170. If you find there is no accessory muscle of respiration is working clinically, that means work of breathing is not very high. So you take these patients today on high flow nasal cannula, and they are monitored their oxygenation by ROX index, which is again tells us a non-invasive way of SpO2 divided by FiO2, and the denominator here comes up the respiratory rate. Presumption is that as the respiratory failure settles down, the respiratory rate will also settle down, and oxygenation will improve. And as the oxygenation failure is there, there will be a drive, increased respiratory drive because of hypoxemia. And what we realize is when you start with a high flow nasal cannula, you need to monitor ROX index. Easy to calculate is more than 5. Routine we have been saying is 4.8, but it is far easier to calculate. If answer is yes, you continue monitoring in terms of heart rate, respiratory rate, and oxygenation parameters. And also the respiratory muscles, what is the work of breathing. And if it keeps on doing, you do it. So keep on monitoring every 2 to 4 hours. But if you find there is an increased requirement of flow or there is an increased work of breathing, if there is a high requirement of oxygenation with increased work of breathing, it is better to shift over to NAV than simply keeping on high flow nasal cannula. 1 point. Second point of importance is don't unnecessarily prolong because mortality is there. One way is to say is that probably they screened out the people who probably doesn't require invasive ventilation. And what our data from our institution and also the literature shows that if you go beyond 1 to 4 hours of it and the patient is not responding, mortality could be as high as 3/4 in these cases. Therefore, it is better if they don't work, switch over early to invasive ventilation. But these are the parameters which we monitor when patient is on high flow nasal cannula, besides clinical monitoring, where we need to look at it, as I said, work of breathing, which in terms of how accessory muscles are working. When the patient is on the ventilator, targets, again, I said before, also repeating again, is that saturation is 88 to 95. Relatively higher we keep up, somebody has a cardiac issues, or if somebody has a CNS issue. Otherwise, around 92 is good enough. If person has also underlying chronic lung disease, lower the better it is. And obviously, we need to minimum use of PEEP, and obviously incremental FiO2 PEEP combinations are required to achieve adequate goals of ventilation. That means oxygenation in these cases. And commonly, we tend to follow ARDS net trial, FiO2 PEEP, the tables, and they have been found to be useful. But what we are looking at is that higher PEEP and lower FiO2 is far more effective, and we tend to follow it up. So whenever we start patients on our ventilators of ARDS, we start with 100% oxygen and PEEP, and then we titrate PEEP, because aim is that within 24 hours, we should be able to come to FiO2 of 0.6, that is 60% or less. Looking at it, it may not cause aggravation of underlying acute lung injury or ARDS. But there are different ways of PEEP which we decide depending upon the response of the patient on ventilator. And again, when you start looking at it, we have talked about what level of oxygenation we need to keep it up. When you see it here, what they have found it up, that liberal oxygen and conservative oxygenation targets were kept up when patient was put on invasive mechanical ventilation. And they found out there was hardly any difference between conservative oxygenation or liberal oxygenation. But they did find some evidence of mesenteric ischemic. But the problem is that in these cases, most of the patients were elderly. Therefore, as I said, if there is an evidence to suggest ischemia of any organ, or you need to have a neurological injury, then probably it is better to have a relatively higher targets. So when you're monitoring, I would like to go for 94 or 95%. But if it is everything is fine, then I would like to go for the as low as possible. Then when you start, this is the oxygenation status, we are looking at it. There are certain other indices which are used for oxygenation we shall be discussing when we shall be talking about PEEP, and one of them is an oxygenation indices. And there you will say oxygen index and oxygen saturation index. I shall be discussing more about it there. But what it means is it is a integral index of multiple parameters, not only oxygenation, but it also takes in account the oxygenation delivery, so that we exactly know whether the cardiac and the respiratory system are working well or not. Before we go up, let's start looking at the blood pressures which we talk. This, I said, we need to keep it at 30 centimeter. From where this magic number has come? This magic number has come up because transpulmonary pressures which are required in most of the patient should be less than 30 centimeter, because hyperinflation is at the upper end. And we try to keep, when you ventilate it, you try to keep optimally between 26 to 28 centimeters of water. And on the basis of that, we decide. So whenever if there is a marked reduction in compliance, you will see blood pressure also rising up. And when they rise it up, and you have to give more pressure. But the caveat there is, if somebody has a restrictive lung disease, or somebody has a restrictive chest wall disease, or has somewhere ascites, etc., this may not hold true, or have a massive effusion where the compliance of the chest wall or the surroundings may come into play. Then we need to probably go for the different mechanism. But for all practical purposes, this is the safety valve for us. So when you find that you have to reduce ultra low volumes, then probably you will see that CO2 goes up. When CO2 goes up, you will also see fluctuations may occur tidal breath to tidal breath. But remember one thing, by and large, usually it stays stable. But at the low tidal volume, you may have more challenges, and acidosis is there. So try to keep pH above 7.2 at least, preferably somewhere around about 7.3. And this also fits with the concept of permissive hypercapnia. Now the question is, when you're talking about it, oxygenation, how you look into it. The oxygenation indices, when you look at the PEEP plate also, and you have to optimize this PEEP so that this plateau pressure is also not breached and oxygenation is not. So what is the optimal PEEP? It could be different for different people. Therefore, one thing cannot be attached. So it becomes more personalized, most individualized, but the methods we need to know how to go ahead with it. Now, also when you're doing the PEEP, it can also have an increased afterload effect on the right ventricle. Therefore, for us, the monitoring of a cardiac function is not only of the left side, the stroke volumes, but equally important when you are monitoring these patients is to look at the right ventricle, and right ventricle dysfunction, if occurs, patients can land up with a big trouble. Now, optimizing PEEP, when you are looking at the monitoring, we look at it, oxygenation, PEEP Pfeiffer table. I have already talked about ARDS net protocol and also talked about the targets of oxygenation. Equally important, we have talked about the basics of compliance. There are another 2 or 3 terms which you are looking at it: driving pressures, pressure volume curve, stress index, and esophageal manometry. Again, esophageal manometry is important to tell us about the driving pressure and transpulmonary pressures, and their esophageal manometry is essential to monitor transpulmonary pressure. But clinical data shows that if you are looking at the driving pressures and you are looking at the esophageal manometry, calculated transpulmonary pressure based driving pressures, that is of the respiratory system versus lung, there is no difference, and therefore you can use roughly in most of the patients we called as driving pressure for the respiratory system. Imaging is coming in a big way, especially EIT, sonography, and thoracic CT scanning. EIT is a very expensive device. Commonly, we have started looking at sonography. Now, this is again optimum beast when you start looking at an oxygenation indices. That is what I was talking about. You keep on increasing the PEEP and you look at an oxygenation with the hemodynamic parameters. If you look at partial pressures of oxygen with MAP, then we look at it, yes, it is probably, or we are looking at indexes, you see both we are looking mean arterial pressures and partial pressure of oxygen. So we have hemodynamic parameters, or this is called as oxygenation index. But instead of PO2, when you use SpO2 with a mean arterial pressure, this is a non-invasive mean, and you can calculate. And we all know that this is what we are looking at it. So we are looking at optimal oxygenation with optimal hemodynamics, and this can give us a fair amount of an idea on the bedside. So whenever the patient of an ARDS comes up, this is what we commonly use our intensive care units, that how much patient hemodynamics is there and how much oxygenation is there. And when you take a multiply, that can give us a fair amount of idea. So continuous measurement helps in selecting optimum PEEP as well as recruitability. So when you look and go up, doesn't mean that the PEEP which has given you the highest oxygen is the right parameter. There you need to see hemodynamics also should be maintained so that other organ systems, they don't suffer. Now, another thing which we are very fond of talking about is the recruitment maneuver. This again depends upon poor oxygenation. If your oxygenation is adequate, you don't need it. But when you need it, under these, if extensive damage is there, open lung concept is that you keep the lung open and keep them open. Earlier we talked about baby lung concept, but here when we are monitoring, in order to ensure that there is no recruitment and decruitment injuries leading on to villi, and hence on the basis of this, we take care of it, that once we have opened the lung which has collapsed, it should stay open, and that's what the PEEP does. Now, what are the prerequisites? So what you monitor? You monitor in these cases hemodynamic stability. You also monitor that there is no pneumothorax. So you look at it, the trends on the ventilator, what is happening to PEEP peak and PEEP plate, are they moving? Have they gone up together? You also know that oral air cavity are fine, there are no cuff leak, and patient is paralyzed. So the moment you do paralyze, more importance or more onus is on you that safety measures are there. If you have a CT, it can give you an idea that there is a high lung recruitability. And if you have a low lung recruitability, you can see it is there. So the patchy one which we are seeing is much easily to expand. But when you are seeing, in this case, it's practically a collapsed one, it becomes very difficult and unilateral in these cases. And one of the best things is on the ventilator, you go and monitor it. And in the ventilator, if you look at two graphics, usually tools will be given whether in a Siemens ventilator, whether in a Bella Vista or Hamilton. And now also in Draeger also it has come up. You look at the two places, you lower inflection point, and then you take another cursor, you take it at the peak. If you're finding it up, and in these cases, the margin is more than 200 at 20 centimeters of water between the inspiratory and expiratory limb. There is always, this is a PV loop on the principles of hysteresis, expiratory loop, which is a level of dew recruitment, we see it here. The volume tends to be much higher. If you had a pressure of 20, if you find the difference between these two places where it is cutting is more than 200 ml, and then you probably chances are recruitability are much more. If it is 400 ml, it is excellent. But we look at LIP and we look at UIP, but when you see the midterm of the pressure 20 point, that is the key which is there on the PV loops. Next, we will see it up here is the methods of recruitment, though it is not part of it, but it is important when you're inflating it, you may not cause barotrauma to these patients. So when you give it 30 to 40 centimeters PEEP, or that is called a CPAP patient is paralyzed, you give, suddenly you take it up for 30 to 40 seconds. So 30 to 40 centimeters, 30 to 40 seconds. This is, there you need to monitor pressure, oxygenation, and hemodynamics. And setting a pressure volume curve are in the range which will help you up. So it is between the LIP and UIP, which is the straightened one, that will help you up. That is the place on which recruitability is there. So if it is a fat one, it tells you, yes, chances of recruitability are high. That's like what we are looking at it. LIP usually is not seen, but when it is seen nicely, it becomes much easier. Trials ART has shown it up that patients with acute lung recruitment and titrating positive, and in these cases, better recruitment has been, and when you find that lung have been more recruited and more PEEP has been used. Driving pressure is another one which we are calculating today, monitoring these patients. It simply means tidal volume divided by the compliance of the respiratory system. As we talked about earlier, the compliance is delta V by delta P. Here now the delta P comes up and you have a tidal volume divided by the compliance. And for this should be targeted between 13 to 15 centimeters, and it can help you in realizing the tidal volume. Now, when you talk in terms of driving pressures, it means it's a plateau pressure minus PEEP. In patients who are pressure controlled, usually we take the pressure control peak pressure minus PEEP. And when you say RS, it means of the respiratory system. It does not eliminate chest wall compliance, but when you do driving pressures of the lung, you need to calculate end inspiratory transpulmonary pressures and end expiratory transpulmonary pressure. That will give us the real reflection, but usually we don't use commonly. We use it when person are obese, there is a diffusion, or person has a restrictive disease where we are finding it up difficulty. For that, you need to use an you need to use esophageal balloon, which gives us the pressures equivalent considered to be to the pleura. That's what we are taking up in titrating patients. So it is very important for us to monitor these cases. So the transpulmonary pressure end expiratory, we take it up, PIP minus P pleura, which is P esophageal. Plat is P plat minus P esophageal, and end expiratory is P minus P esophageal. So usually we give a end expiratory maneuver. End of that, we look at it, what is the pressure. From that, we minus the P esophagus. And same way, at end of the expiration, whatever the PEEP is given, you look at it, and then you see what is the end expiratory pressures. The difference between these two tells us the driving pressures. And also we have to ensure when you're doing and monitoring these things, that end of expiratory, the end transpulmonary pressure should be 0 or positive. That's what we are seeing it in one of the ventilators of our department. We have done it up. Airway pressures, we are calculating P plat. This is esophageal pressure. This is transpulmonary pressures, which we calculate. The curve is the same as you see of the pressure time curve of routine volume. And here was the catheter is there, pre-transpulmonary pressure curve is coming to us. And that is the airway pressure is 10.1. And here esophageal pressure, if you see, is 6.4. Therefore, what we are finding it up is transpulmonary pressure at that area at end of inspiration is 3.7. On the other end, when you do it up here, you will find at end of expiration, the transpulmonary pressure is 12. Here you will see it is negative. That means lung is still not recruited. So by monitoring it on the ventilator, we are able to know what we are dealing with. The lung is adequately recruited or not. That's a PEEP 10. P esophageal is 17. So it's a negative minus 7.5, which is telling us it's a negative transpulmonary pressure. So you need to step up PEEP to get better oxygenation in this particular case. And usually it is seen commonly with a non-recruitable lung or people who have a thick chest wall. So setting PEEP, again, we have already started, is above 0 at the end of the expiration, and PEEP transpulmonary should be kept below 25 centimeter water. So what is by monitoring transpulmonary pressure in difficult cases, you can actually target your PEEP. So monitoring, advanced monitoring is essential in a certain number of cases. This is the data which is showing it up, and the studies which are showing it up, that you can actually reduce the mortality by using these techniques. So reduced physiological and alveolar with transpulmonary pressure guided strategy is the key. And this is the data which has come from PJ Chandigarh. Again, in the study, effect of titrating PEEP with an esophageal pressure guided strategy versus empirical have shown that that the technique is better. Standard care esophageal pressure monitoring is better than the standard of care and improves and tells us better about compliance and oxygenation. This is another study which is talking about driving pressure and survival in acute respiratory distress syndrome. And what we do and follow is in difficult patients, pressure guided management. So you monitor, you start with 6 to 8 ml kg, you measure DIP, and if you find driving pressure is less than 15 centimeter, we keep ventilatory parameter. If it goes very much high and we see compliance is reduced, which we calculate that happens in ARDS, we immediately further go down and go for recruitment maneuver and decremental PEEP titration to best. Or also we can use here the esophageal one, or we can go for prone positioning, and then we can do a neuromolecular blockage. So by simply looking at the bedside, the DP, if you monitor it properly, you can change your strategies. And when you have taken the patients on prone, please be careful and monitor clinically, increase intracranial pressures, intraocular pressures, and facial source. And patients also can have hemodynamic instability. So if it continues to be there, further decreasing extremely low, or you may have to consider ECMO in these cases. Capnography is again one part which we need to look at it. It also gives us an idea about ventilation. It is not a reliable estimate of arterial PCO2, but can help us in calculating dead space ventilation, which is most important. And we can actually, with the capnography things, we can do it. With ultra low tidal volumes, we are now seeing variations, which otherwise capnography was a very stable device. You can actually calculate the dead space. And we know if you can reduce the dead space, alveolar space is there. So tidal volume is dead space plus alveolar space. So if your dead space is more, it encroaches on alveolar space. So you can monitor dead space by looking at it Bohr equation, which is VdVt PaCO2 minus PeCO2 divided PaCO2. So this we calculate. Please do it. Make it a habit, routinely doing it, because it can tell us why carbon dioxide is going up or not. There will be a PaCO2 end tidal CO2 gap of 5 to 6 millimeters of mercury. But nevertheless, when you're going ultra low, you may have fluctuations in the level of capnometry and may not give you a right data at that point of time. And this is, as I already said, dead space reduction should be the aim target and can help you in optimizing the ventilatory care. This again is a paper which shows that by reducing the dead space, you can improve the, you can decrease the mortality and improve the outcome. This is again a study which shows minimal VdVt can be used for PEEP titration. So you have various ways which you can individualize in different goals. Imaging is becoming another important cause. You can do an ultrasonography by lung today, but you need an expertise. So what you see, you look at the pattern, keep protective ventilation, check hemodynamics. You can also do with the left ventricle stroke volume outputs. If person is stable hemodynamically, then you can go ahead further and find lung opening and closing pressure. You can easily do with the recruitment whether the lung, more air has started, dynamic air bronchogram, and the profile, which was of a consolidation, changing to more B profile, and when it will be good, it will shift over to A profile. So looking at the bedside posteriorly, when you look at the recruitment, it can really help you out. And also you can assess cardiac function. That's another idea with it. EIT is specifically with the Draeger ventilators, but this again, what is important is it does not assess aeration. It only covers frontal or dorsal slices, rest it will not be. It gives you a structure like this, that this is the lung ventilation, which is taking place. We used in a couple of patients when we had this machine. We're no longer using it, but it can help us. You look at it when you apply PEEP, it can tell you adequate ventilation has taken place, but it can help us whether the dorsal area has been ventilated or aerated or not. Again, people have tried to use it, but it's a difficult one. We don't follow it up. Should we consider personalized ventilation? It can only be considered if you monitor your patients carefully. If you are not, probably you may not be. So today we need to monitor tidal volume. We need to monitor driving and plateau pressures. And if need be, further you go for a further precise or personalized ventilation on transpulmonary pressures. Mechanical power I have not touched because that's still not possible on ventilators. You go when you go for the alveolar recruitment. Again, the bottom line is oxygenation and end-tidal CO2. Gas exchange, again, alveolar oxygen gradient will all tell us. And also look at this point of time, VdVt, which will help you up in looking at it and can look at oxygenation indices. Phenotypes, I'm not getting into it, but from the monitoring perspective, you can look at these parameters and you individualize the ventilation. And as the time is coming, it is the time for personalized medicine. Thank you very much to all of you for the patient listening and to the residents of my department for their valuable contribution. Thanks a lot.
Thank you, Dhruva Chaudhary, sir. It has been an excellent presentation, sir. It has covered a lot of queries in our mind, and thank you for that. There are a few questions for you which have been asked by the delegates, sir. The first question is that during the patient on HFNC, when you have use ROX index, how frequently you should monitor the ROX index, and if the ROX index is low, should you go for an NIV trial or should you go for intubation? So you're not audible, sir. You're not
audible now?
Yeah, now you're audible, sir.
Yeah, thank you so much. In fact, if you would have seen that graph carefully, everything is written there. On an average, we take it at 1 to 4 hours. When you take the patient on ventilator, on high flow nasal cannula, good time is to look at 1 hour, you look at 4 hours. And secondly, clinical monitoring is the key along with it, whether there is a sign of for work of breathing or not. That means whether intercostal muscles are working, recession is there or not. You have a sternocleidomastoid or you have a nasal flaring. If you have got work of breathing associated increase with hypoxemia, then non-invasive ventilation or CPAP is the choice. On the other hand, if you don't have only you have a tachypnea and hypoxemia, then we go with the high flow nasal cannulas. And usually we monitor 1 to 4 hourly. And if patient responds, then depending upon the response, it can be 2 to 4 hours. There can be no rule of thumb. But nevertheless, by and large, it is 1 to 4 hours, maximum up to 6 hours. Patient improves, then you go and extend it up. So it's a constant process. It's not one-time fixed thing. It has to be done. But for a beginner or as an average, first 1 hour, then 4 hours.
Further ask, sir, if the ROX index is low and the patient is having distress, should you go for NIV or should you go for intubation?
You see, in higher one is the more indicative of when you start looking at it, when it starts going up. If you find there's no much work of breathing, but patient condition is deteriorated, I will rather shift over to, depending upon the underlying condition, intubate and ventilate rather than other way out. It's much safer to tube the patient early because this sort of a problem has come up because of COVID. Later on, people realize that there's no difference between two in terms of
the same strategy in our unit also, so we agree to it completely. Another question is that what is the role of mechanical power monitoring in ARDS ventilation? This has been asked by one of the delegates.
I had written about it, but as of today, we are not monitoring it because there is no ventilator which is telling up. But gradually, in terms of safe ventilation, it is going to be part of it. As of today, answer is no. We are still understanding it and putting into it, but from the monitoring perspective, probably it does not add too much of it. It's a theoretical concept which has come up, which has a very relevance. So answer as of today in 2023 is no, but I do expect the next year or two be a part and parcel of it as we used to see the driving pressures, etc. The names have been given. Otherwise, it's not that if you look at the compliance curve, we were written P flat minus P, which we're looking at the delta P. So looking at the same way the mechanical power. So probably once this will become part and parcel of algorithm, then it will be written, but not as of today. Any other questions? Hi, Ghanshyam.
Good afternoon, sir.
Good afternoon.
Mithilesh, any other questions?
Yes, sir wants to add something on esophageal pressure monitoring, sir. Something
Sir, there is one question, sir. There is one question. When to stop prone ventilation? What are the targets?
You see, we have been using very extensively now prone ventilation. We are not straight away going for the recruitment. Let me be honest, because prone ventilation itself is a recruitment matter. What we are finding is that if person continues to have higher requirement centimeters of water of PEEP and FiO2 is not coming down to, we are not able to reduce and compliance continues to be low, that is the time we switch over most of the time. And person needs to be hemodynamically stable. And if person is on inotropes, then requirement should be minimal, A. B, we also look at these patients must not have any intracranial pathology or should not have any evidence or incidence of glaucoma, etc. These are the few caveats which we take. Obviously, in pregnancy, it becomes difficult late pregnancy. So we don't. So these are the few contraindications, but with this, any refractive. And endpoint for us is requirement when you make them, when you flip them in a prone supine position, requirement continues to be low, then we don't go for it. And usually we are giving, am I audible?
Your voice is breaking, sir. Can you please repeat that?
Yeah, what I'm saying is when you flip the patients back into supine position, and if we record that the requirement is less than 0.6 or less, and the PEEP has stabilized, and then that is the time when we say, okay, we can hold on and wait for. If we don't find any response at that point of time, again, flip up. Initially, we used to give 16 to 18 hours, but with experience and confidence, now we started giving even up to 20 to 22 hours. But once in a 24-hour, we flip them back, see the response, and then take a call. Any other question, Ghanshyam? I hope the voice was clear.
Yes, sir. Yes.
I hope that answers it. Because ARDs, the domination is only two things: oxygenation, A, and then along with you see hemodynamics, because hemodynamics is important in terms of oxygen delivery. And the third thing is obviously the safe ventilation, that we don't cause a trouble. In fact, people are using it on ECMO. We are also had one patient with us who had developed pneumothorax. We still flipped it up, the PEEP levels.
So your thoughts on monitoring the right heart, especially in ARDs, monitoring the right heart, RB function. How
monitoring the right heart, again, it's not so easy, simple, because commonly we look at echocardiography, or we try to look at other pressures which are there, which don't make too much of a difference, because there are so many confounders in it. That's where the problem is. Major challenge comes up when you start, because hypoxemia plus PEEP combination together puts up the right ventricle hemodynamic. If we start finding that left is all right, other things are fine, then we look at it and they try to, like we are doing in right ventricle infarction, put a lot of fluid and along with inotropes. That's what we are doing. But as of now, on such high pressures, it is still a challenge. The only way we try to look at the RV is most of the time with an echocardiography on the bedside. We are not taking them for the cath or anything else, but this is what we do, and we all know that intrathoracic pressures have their own effects and challenges on there. And measuring the right heart from echo has its own challenges. LV is much easier, right ventricle, but yes, if it's too much dilated, not contractile, then we all see that there is a problem. And if we are finding that the blood pressure challenges are there, then we fluid plus along with it, we use the inotropes. Do you do any differently, or you do the same way?
No, sir. We rely heavily on the echo, bedside echo.
But
sir,
I put a lot of my effort on stethoscopes and other things also the whole time, adding up to the clinical monitoring, because it does help us. And I keep on telling my fellows and residents is, please keep on auscultating these patients, because sometimes I'm still a little old-timer, old-fashioned clinician. Enjoy that.
So thank you so much for joining us. We will take a small break of say 10 to 15 minutes. We have been online continuously since morning. So we'll give a 15 minutes break for lunch and rejoin at 1:30. Thank you so much.
Thanks, Mithilesh. Thanks, Ghanshyam.
Thank you for being with us. Thank you so much.
Healthcare is often provided in busy clinical scenarios where lives are at stake. Decisions are made in a rush. Reports are analyzed on the go. This is where we step in. We search for innovative solutions across clinical scenarios. By rebuilding connections between people, device, space.
Afternoon, sir. So we move on to the next session on end of life. My approach to end of life discussion by Dr. R.K. Mani. I welcome Mani, sir. You can please start, sir.
Yes. Of course, this is an unplugged session. Thank you very much for inviting me to HICS. Good afternoon, everyone. So this session is about how to approach an end-of-life discussion. Actually, an end-of-life discussion begins in the beginning, when the patient is transferred to the ICU. We have a meeting with the family, so-called multidisciplinary family meeting, which is the most crucial intervention actually concerning and not only end-of-life care, but also the overall care of a patient in the ICU. So within the first 24 to 48 hours, we have the meeting because you don't have a discussion starting with the situation of end of life. You have a discussion when you are introduced to the family, when you first evaluate the patient and then talk to the family. Why? Because this crucial intervention of communication is founded on building a rapport, building a relationship with the patient if that's possible, or of course with the family as it happens in most cases. Because we must remember that end-of-life care exemplifies the situation where all of the principles of ethics are laid out. And we've got to be really good at it. How you balance all the four principles of autonomy, beneficence, non-maleficence, and justice or fairness. And that, I said, is founded on mutual trust. And so when we start the conversation, of course, a few things are very important. When, what, and how, all these things are important. When I said as early as possible. What? Yes, factually you should be as accurate as possible. That comes with honesty, and honesty is hampered if you are on a self-defensive mode all the time. I think as a man of science and as a practitioner of a very humane activity, we shouldn't let excessive defense and self-preservation instinct to come in the conversation. Let's be honest with facts and convey it without ambiguity. And of course, there is an there is a huge element of uncertainty in ICU, which should also be conveyed as an uncertainty. You're not cocksure about anything, but you're not vague either. And we must convey kindly. Okay, that's very important. We talk about empathy, but I think conveying kindly means we even put harsh truths in a way that that empowers the family rather than sort of destroys their morale. If you understand what I mean. So what happens as we have a sequence of conversations? The picture emerges about what we expect. Prognostication is a very, very important part of the conversation. Obviously, every time you enter into a conversation with the family, first thing they ask you is, how is the patient? What are the prospects? Will he or she survive? Now, these are very common questions, so you can't escape prognostication. And it's the hardest thing to do. It's both a scientific activity and also a subjective activity. Right? Subjective and objective mix is there in prognostication. That's inevitable. Even in the days of so many prognostic scores that have emerged, not only general prognostic scores like Apache and so far, but also specific, disease-specific prognostic scores as for pneumonia or pancreatitis. And now with this artificial intelligence emerging, you might have scoring systems that utilize AI and maybe give you a more accurate picture. However, it's not all about these scores. It's about a composite impression you get. If you have seen the patient before, then all that has gone through, and all in the context of what interventions have already been made and the response thereof. We must understand that prognosis is a very important activity, and you do that within your team first. It's not enough to talk physiology. It's not enough to talk about the numbers that the monitors are giving you. But it's to understand what is the story picture that emerges, and that should be conveyed to the family as well. Don't keep it close to your chest. To convey that on a day-to-day basis, you build a rapport of trust, and the family thinks that you get a credible information from the doctor, not just plain information, but also the doctor's thoughts and interpretation. So that we must do. Prognosticate, and again, don't get the prognosis be hampered by instinct for self-preservation. Right? I must give the most gloomy picture so that I'm not caught out later and I'm not questioned for a so-called defeat on the patient. You see, the process is important. So we look at whether we are providing information honestly and kindly. You know what happens. You don't, in most cases of end-of-life care in the ICU, the outlook for curative treatment being dismal is not clear right from the beginning. It slowly, the picture emerges as your intent, your curative intent has not culminated in any sort of success. So there are scenarios which build up and then make you think whether this is going to work or not, or should I be thinking about palliative care. And this is not uncommon yet. Nearly a quarter of the patients in the ICU, as per surveys in Europe, particularly in Belgium, Ruth Byers et al. It reveals that about, the nurses say about 23% of patients are going nowhere, and we are giving excessive treatment. And more than that, over 27-28% of doctors say that. So that is a questionnaire-based survey which tells us that we are giving excessive treatment in quite a substantial proportion of patients. We know it, but we are not sharing it. So what are the scenarios or triggers which make you think like that? See, in 2005, the Indian Society of Critical Care Medicine came out with its first position paper on treatment limitation and applying palliative care. And we could sort of construct a flow chart of about 8 steps. So the first step was the getting a diagnostic, reasonable degree of certainty. You can't call it certainty, I mean a reasonable level of surety. And that you get by working at it, not just guesswork, obviously. You, through a process of reiteration, through a process of consultation within the team, within the intensive care team, across the intensive care to other specialties, and you might even consult with a family physician for background information. So that having accomplished, you get a reasonable level of the diagnosis and prognosis, the trajectory by watching the patient over a period of time. When you get that, and the scenarios, you have various end organ failures which have no answers, like organ transplantation is not feasible for one reason or the other, or declined, or various malignancies where the treatment options have run out, and where the post-cardiac arrest state and the M less than 2 after 3 days or 4 days, or you have the chronic altered states of consciousness coming in with one terminal illness or one serious life-threatening illness, like a demented patient or those with advanced brain syndromes, or catastrophic brain condition, trauma. So these are some of the conditions. Additionally, you can say where the family or the patient says, I don't want any further treatment. That very often happens. So you have to seriously consider whether that's in the best interest of the patient or not. Not that you don't value the autonomy, but you have to think for yourself as well. There's a beneficence obligation also. Then lastly, you take a step back from the foot of the bed and ask yourself, would I be surprised if this patient is not alive at the end of 6 months? Right? The surprise question, would I be surprised? So these are the scenarios which make you initiate an EOL discussion. When you start to think like that, you talk to your colleagues, and your colleagues, I mean, there is a reasonable concurrence within the team. Then the step is to share this with the family, the prognosis, what you think, where we are going, honestly and compassionately, and then take a feedback. So you see, 2 mnemonics are very important. The value mnemonic spikes. Value is, in one word, you value the patient, the family, as a person, not as a disease entity, not the family as a potential litigant, or the family as somebody who is going to create trouble for you, family who may not pay. Not these kinds of things, but valuing them as people, as persons, no matter which social class, no matter which religion or nationality or ethnicity. And spikes is you breaking barriers. Obviously, when you open up a conversation about a prognosis, it suggests that we don't have any curative options left. it does shake up the system. It's a very important conversation. I wouldn't call it breaking bad, because it's not necessarily bad news, but it's an essential conversation. It's something, because see, death in the ICU is not a defeat. You must understand. It's a culmination many times of a long struggle and to a well-deserved peace. Or it is the appropriate discussion for the situation. It's the most valuable discussion. So I would call it an essential conversation, where you have the right setting, and then how to do it. First, figure out what the family or the patient has understood. Many times you've been lecturing them day in, day out. And to be honest, only 10% penetrates, and maybe it's a garbled sort of song. Many times a garble, you're surprised. She said, you have given it all your energy, yet this is all they've got. So ask, tell, ask is, in a nutshell, the how of it. Ask, what have you understood, my friend, so far? And if you think he's got it all wrong or garbled, tell the facts, clarify. And this ask, tell, ask happens from day one, right? Conversation on day one, then day 3, day 4, by day 6, you're thinking perhaps it's UL. Ask, tell, ask is very important. Number 2, don't miss opportunities. Randall Curtis showed us back in, I think, 2003, through very elegantly done qualitative analysis of audio recordings of conversations between physicians and family, that we are missing great opportunities to trigger a conversation on palliative care. We miss opportunities to support emotional pain among families. We miss opportunities to reassure our support and non-abandonment. So we must remember that we must carry the results of these research into our daily discussion, that we take care to listen. There was another paper, qualitative research from the same team, McDonough et al., who showed that we hog the conversation, and you can't expect good family satisfaction. To allow them speech, hear them out, give 50%. It's fair, right? Of the time to hear out, even if it is irritating, even if it is digressing. I tell you, without patience, there is no good conversation. There is no great conversation. You're talking at each other. You're not really talking with each other. So we must remember these very important principles of soft skills. They are called, unfortunately, soft. They are very hard to acquire, hard to train, and very crucial in these. So I remind myself that to hold my breath and listen, and then seize the opportunities to get to understand the values and wishes of the patient, who can't convey directly, but you can assess that from the family. You would say that would take a long time. No, it doesn't. I think if we get better and better at these conversations, they take less and less time to get to the meat of the matter. You know that with any skill. No. To put a line in gets easier and easier, and quicker. Same with many surgeries. Same thing. If we build on the foundation of sound listening and grasping the facts about the person of the patient, then it gets deep. So you get an idea what, and this discussion on values also makes the family think. Right? What is ethically, what is morally the best thing to do for the patient? See, we have overemphasized the legality and the finances around it. So sorry to say, we missed the point. We must peg these discussions on values and what the person or the patient may opt for, right? And steer clear of finances for the moment. Because if we take the right decision, then we are fiscally also efficient. It is not the other way around. We talk finances first and say if the fellow can afford, then I will carry on. Otherwise, I'll stop. It doesn't make sense. That's immoral. That's not what a man of science should do. Particularly not a caregiver. A caregiver with a fiduciary responsibility will not do it at any circumstance. So I wouldn't talk finances. I wouldn't talk law at this stage. I would emphasize on what the person would want. Because the choice of palliative care is a choice. Okay? It is not imposed by definition. The curative treatment is not mandatory when those options are very few or extraordinary or not shown to be of benefit. So this is what a discussion with the family should open up the possibilities. What are the treatment options left? And the pros and cons of adopting them. And then also the option of not doing any intervention, right? We never mention that. We keep only talking about the escalation. We don't talk about the de-escalations in the same breath. We don't talk about the option of having no treatment, which is the honest truth in many circumstances. So I think these discussions are founded on honesty and sticking to the science of the matter, combining with the caregiver's instincts for kindness. So having done that, previously you had ensured that the team members have a consensus, team members have an understanding, and there is a coherence in what they say, and there is consistency in what they say from one conversation to another. There is a thread running through them, there is consistency. And all this should be reflected in the case notes. It's not important to have million forms and too many signatures. It's very important to have these conversations and discussions and decisions reflected in the case notes. Because transparency means honesty. Transparency means responsibility, accountability. So all this should be there for any physician or self-respecting physician, I would say. So you have had conversation and you arrived at a decision of these options of withdrawal, withholding, DNAR. DNAR is also a withholding option. DNAR, none of this is euthanasia. DNAR particularly is not equal to withdrawal, withholding. Euthanasia is about medical assistance in death. None of them is doing that. It's only a decision to omit interfering. Omission. A decision not to interfere with the natural process of dying which has already started due to some other cause. You are not doing it. This should be made clear. And these queries should be answered, addressed. Queries will be there from the patient's side on all this. Answer with care. Don't make it legal. Make it logical. And make it humane. Why we are doing. in the interest of the patient, in the interest of the family. This is why you take this decision. If there is any lack of understanding or there is no certainty, then wait. There's no tearing hurry to jump to these conclusions. Wait. Talk again tomorrow. Come back. Renegotiate. If it is very difficult for people to grasp withdrawal, for instance, take the simplest decision, which is DNAR. It's not going to work if we pump the chest. It's not going to work if we put a tube down the throat. All right. So these sort of decisions can be taken. It's not going to be useful to put the patient on a dialysis. But these sort of decisions can be taken. Now, withdrawal is not any way different ethically, morally, legally from withholding. This we must understand for ourselves, because both are from the same premise. They won't work. They're doing more harm than good. They are not in the patient's interest. Both are pegged on the same premise. So why should they be any different? It may appear, it may be perceived as something very proximate to death, withdrawal, and may look bad. Okay, they look like that. But then if you clarify the situation, withdrawal is more logical because it's not wasting any time. It is not making the death stretched out, which we don't want. The most important, there are 11 criteria for good death. I won't go into it. And they were constructed by a meta-analysis of reviews, meta-analysis, right? So out of which one of the 11 is very important is you don't stretch the dying process out. You don't impose burdens which are totally uncalled for, both from the scientific point of view and from the patient's wishes point of view. Nowadays, you can have an advance will, the penetration of which is negligible today in India, but one day it will happen that there will be an advance will which you must consult to get a direct view of what the patient wishes are. And if the patient has appointed a proxy, then we must engage with that proxy, because that is the instruction of the patient. So if you have a valid advance will, that becomes important. It doesn't matter whether it exists or not, you must talk with the family, construct a picture of what the person is and might opt for. Once you've got the decision made, withdrawal, withholding, or DNAR, and you have put them on paper, implement them. Don't make excuses for not implementing. And you're not honored your word. You're not honored the autonomy. Nor have you respected your own promise of beneficence and non-maleficence. So how do you do that? So many times people want to die at home, because that's also an important quality of dying. People want to, if families want that they would have their loved one die at home, enable it. See, when we talk to families, support their emotions, they become empowered. Speaking, telling them the truth about things empowers them. It doesn't agitate them. It may agitate them temporarily. But then if you stay the course, then the agitation transforms itself to empowerment. So don't be shy of talking frankly and then asking, as I said, ask, tell, ask at every point. And if their wishes are to take the patient home, enable it. For example, if there is a withdrawal decision to be made and the patient wants to go home, we must take the patient home, extubate at home. This is what I do. extubate at home with, of course, all the pre-medication, all the anticipatory sedation and analgesia. And then, of course, the formalities of death certificate. So that will complete the loop. If there is a withholding and then you send the patient home, ensure that the patient's comforts are looked after at home. Symptom management is paramount. So one must meticulously manage symptoms with pharmacological and non-pharmacological ways. And that's a lecture in itself. So you focus on that and put that all on discharge summary and be available to the family. You see, for any instructions or advice. I must say, if the family chooses to remain in the hospital, then again enable, right? Shifting the patient to a private room or a private space, relatively private space within the ICU. Checking on the patient every day, revealing non-abandonment principle, sitting with the family, listening to their queries is a very, very important part of it. Giving them a shoulder to cry on or putting an arm around when the reassurance is needed is extremely important. Family presence during withdrawal, well, if they prefer. But one thing very important, the consultant should be present. Or the head of the unit should be there, withdrawal procedure. It's extremely important during procedure not to have optimal symptom management and also reassurance to the family. Then post-death to be there to declare it to the family and to allow their emotions to play out. And post-bereavement care, all of it is important. If we practice what we are talking about today, the ethical environment will greatly improve, and with it, the caregiver wellness as well. Thank you very much for your patient hearing. Thank you, organizers.
Thank you so much, sir, for making such a difficult topic, making so simple, and it has got a lot of gray areas also. So thank you for making it very simple. There are a few questions from the delegates, sir. There is the first question is, if we tell that the patient's prognosis is not good and the patient is not likely to survive, and in that scenario, the family asks for removal of the endotracheal tube in the ICU itself, can we do that?
Yes, of course. See, what I'm saying is an end-of-life discussion and decision is based on choices, right? Not on imposition. There are some families who would like the patient to continue in the ICU. But then you can give them a relative privacy, ease the visitation, right? That's extremely important. I mean, it's stupid to curtail visitation in any case. An end-of-life situation, it is one of the most crucial modalities to reassure the family and to provide comfort care because it's good on both sides. Patients need the family needs the presence of patient. And you will see that the culture and the atmosphere in the ICU changes, right? There is no strife, there's no conflict, there's no anger displayed. So please do it. Don't worry about, see, majority of the time, who objects? It's a nurse who objects because ICU gets cluttered up or, they pick up some fault. That's less important. More important is transparency, which will allay fears, and then proximity to the patient, which will again reduce their suffering.
Another question which is there, sir, it is about the advanced will. Is it valid in India, sir?
Yes, it is extremely important for everybody to know that by the 2018 judgment, Common Cause versus the Union of India, advanced will, withdrawal, withholding decisions are constitutionally absolutely valid. People have no doubt on that score at all. It is It is valid. Now, by the new January 2023 judgment, the process has been simplified. Now it is very much doable. The process is another talk, so we won't get into that. But go and look it up. Process is extremely doable. In any case, what I believe is whatever I have been doing so far, whatever Ram has been doing so far, talking to the family, reducing it to simple sort of notes, taking a rational decision like that is enough. Actually, what the court has done is give it sort of a legal validity teeth as well. So I believe what is happening today on the legal side is only validating or sort of supporting what the ISCCM guidelines have been saying all along.
In case of disagreement between the other family members and the proxy, according to the advance will, whose decision should we accept, sir? If their majority is going in having a disagreement and the proxy is having disagreement with others, so in that situation, what should be our stance?
Proxy? Yeah, no, proxy is the most important, right? Proxy is the most important. And the proxy's, decision should be final.
Yes.
But best is to drive a consensus in the family. That's most of the time possible. Or you need to work at it. Sometimes you don't get a consensus right away. Then have the patience. Have the patience to wait. Waiting has solved a lot of my problems. Today somebody emphatically says this can't be done. 2 days back, the same person turns around and says, "Doctor, you said that the other day, let's pursue it." This happens because in the light of what is actually happening, our hearts and minds change.
So one question, sir, right? Among the siblings, if one of them is footing the bill and who wants end of life care, but the other siblings who are not footing the bill say continued therapy. Now, this conflict we have seen very often. How do we proceed in such situations?
No, you see, you must have consensus. We are not imposing anything on anybody. Just let us understand. If the family isn't ready, it's okay. The issue is these sort of situations are possible, but they are not the rule. Any kind of permutation combinations are possible. But you see, by and large, 80-90% you're able to implement these decisions. Look at the world data, right? 70 to 90% of deaths in America and Europe are through end-of-life decisions. At least 50% of these decisions are there in China or Singapore or in Southeast Asian countries. These decisions are being taken. So what are we talking about? We are talking about exceptions. Why don't we talk about the usual happening, average happening?
So one last question, sir, is asked by the delegate. If the patient comes with a traumatic brain injury and the brainstem reflexes are absent, after 24 hours, you do a apnea test, first and second, which are positive, and we proclaim that the patient is brain dead. But the family is still not, patient is on ventilator, family is still not accepting and they still want to continue the ventilator. In that situation, what should we do, sir?
You see, by and large, the problem is in communication. I've had neurologists writing in the notes, all the fulfilled criteria for brain death and saying prognosis extremely poor. No, it's ridiculous, isn't it? After death, you don't have a prognosis. You don't use the word death. You're ambiguous in what you're saying. And you tell the family there is 1% chance right after brain death, right? Any case, 1% chance is no chance. And you play up that 1% chance and you talk about miracles. Now, see, our words that we use are very, very thoughtless. When you say somebody is dead with conviction, no family is going to continue. Or at least 9 out of 10 won't continue. If the 10th one continues, give a time frame, okay? Give a time limit. Okay, we'll wait for 24 hours and we'll come back to you again. By and large, you win. You see, this whole of conversation between doctor and patient is one of negotiation. Right, and that you should be prepared to do. nothing is just black and white and clear and you say something and it's accepted. It doesn't happen even in non-EOL situations. So we must be good conversationalists and we should be persuasive, not coercive, persuasive.
Mithilesh will.
Okay.
Thank you so much
Thank you
for
so much,
being with
sir.
us and clarifying so many doubts. Just a minute, sir. There is one question. Just hold on. One delegate.
Oh, the legal process is too complex.
How do you talk?
You see, the legal process we have made complex because we don't want the ethical and the humane process. The ethical human process, which is the most natural, is what we must follow. We must know the legality and it needs now workable. Legal process needs now two panels. Okay, the primary board where you have 3 physicians. In any case, with every critical care, critically ill patient, you have 3 physicians involved. The intensivist, right, and 2 others. Okay, you do have specialists involved. You know, you have a neurologist or you have a cardiologist. So the 3 people, they talk amongst themselves and they get an idea that this is going nowhere. Then they put it to the family. Now, when there is a reasonable consensus between the 2, then you take it to a second board. Second board has 3 other physicians, one of whom should be empaneled by the chief medical officer. Now, this empaneled physician can be out of a permanent panel, right? You can get your CMO. I've already asked our CMO to empanel 5 or 6 physicians in the hospital. So we can keep it all in-house. All right. So if we do it a few times, it becomes easy. Just as we have a brain death committee where you have 5 or 6 physicians empaneled and 3 of them, they take a decision. So this is all doable, and we must do it. We must not shy away. What has happened for us is we have made a big barrier out of EOL decisions. We have made a big barrier out of ethical decisions, calling them legal. They are actually ethical decisions. And if we don't take ethical decisions, we are going to face serious consequences of conflict with families, violence for our junior doctors. So please, this is worth doing, extremely important, and if it is also socially very sensitive.
Thank you, sir.
Okay, thank you. I won't be able to listen to Ram. I'm going to take my round. Ram has already taken his round. So I will see the recording afterwards. Yeah. Okay, folks. See you.
Thank you very much.
All the best for the rest of the conference. Yeah.
Thank you, sir.
I would like to welcome Ram Rajgopalan sir for the second unplugged session, which is on the redefinition of the sepsis. It is a very important topic for all of us. I won't take any other time, and I would request Ram sir to start. Thank you, sir.
I've been asked to give this lecture on whether we need new definitions for sepsis. This is going to be an extempore lecture where I'm not allowed the privilege of using my slides as a memory guide. So as a consequence, I can be a little haphazard in my presentation. I hope you will understand that, but I hope I will be able to create a clear enough understanding of the topic that I will be dealing with. Okay, is there a need for us to redefine sepsis is the question that is being asked right now. And I think we need to understand the context, because basically in the last couple of decades or so, there have been multiple redefinitions of sepsis, starting from the SIRS criteria to the current sepsis 3 criteria. And the reasoning behind this is a little opaque. And my intention is to try and see if I can analyze this process and give you my own opinion about whether we need to be redefining sepsis in the first place. And if we are going to be redefining, do we need to use methods that will be very different from what we are at present? So with this in the background, let me just start off with at least an area that all of us will agree on. And that is, there is a big difference between infection and sepsis. Infection being a microbiological process is the existence of bacteria, or for that matter, microbes, at sites that are normally not colonized, and they need not necessarily be associated with any kind of a systemic response. Sepsis, on the other hand, is the systemic response that an infection provokes. And this is classically inflammatory. And this inflammation is probably going to be a very strong determinant of the outcome of the patient. So we all understand that infection by itself may not be as lethal as the development of sepsis. And we clearly understand the role of the inflammatory process in making this differentiation. The unfortunate problem about this is neither the definition of infection nor the differentiation of the inflammatory process in sepsis is easy for most of us as clinicians. The first thing we need to recognize is whenever we say infection, sometimes it is very obvious. We may have an abscess, we may have a pneumonia, which may be much easier to identify in the vast majority of patients. But sometimes the infections can be clearly occurred, and the process of identification may take more than a few days to achieve a certain degree of certainty. And even under those conditions, when we believe somebody has an infection, we are probably wrong close to 50% to a third of the times. And this has been documented repeatedly in critical care literature, where patients who have been admitted for sepsis ultimately do not have clinical signs of an infection at all. We don't have a gold standard at the present time to define infection. And the other side of it is also, we can't differentiate the inflammation in an appropriate way. The inflammation that you get from sepsis is not necessarily very distinct from the inflammation that you get from non-septic processes, such as, say, pancreatitis or burns. And as a consequence of this two factors, there is no gold standard definition for sepsis. So this actually makes a lot of concerns about the clinical definition that we are using, because we don't have a gold standard against which we can compare our definitions. And this is seriously a problem that we need to look at. How have the experts handled this? And I think we need to look at it by looking at the sepsis guidelines that have been developed over a period of time, and how have they come to the conclusion that the current sepsis 3 guidelines, the sepsis 3 definitions, are better than the older definitions. I think for this, we go back to the history, starting with Roger Bone's emphasis in 1992 that sepsis has to be differentiated from infection by the existence of a systemic inflammation. And he defined what he called the systemic inflammatory response based on reasonably logical kind of endpoints: an elevation of temperature, a change in your heart rate and respiratory rate, a change in your white count, classically being associated with an inflammatory pattern, was what he used as his definition of what he called the systemic inflammatory response syndrome. He was very clear in saying that it is not very different from non-infective etiologies, but this is when you have a clinical suspicion of an infection and you have a systemic inflammatory response, we shall call it sepsis. Now, this was challenged in 2017 by the individuals who developed the sepsis 3 guidelines, basically because they argued that when we differentiate a patient with an infection as having a systemic inflammatory response syndrome or not having a systemic inflammatory response syndrome, their outcomes are identical. It doesn't appear that the SIRS definition adds to any ability to make a distinction between the outcome or the survival of a patient with an infection. So their argument was that that is a very weak definition. On the other hand, they said, if we define sepsis on the basis of the development of organ system dysfunction, which they formalized with both the use of a SOPA score or a Q-SOPA score, they basically said that under these conditions, your ability to predict the survival is much better. Or in other words, a patient with an infection, with SIRS or without SIRS, has identical prognosis. But a patient with infection who has no organ system dysfunction or who has an organ system dysfunction is distinctly different. And as a consequence, the latter definition should be more appropriate. Now, this is a little bit of a twist, because when we said we don't have a gold standard for the definition, how do they make these comparisons? They make these comparisons on the basis of outcome or survival. And this is going to be a little crazy, because if you really look at it, if we use one definition of survival, that is the old sepsis criteria, the SIRS criteria, it is very likely that under those conditions, the patients may be identified early before they have organ system dysfunction and are likely to have reasonable prognosis. On the other hand, once you develop organ system dysfunction, it is extremely logical that you're going to expect to see a higher mortality. So what you are seeing in these two definitions is a matter of severity. You're identifying one group a little early and demonstrating no difference in their outcomes. In another group, you're identifying the patients much later, and because they have developed organ system dysfunction, you're noticing that they have a difference in their survival as well. And this is a very illogical kind of an approach to the differentiation. It is only logical that criteria using organ system dysfunction is likely to demonstrate a poorer outcome than one which does not. So I think we need to very clearly understand that this is a serious problem. But is this a problem that is, likely to affect outcomes? To me, I have a feeling that it will affect outcomes. If we use the old SIRS criteria, we are likely to pick up a large number of patients who have sepsis earlier. Of course, we will be picking up a large number of patients who also don't have sepsis, but our ability to approach these patients can be accelerated quite significantly. If, on the other hand, we waited for them to develop organ system dysfunction, as defined by the the sepsis 3 criteria, it is going to be a serious problem. There is going to be a delay, and it is likely that that would translate into a negative outcome by itself. And this raises a very strong concern about whether we should be using these criteria at all, considering that we have had no data demonstrating that the use of one or the other of these criteria makes a difference in terms of the treatment responses that patients will have. I think we need to be very cautious about saying that the sepsis 3 criteria are better indicators or better definitions of sepsis. They are better definitions of poor outcome, but not necessarily better definitions of sepsis itself. What we definitely need is a new set of criteria or definitions that can make a better judgment in terms of responses to therapies rather than looking at survival and outcome alone. So let's just look and say, if our current definitions are not adequate, what should we be using to solve this problem? I can take the impossible route and say, effectively, let's go and develop a gold standard, which means let's go and find a way in which we can identify an infection with 100% certainty long before you develop your cultures results or your microbiological reports that come much later. You need to find a systematic way in which you can identify infection. We tried it in the past. You use things like procalcitonin, which we know has clearly backfired. It doesn't identify the existence of an infection any better than a clinical judgment itself. Likewise, we can always argue that we can add other markers and maybe improve on this performance, but this is something that we need to wait for till we understand infection a little bit better. The other side of the equation is, can we make a differentiation in the inflammatory response that SIRS has, that sepsis has, in contrast to the inflammatory response that you will see in non-septic patients? Here again, identifying the marker has been at best elusive. So quite honestly, if you're going to try to look for a better gold standard, you're not likely to find it. So what can be the solution to the problem? I think what we need to do is step back to our earlier definition of sepsis and say, let's use the SIRS criteria to identify patients who are at a risk for sepsis. And then we try to identify subgroups within this patient who will respond differently to different therapies. And this is a process that has been quite aggressively being pursued right now. And that has been mainly through the development of what we will call as phenotypes. In the process of phenotyping, what we are trying to do is we take this heterogeneous group of patients who have sepsis and identify individuals with shared common characteristics. And we define these common patients with the shared characteristics as specific phenotypes. And then on the basis of their falling into one phenotype category or another, we can test the responses to therapy. And this has been done interestingly in simulation models, where sepsis has been divided into 4 phenotypes. Okay, and then the mix of the phenotypes has been altered in simulation models, and they have demonstrated that the dominance of one type of phenotype, the alpha phenotype, for instance, is associated with less of a response to EGDT, whereas the delta phenotype is associated with a better response to an early goal-directed therapy. And these kinds of processes, which we have derived in retrospect, are probably things that we need to start developing. Or in other words, my own feeling is if we need to redefine sepsis at this point in time, we need to define it not on the basis of the mortality of the individual, but on the basis of an old criterion where we are including a large number of patients and then subdividing them on the basis of their phenotypes so that we can make a differentiation in their outcomes. I hope this sort of gives you a reasonable understanding of what it is. To summarize, I basically said that our attempt to change the definitions by advancing from SOS criteria to organ dysfunction criteria are likely to be delaying our diagnosis of sepsis. Rather than delay the diagnosis, if we make an early diagnosis and then subdivide the patient on other characteristics such as phenotypes, we probably are likely to make big differences in the therapeutic outcomes of these patients. And that may be a much better way to define sepsis. Thank you for your attention.
Thank you, sir, for such a nice presentation. Can you please add a few more things that you wanted to say something more on this?
Before I listened to my own talk, I didn't see the recording in reasonably clear. Maybe I need to just emphasize a certain set of points. Am I audible? I hope I am.
Yes, sir.
Audible?
Yes, sir.
Okay. Yeah. No, I'm just so I just thought I'd emphasize a few points that we needed to very clearly identify. Whenever you say the diagnosis has to be confirmed by some kind of clinical criteria, that's what we're trying to do with the sepsis definitions. We need to have a gold standard for the diagnosis itself. Are you losing me intermittently?
Yeah. Briefly, sir. Briefly.
Okay. So we need to have a better gold standard of the definition of sepsis as we start with. And that, unfortunately, is a elusive kind of a point of view. So what these guys have done indirectly is to say, instead of using a better definition, if we can demonstrate a difference in outcome in one group versus another group, it may be a better definition. And let's use that as a substitute for the gold standard. And let's just use it. And that's basically what they've done when they developed the SIRS criteria and then migrated to the sepsis 3 criteria. That's effectively what they've done. And this is an unfortunate kind of a process. Remember, outcome or mortality is not just affected by the existence or the absence of sepsis, but it's also affected by a lot of extraneous factors, particularly the nature of the infection. So if you have somebody with a bad Acinetobacter infection, obviously these patients are more likely to die and independently. Okay, so that is going to be a very serious confounder of this entire hypothesis in the first place. Okay, likewise, it also depends what site of infection do you have, how the individual responds to it. There's going to be a huge heterogeneity in these patients who are in terms of the response. And by lumping them into a classic kind of a, do they have organ dysfunction or don't have organ dysfunction? And that's the way you're going to define sepsis. You're homogenizing this group excessively. that kind of homogenization is not going to result in a better identification of individuals who respond to a specific therapy or not. That is what we invested. So if we give EGDT to somebody, it's not like EGDT is an illogical process. It's a reasonably thought of physiological process, but we need to be able to identify the individuals who respond to it appropriately or not. And what we are recognizing is, again, I'm reiterating my talk from earlier today. We're talking about routine subgrouping of patients versus the use of phenotypes. This use of phenotypes seems to be a much better way of identifying groups of individuals with common shared characteristics and who probably will be very similar in terms of how they respond to specific therapies. And that is what I think we need to do. And along those lines, my reason for believing that we should be going back to the SIRS criteria is another kind of a very important basis. In the treatment of sepsis, the earlier we treat the sepsis, the more likely we're going to have a beneficial kind of an outcome. And it seems frankly illogical to extend to a point at which you're going to develop organ system dysfunction and then call it sepsis. And that is going to be definitely associated with a certain amount of delay and a certain amount of poor outcome that we need to avoid. So my argument was, go back to your old definition of sepsis 3 and then try to develop or at least approach these things with a phenotypic kind of way. We are far away from that. I'm not trying to say that we can do it tomorrow or a day after tomorrow. It clearly is going to require a lot of thought. And if somebody goes back again and tries to use these same definitions or try to tweak these definitions, I think it will be frankly illogical. So I think there is a definite need. We have not been able to, by the use of our current definitions, to make any kind of difference in outcomes. So the absence of that ability to do to make a difference in outcome is purely because we're dealing with an extremely heterogeneous kind of a condition. We need to find the ideal way in which we need to subtype these patients. And that is basically, I think, going to be achieved by some process like the phenotypic process. Okay, so I hope I'm sort of clarifying the issues that I wanted to bring up. So if there are any questions that you'd like to hurl at me, I'm ready to be assaulted.
So just one thought, sir, and I need your comments on that. I agree with you that we have placed a lot of emphasis on the outcomes, especially in sepsis, and often everywhere in the literature we keep talking about poor outcomes associated with sepsis. Have we kind of created a fear among a lot of clinicians, not only intensive care specialists, that you tend to overtreat even a small, you see a minor rise in WBC count or one febrile spike. That morbid fear that this could be sepsis and the outcomes could be bad tends makes us kind of overreact or kind of use treatments which probably may not be justified.
I think that it also depends so much on the definitions. Now, when we are trying to focus on this and basically say, okay, guy comes in with an infection, and besides the fact that we know he's got an infection, you notice that his kidney function is marginally elevated. And automatically your knee-jerk reaction is, oh, throw a lot of antibiotics, Gorillapinum and megalomycin at him. It doesn't make, I think that is a very irrational kind of a response, primarily to the way in which we have categorized sepsis. I think we have done a major disfavor using these kinds of ways to subdivide these patients into having sepsis or not having sepsis. Whereas it is far more subtle and far more important that we need to look at it from a little bit more nuanced kind of a way. And I feel I completely agree with you. I think we have created a fear psychosis by the ways in which we have defined it. And I mean, I'm certainly going to be an outlier in terms of my argument. And please remember, this is not an argument that is completely original. Okay, this kind of argument was raised immediately after the Sepsis 3 guidelines were published. There is a very nice article in American Journal of Respiratory and Critical Care. Unfortunately, I'm not able to quote it over here, but you can find an AGRCCM article that very clearly says virtually all the points. In fact, a lot of the points that I'm talking about have been borrowed from reading that particular article. And I feel that's very rational. I think they are very clear as soon as these guidelines came out. So why did we go away from our SIRS criteria to an organ dysfunction criteria when we know very clearly that organ dysfunction is something that is going to occur later in sepsis and is going to delay the diagnosis in an appropriate way? Yes, we may be picking up a lot of garbage when we're using SIRS criteria. There's no question about it. But if we have specific therapies that can be initiated effectively, unfortunately, we don't have anything yet. But if we do have specific therapies that can be initiated early, yeah, that may be the best time to do it rather than wait for organism dysfunction to develop and then say, okay, let's work on treating the patient. I thought it was a beautiful article. I wish I could give a quotation. I don't have it right now, but if I can, I will put it on the group website. I will just
please
send
share
the
it
reference.
with the delegates, sir.
Yeah, I'll do that. There's no problem.
Mithilesh, any questions from?
No, sir. No questions. Thank you, sir. Thank you for.
Very typical. Either it is all understood or totally misunderstood. Anyway, I'm very glad that you gave me enough time. I appreciate the time that you're giving us, despite the fact that you have days, for making the points very clear. Thank you all. Thank you both.
Thank you, sir. Thank you. It's always a pleasure to have you with HICS. Thank you very much.
Now we come to second plenary. Now we come to the second plenary session for the HICS8, and this topic is the unexplored pandemic of post-ICU syndrome. And it is the orator is Dr. Rahul Pandit, who is the chief of critical care and emergency medicine in HN Reliance Foundation Hospital, Mumbai. And he's been associated with HICS and is a great orator. So I would request Dr. Rahul to start.
Hello, everyone. I'm Dr. Rahul Pandit, and at the outset, let me thank Dr. Srinivas Samnathan, Dr. Ghanshyam Jakatkar, and the entire HICS team for inviting me to give this talk on a very interesting topic. I'm going to talk about post-ICU syndrome and a lurking pandemic which we all probably have not been aware of, or we probably know about it, but we are not doing a lot about that. And let's see over the next 20 minutes or so where we are in terms of this problem, how can we actually understand it better, and what are the steps to mitigate it. So the first thing, why are we actually in this problem? Over the years, as intensive care has become a more established specialty, we realize that we are actually having patients who are now surviving critical care quite well. Our ICU mortality from 1990s to 2010, 2020 have become better and better, which is good. We are having patients who are now living longer. And ICU is not a place where people just come to die, but they come to actually get better and go home and live a normal life. Not only that, even the population which we look at, the people who are elderly, they are now surviving critical illness quite well. And we are aware of the recent COVID pandemic which went through, or some of the recent infectious disease problems which we've gone through, like H1N1 or influenza infections. We know that a lot of people are now surviving critical illness and are going back to their normal life. And that's what is basically causing an increased level of people who are now coming out of intensive care back into the community and are trying to live a normal life. And that's when this question of post-infection, post-ICU syndrome comes into the picture. If you go by the logical definition of it, basically it is a new or a worsening impairment in the ICU acquired weakness. So the weakness which you acquire in ICU becomes either worse as you are discharged at home, or sometimes you have a new onset of weakness coming in. There could be a cognitive or mental or both worsening in the patient's function. And that's something which really bothers most of the patient. And the symptoms obviously have to persist beyond discharge from acute care settings. So they have to be discharged from the intensive care unit, maybe at ward, maybe in the home, to sort of talk it up as a post-ICU syndrome. Now, unfortunately, this post-ICU syndrome is not just affecting patients. It is also affecting the family members, the caregivers, those who are spending their time with the patient while the patient is admitted to intensive care. And a lot of it is to do with the stress or the anxiety they go through while their patient, their loved one is in the ICU. Many of them go through a depression as well. Now, there could be a lot of factors. It may not just be a patient being admitted there. There could be a financial stress. There could be a mental stress on the patient leading to depression. There could be other difficulties where, especially during COVID, we saw that many family members were admitted in ICU. Some of them even lost their life. Young lives were lost. So depression, like a post-traumatic stress disorder, is quite a common thing, which we are now seeing in this post-ICU syndrome patients. And then, of course, if you lose a loved one, or you have a loved one who is basically now going to come back home with a very poor quality of life, there could be grief, and it could be complicated grief. It would be very difficult for us as doctors to actually understand what is happening. So PCIS of the family is another parallel problem which is going on. While we are not just talking about the patients, we need to also address the family into that. Now, how far does the post-intensive care syndrome features, sort of persist, and especially in the family? Unfortunately, they can last on for years together. It's not something which I've come across families who have had an ICU experience of a family member several years ago, and they still feel the pain and the trauma. And the risk factors for the family probably includes multifactorial. Female gender seems to have a higher propensity towards that. Then obviously distance from the hospital to the home, younger relatives and patient age who are getting admitted and who actually have a worse outcome, critical illness of their spouse, low education level remains a problem in the Indian population. Low socioeconomic group also remains a problem. But what sort of baffles me is the last 2 points which I have highlighted. Lack of communication with nurses and lack of empathy of the care team in the hospital. Now, these two I've highlighted because I think these two, we as doctors, as nurses, feel that we are doing a fantastic job of communication, a fantastic job of showing empathy, and we rarely have a finger pointed towards us. But here it clearly looks like two of the causative factors are easily correctable. Only if we were communicating more with the family, only if our nurses were communicating more with the family and the caregivers, and the doctors in the care team actually showed some empathy, more than what is being shown, I think we would probably be able to correct this problem quite significantly. Then the next issue basically is to do with the fact that we have these ever-expanding definition of post-ICU syndrome. Over the years, we have seen that there are now a number of new systems which have been involved. So there is a bone loss which has been described, fragile fractures for patients who have been bedridden, who have developed contractures, a little movement in the bed cracks their bones, sometimes cracks the ribs. It's very, very difficult for the caregivers to look after such patients as well. Swallowing difficulties. We've got endocrine and metabolic problems, which are very difficult to sometimes diagnose. And even if they're diagnosed, how much of it is correctable is a different question altogether. Chronic pain, nerve and plexus injuries, just isolated nerve and plexus injury, like a brachial plexus injury, post-proning, or lateral peroneal nerve injury because of a bad positioning in the ICU. And hence, a newer syndromic approach is used. And this syndromic approach essentially talks about expanding the PCS criteria. And you can see that now the PICS is essentially looking at functional disabilities, cognitive disorders, mental disorders, chronic pain, how vulnerable the patients are, sleep problems, fatigue, endocrine problems, metabolic problems. And then what we actually correlate that is the baseline status of the patient. And then we obviously look at the increasing cost, socio-economical problems, and all of them together form up this syndrome of the post-ICU care syndrome. Now, how long does it actually persist? I would say very honestly, it is really difficult to predict how long this is going to persist and how long does a patient take to come out of it. Obviously, it will depend on the trajectory of the recovery. Some patients who may recover very quickly, in them the outcomes might be very, very reasonable. In some patients in whom the recovery might take time, obviously they may be going through this post-ICU care syndrome in a very bad way. And obviously the family suffers along with them. Also depends on how the pre-ICU status was. If the pre-ICU status was normal and healthy and they make a good recovery, that's fine. If the normal state was normal and healthy and they are now going to make a very poor recovery, I think it's a problem. One thing which we all tend to sort of misunderstand and conclude to ourselves that an elderly patient may not have as many problems because they are sort of dependent already on others for their day-to-day activity, or an advanced age is thought to be a very poor predictor of outcome. I think it's well proven now that advanced age is not a very good criteria to determine whether this patient is going to do well or not. So don't be an ageist. Look at the trajectory of the recovery, look at the pre-ICU status, and then decide what is actually happening with the patient. So to understand anything of what is actually happening to the patient, we need to do an outcome assessment. And how do we do an outcome assessment? To understand an outcome assessment, we should be looking at the clinical manifestations in detail. We just went through some of the clinical manifestations in the last couple of slides, but the most common ones you need to sort of prioritize and chronologically enumerate them. So weakness, fragility, mobility, mood swings, depression, sometimes sexual disturbances, sleep disturbances, cognitive and mental issues. These are the things which actually matter the most. If you are going to have night after night where you're not going to have a good sleep, if your weakness is so profound that even after working for an hour or two, you feel as if you've worked for the entire day, I think it's a problem, and these problems are very difficult to correct. However, there has to be some way of assessing this problem. And that's where I think some of these tools which have been developed actually help us to understand what these problems are. So you can look at the weakness and you can look at the muscle mass in a quantification way by doing a quadriceps ultrasound on the MRI. You can look at the strength of the muscle by looking at the hand grip. You could also do a 6-minute walk test and understand whether the patient's overall mobility and strength is pretty good or not. Obviously, everything which is to be asked from a patient can be in a form of a questionnaire, and provided the patient gives a reasonably honest answer about it, and which I feel they should be able to give, there is no reason to hide it. I think a questionnaire can also be developed around this. Respiratory function, you can look at the peak expiratory flow rates, diaphragmatic ultrasound of the diaphragm, and you can obviously formulate a questionnaire along with that. To add up to that, you do a swallowing assessment, you do an assessment of the cough, and also then end up with a flexible nasal endoscopy to understand what is actually going wrong in the swallowing. So that's called the dynamic swallowing test. Sometimes you can use a contrast and do a dynamic swallowing test as well. Metabolic and endocrine, you need to actually look at biomarkers, whether you look at HbA1c, whether you look at hormones to sort of try and understand a better metabolic system a bit better, endocrine system a bit better. I think you will be able to suppress this problem right at the beginning. One of the complex ones, which most intensivists are not able to actually go down to the root cause of it, is the mental disorders. Best to seek a psychologist help or a psychiatric help. Anxiety and depression scales are sometimes used by an ICU psychologist. And I think we need to interact more and more with a psychologist to understand whether there is a mental disorder or not. Cognitive assessment, there are functional scales to assess the cognitive function like Montreal Cognitive Assessment Scale. We can objectively assess the cognitive function and come to some form of understanding. Sleep disorders, sleep studies, sleep hygiene, talk a lot about your quality of life after intensive care. These are some of the things which we can actually look at objectively and mark and put up the normal values there, look at the patient values, and then aim for an improvement in the overall condition. Now, what is it that we talk about aim? I think mitigating problems of PICS arising later on during the ICU stay or post-ICU stay is the best thing which we can do. We now know that delirium in ICU and results in subsequent long-term disability among survivors on mechanical ventilation. And if you could look at this graph here, which talks about the days of delirium as the patient remains on mechanical ventilation longer and longer. So it's something which we need to look at, that how are we ventilating in our patients, so on and so forth. Brain ICU study investigators looked at hundreds of patients. They ultimately went on to randomize around 500 odd patients. And if you can look at these patients, their brain's global cognitive score at the baseline was supposed to be 100, but most of them at 12 months of admission in the age groups of less than 49, 50 to 64, and greater than 65 were doing worse than normal when they were actually discharged. This study by Pandrinath et al., Pandri Pandey et al., is really informative. It tells us that no matter what your age is, at 3 months, you're probably at the lowest point in terms of your mental status. And after that, if you actually work hard, you will be improving it. The American Psychiatric Association has gone a little bit deeper into it. They've deep dived into it and looked at exposure to traumatic event, which could be an individual experience, or they could actually look at some serious form of experience which the patient may have had, like a life-threatening problem, serious injury, and whether the physical integrity of the oneself was intact or lost. Also, some of the patients may respond with intense fear, helplessness, or horror. 3 symptoms which many patients described were nightmares, flashbacks, and they want to really avoid remembering it. Hyperarousal or not sleeping well is a part of that. And symptoms may be experienced more than a month. So I think this post-traumatic stress disorder, as per the American Psychiatric Association, is a very important tool which most patients and families who have gone through this pain should undergo an assessment and come out with the treatment in a triumph way. So when I'm going back to the mitigation, what should patients do? What should we do for the patient rather? All of our patients should have a psychological assessment once it is understood that they're going to remain in the intensive care for some time. We need to understand the pre-admission history, adapt to the level of stress, and try and help them into adapting to the level of stress. Medication history, current clinical and medical status, environmental factors, and family and friends. I think some of these factors are easily correctable, and we should be able to do that reasonably well at our patient side. You need to sort of try and eliminate or correct the causative factors. So some of the simple things which we talk about: appropriate use of sedatives, sleep-wake cycle, decrease environmental factors, frequent family and friends visit, and communication makes life much more easier for ICU patient. There is a bundle which is suggested, ABCDE bundle. A stands for awakening, B stands for breathing, C stands for coordination of care and communication, D stands for delirium, monitoring, assessment, and treatment, and E stands for early ambulation in ICU. So I think ABCDE scale is a very good scale which may help you to actually prevent this post-ICU care bundle. And as we all know, prevention is better than cure. What additional strategies can we actually look at? We can look at nutritional status. We can look at avoiding hypoglycemia. Family engagements which need to be attended, which need to be sort of monitored, should be offered to the patient. Early psychological assessment, and then there is something called the ICU diary and post-ICU clinics. Let's understand what this ICU diary is. Early psychological support is something which the university in Florence, the Craigie University Hospital in Florence, actually experimented with it. They are a clinical pharmacologist who are supporting and giving emotional support and education to families. The psychologist was available 24/7. He would observe those patients with or without a child psychologist. If the child psychologist was not there, a trend towards less depression and anxiety and a statistically significant difference in the post-traumatic stress disorder was seen when early psychological intervention was done. The other option could be to write ICU diaries. This was an idea which has originated in Scandinavia. It's written for ICU patients during their time of sedation and ventilation. Daily account of ICU stay, stories written by relatives, nurses, doctors, others in plain language, photographs of the patient taken from the starting point to the point of change. Patients can read their diaries and is more able to understand what happened. The aim is to fill in memory gaps and help patient understand their illness, with staff supporting them to go through the whole process with the help of diaries and photos. And the UK National Institute for Health and Clinical Excellence recommended cognitive behavioral therapy, CBT or PTSD, changing how clients think about their traumatic experience in one of the aims of actually having a patient diary being used. So these are some of the examples of the diary. You can see some of the photographs, see what the staff has written. Does this all translate into actual outcomes? You can see that the diary is sort of known to reduce post-traumatic stress disorder, anxiety and post-traumatic stress disorder for families as well. And I think overall the impact of family was greater than the patient, because there was a perception which now diary sort of counteracted. The perception was that the doctors were not giving enough care, nurses were not giving enough care. When the diary is there, it's a recurrent documentation, they actually appreciate whatever care was being given to the loved one. Post-ICU clinics, it's not an old idea. We all want to have this post-ICU stress disorder clinic. I was just going to be basically looking at setting up one of these in my hospital very, very soon. And we all know that these have been experimental factors, but they have all shown to be in a favor of a better outcome if you have this intensive care units, which are post-ICU care units. Now let's come back to the family. What should we do to the family so that they can actually experience less stress? So ICU staff should educate family related to assessing and meeting family needs. Communication should be frequent, should be clear, should be done by a senior most person. Sometimes you need to understand the preferred level of involvement and just leave it at that. You need to sort of have yourself valued there. At the same time, the family should understand that this doctor is saying something which actually makes a lot of difference. Acknowledge family's emotions, listen, and understand the patient as a human being, and elicit questions from the family. I think these are the things which are the family unit, if you do, you may go through a less amount of post-ICU care syndrome. Risk stratification, you need to start looking at risk stratification by having medication risk, by risk stratification by understanding that what is going to happen if this patient goes home. So medication reconciliation forms a very important part on discharge. Make sure that the patient's normal medicines with the normal brands are written up. Otherwise, some of these medicines patients get very, very distressed if these medicines don't reach them. Keep their vaccinations up to date. We know that a patient who comes out of intensive care, especially with sepsis and multi-organ failure, has got up to 45% chance of going back into the ICU within the first year. Those on immunosuppression, splenectomy patients should be aware of the increased risk of sepsis and preventive strategies and vaccinated as per the guidelines. I think these are very important things to do. So I would like to summarize that this is an area where a lot more can be done. Assessment outcome measurement tool needs to be developed. We should have ICU diaries and post-ICU clinics are low-hanging fruit, which we should develop again. And pandemic of unrecognized proportion is already there, which is why we need to have a good understanding and idea of what we are able to do and how we can offer this. Thank you very much.
Thank you, sir, for covering the post-ICU syndrome, pandemic of post-ICU syndrome. There are no additional questions for you, but one question is there for Ram Rajgopalan, sir. Sir, are you listening, sir?
Yeah, I'm here. Thank you.
The question is, if there is no much mortality difference between first and third hour of sepsis and shock, can we take time to evaluate and then react?
Okay. I'm sorry. Didn't make any allusions to the fact that there is no difference between the first and third hour, but it is probably real. I have no problem. The fact of the matter is, yes, the probable reason that there are no differences is probably the way in which we are defining sepsis. By defining sepsis in these kinds of homogeneous kind of subgroups that we are dealing with right now, it is very unlikely we'll be able to demonstrate any kind of difference over time or between groups in the first place. But irrespective, as it stands today, I think even the surviving sepsis guidelines have been modified to the point where they try to make a distinction between situations where you're absolutely certain that the patient has an infection versus the situation where the patient has a probable infection. They're very clear that if you have a certainty about the existence of an infection, that the aggressiveness, the old time bound 1 hour or whatever else that you need to give the antibiotic is becoming very relevant. On the other hand, if there is any question about the certainty, they say take your own time to try and get to a definitive diagnosis before you attempt to treat. So if the answer to this question is there a problem about delaying the treatment by a few hours? Probably not. And even more interesting is when you look at the data related to fluid resuscitation also, it doesn't appear that a time-bound approach to fluid resuscitation makes a difference in outcome, at least in retrospective large groups. Okay, so I personally believe taking that time is absolutely essential so that you achieve a better diagnosis. This is irrelevant to my specific talk, but I still think it is worthwhile as an emphasis for this the question. Is there any other question?
No, sir. That is the only question.
Hey, thank you very much for re-including me to give this answer. Okay, thanks a lot.
Thank you, sir. So now we come to the next session. The next session is view, counter view, and consensus. This is about feeding the patient. So Dr. Tapas Sahu, who is the Associate Director and Head Critical Care of Critical Care Medicine at Medanta Hospital in Ranchi, he is going to talk about early feeding in critically ill patients. So over to you, Dr. Tapas.
Hello. Thank you, HICS8, for giving me the opportunity to discuss about some important topic, what we do practice in our day-to-day clinical areas. So today, the topic which have been assigned to me is a pro debate for the early enteral nutrition. So I would be making it clear that this debate is not fixed. This is one of the rare instances of our broken debate where the verdict is clear to everyone, including the judge as well as our rookies. I appreciate profoundly all my co-speakers' efforts and work. And also in the next 10 to 12 minutes, we'll consolidate our existing knowledge in a better way and get recent updates. Now, my points would be basically with the common sense. I would discuss about the physiology behind starting early enteral nutrition and also the evidence supporting early enteral nutrition, along with evidence against delayed enteral nutrition, and also defend critics against early enteral nutrition. Now, to start with, when I thought of putting this in the Google search, early nutrition in critical illness timing, I was surprised to see in 0.47 seconds, Google informed me that it's 24 to 48 hours. And I just thought of getting and keeping this screenshot for all of you. Though I thought I would stop my discussion rather entering into a vivid discussion. But yes, we don't stop here. We would discuss with all the evidence, all the guidelines, and all the physiological as well as the scientific reasons behind the point of starting early enteral nutrition. Now, this is one slide I want all my trainees to look into and understand. Whenever any patients enter into our ICU, we get the patient into the acute phase of illness. And that is first 1 to 2 days. Now it enters into day 3 to 7. That is the late period of the acute phase. And in these states, patient is in catabolic state. You can see the cannibalizing tissue picture. And when we treat the patient, we resuscitate the patient, and we think that this patient is improving, it enters into the rehabilitation and recovery phase. And here we can see the anabolism or building tissue happens. So that is important because we need to categorize and we need to think about what part of nutrition or what dose of nutrition or what route of nutrition we need to implement or provide to our patient so that the patient will go mostly into the green phase. But sometimes despite our of all efforts, patient doesn't improve and finally end into the prolonged inflammatory and catabolic syndrome in the late phase, that is day 8 plus. So maybe we need to think about, understand this concept behind the anabolic and catabolic stage. Then only our provision of starting the enteral nutrition in the correct way can be given due importance in our clinical practice. Now, the rationale and definition behind starting the nutrition within first 48 hours of ICU stay. We all know in the initial time, the patient is in hypercatabolic state, requirement of macro and micronutrients is really high. We need to take care of the gut health also, and there is also need for trophic stimulus of the bowel mucosa. Also, the susceptibility of the patient to the added insult of the gut bacterial translocation and malnutrition is very high in the acute phase. So we need to also take care of that. It has been seen that if you start early enteral nutrition, there is clinically important reduction in the infection rate, and also that finally end up with our the goal of treating, that is important reduction in the mortality. But there is also a flip side to the starting the full nutrition in the early phase. That is, we are suppressing the autophagy and ketogenesis, and also that may be that we do not want in our patient to undergo in the early phase, and that affects the final recovery and lead to maybe overfeeding and refeeding, something like that. Now, again, the acute illness has 3 phases related or pertinent to the nutrition that we can divide from this slide. You can see acute phase, early period. We all know we should provide only up to 50% of the patient's estimated caloric utilization at this point of time, because of the reasons what we have already discussed. Catabolism will occur whether or not you are providing exogenous nutrition or not. Now, we should not suppress the autophagy. That may be helpful for the patient's recovery. In the acute phase late period, this is a transitional period. Normally, recovery will begin during this stage, and with waning of the catabolism, maybe we can think of ramping up our nutritional administration at this point of time. Coming to the late phase, I have already shown in that graph, this is the anabolic state, and we need to provide full nutritional support during this time. Now, this is one article I want all of you to go through, published very recently, 2021 in Critical Care, and they have given 10 expert tips for the enteral nutrition in the daily practice, and they have clearly shown or written that early enteral nutrition less than 24 to 48 hours of the intubation has consistently been shown to improve outcome, and the benefits we already discussed, and all the guidelines they recommend that you should initiate nutrition within first 48 hours, and nearly all intubated patients should be fed. Now, there are certain so-called contraindications to enteral nutrition. Normally, we keep in our mind that I want you all to remember that these are not contraindication to enteral nutrition. Just like lack of bowel sound, if we think that now that patient is right now completely paralyzed, so I should not provide nutrition. No. To our understanding, gut is composed of smooth muscle, so we doesn't respond to paralytics. So that is a thing what we should clear in our mind. Unable to lie in a semi-recommend position, prone positioning, pancreatitis, open abdomen, recent gastrointestinal or abdominal aortic surgery patient, low to moderate vasopressor. So that make it clear that these are not contraindication. Rather, you should start with low dose of feeding from the very beginning. Now, there are certain contraindication. I would definitely make it in 2 ways: gastrointestinal catastrophe, and we can see all the things that comes under gastrointestinal catastrophe. We should not feed enterally, and high dose of vasopressors. If the patient is almost around 0.3 to 0.5 or more than that, maybe we need to think now I should not feed this patient enterally. So enterally, we should not feed the patient with refractory shock or patients on high dose of vasopressor. But if the patient is adequately resuscitated, they can be started on enteral nutrition at a relatively low rate. Now, this is one study that have shown Nutriria 2 that if the patient has been fed fully, maybe the risk increases for the bowel ischemia in those patients. But yes, those are very rare cases and extremes of risk. So we should not feed the patients of patients who are on massive doses of vasopressors. This is one thing I want to clarify, that ESICM clinical practice guidelines, they have made 17 recommendations favoring initiation of enteral nutrition and 7 recommendations where we should promote or favor delaying enteral nutrition. They have included or performed 5 meta-analysis, and they have included all domains of critical ill patients where we need to think for whether the patient to be early enteral nutrition to be given or delaying in the enteral nutrition. And they have shown that almost majority of critical ill patients fall into the early enteral nutrition group. Rather, only the patients with uncontrolled shock, uncontrolled hypoxemia, acidosis, uncontrolled upper GI bleeding, gastric aspirate more than 500 ml per 6 hours, bowel ischemia, bowel obstruction, abdominal compartment syndrome, and high output fistula without the distal feeding access. Now, thumbs up to all the 15 recommendations where almost 100% agreement was there to start early enteral nutrition. Also, European Society for Clinical Nutrition and Metabolism echoes the views with the ESICM practice guidelines. They have also shown that almost a grade of recommendation A with strong consensus, 100% agreement of patients starting early enteral nutrition in critically ill patients within 24 to 48 hours of admission to the ICU. Now, the most recent article, Nutriria 3, also is very relevant in current day-to-day practice. What I want to clarify or make it clear for our trainees that rather standard calorie and protein target, early calorie and protein restriction that did not decrease the mortality but associated with faster recovery and fewer complications. They have divided the patients of 61 French ICUs into two groups. One is low or standard calorie and protein target where the calorie target was 6 kilocalorie per day kilogram and the protein target was mere 0.2 to 0.4 gram per kilogram per day, versus 25 kilocalorie per day in the standard the normal what we normally provide, and 1 to 1.3 gram per kilogram per day protein during the first 7 ICU days. And they have found very interesting observation that is again contrary to the, or maybe I would say supporting the effort trial which has recently published again in the Lancet journal. Now, the editorial is very interesting. I would request maybe you should go ahead with reading this Nutriria 3 where to next. And these yellow highlighted points are very important for our understanding what is going to happen in near future for the nutritional perspective. And this is published just recently, April 4, 2023. So now, one negative trial related to early enteral nutrition, I would quote, maybe my co-speaker would be discussing in detail to defend her view. So that has been mentioned by the France Prospective Nutrition Cohort study that if you start early nutrition support in ICU, that is associated significantly with the increased mortality at day 28, and particularly in younger patients with less severe disease. But I would request maybe we should take this study with a pinch of salt, because the limitations I have found out from the study that they have already have the calories 5 kilocalorie per kilogram per day, not through the feeding enteral nutrition, rather they have already the patient is receiving from the IV dextrose and propofol. So anyway, it is almost the permissive underfeeding in the recent RCTs. Now, they have not included any nutrition risk screening to 2002 or Nutrix score to estimate the nutritional risk. The effect was not found with early parenteral nutrition in propensity weighted analysis, which is again very interesting that the enteral nutrition, they did harm rather than early parenteral nutrition did wonder. And also the nutritional follow-up was only limited to 10 days. And what we have already discussed, it should be almost into the late phase of the critical illness or the recovery phase. And they have not included or estimate the energy requirement by indirect calorimetry. And last point, the study started in 2015 and published in 2023. So you can understand the significance and the the weightage of this study. So it coming to the final take home message, we do not know the exact feeding, how much to feed or when to feed, but there is agreement that early enteral nutrition is a good thing within 48 hours of ICU admission. Nutrition needs to be customized. Again, here also we need to be personalized and precision based, just like other forms of our nutrition, our critical care. And also comorbidities, patient's disease state, including the level of inflammation, catabolism, phase of the disease, all need to be considered. And we need to take into account which phase the patient is in for calculating and also starting the enteral nutrition. And also we need to continue the nutritional support throughout the patient's recovery to get a better result in our patients. So with this, I conclude, and I would rest all the discussion to my co-speakers, Dr. Sulagna, and finally for Dr. Srikanth. Thank you all of you for your patient listening.
Thank you, Dr. Tapas, for such a clear view on early enteral nutrition in the critically ill patients. So now with the once we have gone through the view, there is a counter view. Counter view is by Dr. Sulagna Bhattacharjee, who is going to say early feeding can cause more harm. Okay, so we'll listen to Dr. Sulagna now. Can you please start?
Good morning, everybody. I am Dr. Sulagna Bhattacharjee, Assistant Professor in the Department of Anesthesiology, Pain Medicine and Critical Care in AIIMS, New Delhi. I will be discussing about how early feeding causes more harm. Brushing up the definitions, early feeding is when it is instituted within 48 hours, intermediate within 3 to 7 days and late beyond the first week. Full feeding when 100% of the calorie goals are met. Trophic when given for maintaining gut mucosal integrity. Hypocaloric when 70% of the target is met, and overfeeding when more than 110% of the target is given. The latest ESPN guidelines of 2019 recommend early enteral nutrition to be instituted within 48 hours in critically ill patients rather than delayed nutrition. This is a grade B recommendation with strong consensus. This was derived from a meta-analysis of 6 studies in ICU patients and 4 studies in non-ICU patients. They showed reduction in infectious complications. This was only true when non-ICU patients were included, and the effect was reduced when the earlier studies with serious methodological flaws were excluded. However, this reduction in infectious complications was not associated with reduction in more meaningful outcome like mortality. In the recent Cochrane meta-analysis looking into early enteral nutrition versus delayed enteral nutrition with or without supplemental parenteral nutrition in critically ill patients, the authors concluded that due to very low quality of evidence, it was uncertain whether early enteral nutrition caused any effect on 30-day mortality, feeding intolerance, gastrointestinal complications, or pneumonia. Similarly, due to very low quality of evidence, early enteral nutrition with supplemental parenteral nutrition was also not evidently beneficial in terms of mortality, infectious complications, and duration of mechanical ventilation. Coming to the dose of feeding that is recommended by the latest guidelines, energy expenditure should be measured by indirect calorimetry if available in mechanically ventilated patients. Hypocaloric feeding is recommended preferred over isocaloric feeding, and at day 3 calorie goal should be increased to 80 to 100% of the measured energy expenditure after day 3. However, this recommendation is not backed by evidence. It is based on strong consensus. If we see indirect calorimetric targeted isocaloric nutrition was seen to reduce short-term mortality. However, it had no difference in long-term mortality of the patients, infectious complications, and length of stay. So what happens during critical illness? There is a profound metabolic alteration. The critical illness is characterized by the acute phase, the early period during which there is severe metabolic insufficiency, hemodynamic instability, and severe catabolism. This transitions into the late acute phase, which lasts for 3 to 7 days, where there is improvement in the metabolic insufficiency and there is muscle wasting. This is followed by either improvement and rehabilitation or the patient landing into chronic critical illness. Now, critical illness triggers a host of complex neuroendocrine response, inflammatory response, and sympathetic response. The neuroendocrine response leads to skeletal muscle breakdown, proteolysis, release of amino acids. The cytokines stimulate glycogenolysis, neoglucogenesis, and protein synthesis in the liver. Also, there is lipolysis. So, all these lead to increased glucose availability, which is utilized by the vital organs during the phases of critical illness. However, there are a number of protective mechanisms which reduce the metabolic derangements, like anorexia. It enhances immune response, decreases metabolic derangement. Autophagy. Autophagy is a key adaptive mechanism. It is required for preserving cellular integrity. It is stimulated by starvation, by inflammation, and by infection, and it is suppressed by exogenous energy administration. Neuroendocrine response causing neoglucogenesis is also not suppressed by exogenous energy administration. Early feeding may be harmful also because it can lead to refeeding syndrome, causing electrolyte imbalances leading to cardiac, pulmonary and gastrointestinal complications and failure. Also, gastrointestinal and hepatic complications like aspiration, vomiting, diarrhea, and non-occlusive bile necrosis can occur with institution of early enteral nutrition. So there seems to be a wide gap in the practice and knowledge of institution of early feeding. Overfeeding, as we all know from large databases, have been proved to increase mortality and should be avoided. However, we do not know about the different caloric targets that may be appropriate for the different phases of critical illness. Endogenous calorie production, as we know, can be up from 500 to 1400 kilocalories per day during the acute phase of critical illness. However, we do not have any established methods to estimate this endogenous energy production. Early full feeding can cause overfeeding. However, we are limited to targeting the actual energy expenditure during the first 72 hours, and we do not have any proper methods to assess the actual requirement during this phase. So with this knowledge in the background, we come to one of the latest published studies, the France Prospective Nutrition Cohort Study, which has seen the association between early nutritional support and 28-day mortality in critically ill patients. This was a prospective multi-centered observational study which explored the feeding practices in critically ill patients during the first 10 days of ICU admission in 23 ICUs in France and 3 in Belgium during the year 2015. It included 1206 patients, of whom 718 patients received early nutrition, majority of them receiving enteral nutrition, and around 488 patients did not receive early nutrition during the first 40. The study population was representative of critical illness with a median SOFA score of 8 and SAP score of 44 at admission. 81% of the patients required mechanical ventilation. Enteral nutrition was more frequently prescribed in patients with multi-organ failure. Comparing the early group versus the delayed nutrition group, the early group had a peak energy delivery at day 3 and that plateaued for the rest of the study period, whereas in the delayed group, energy delivery gradually rose from day 1 to day 10 in a linear fashion. Comparing the survivors and the non-survivors, the timing of enteral nutrition was similar in both the groups. Total caloric intake, non-nutritional caloric intake in the early phase, the early protein intake were similar in both the groups. However, the enteral nutrition group had more incidence of gastrointestinal complications. As compared to survivors, the non-survivors were older, were sicker, and with higher SOFA scores. Higher proportion of early nutrition was received by them by any route. Early nutrition by any route was also associated with significant 28-day mortality in univariate as well as multivariate model, and also in propensity weighted analysis. Early parenteral nutrition was associated with significant 28-day mortality in multivariable multi-level analysis, but not in propensity weighted. On subgroup analysis, 28-day mortality was strongly associated with male sex, with age less than 65 years, with BMI of 18 to 25, and with SOFA score of less than 8. So apparently these patients do not seem to be in a high risk of malnutrition, but they probably had increased mortality because of overfeeding due to institution of early enteral. However, the most important finding of the study was dose-dependent effect of early nutrition. Significantly higher mortality was found when delivered calories were more than 6 kilocalories per kg per day, or protein more than 3 grams per kg per day during the first 48 hours. Also, a potential dose-dependent effect of increasing protein with increasing mortality was found. This study is important in many ways. It has demonstrated that more than 75% patients received energy and protein below the recommended targets, and this is reflective of the prevailing practices. Nutritional support was widely prescribed by the enteral route, and early nutritional support was associated with 28-day mortality. Also, this study has been useful in identifying a dose-dependent association with mortality, which is a very significant finding in an observational study. Therefore, we can conclude that provision of higher amounts of macronutrients early during the ICU stay can be associated with poor outcomes from this high quality observational study. Coming to one of the latest publications, the NutriRia-3, which has compared low versus standard calorie and protein feeding in ventilated adults with shock. This was a randomized multicentric trial done in 61 French ICUs in the year 2018 to 20, recruiting adults more than 18 years receiving mechanical ventilations and having shock receiving vasopressin. The patients were randomized within 24 hours of intubation and to a low group and a standard group. The low group had a target of receiving 6 kilocalories per kg per day and a protein of 0.2 to 0.4 grams per kg per day via the enteral or parenteral route, and the standard group had a target of 25 kilocalories per kg per day and a protein of 1 to 1.3 grams per kg per day via the enteral or the parenteral route. This was continued up to day 7 after the completion of the study period. At day 8, both the groups received standard feeding at 30 kilocalories per kg per day and protein of 1.2 to 2 grams per kg per day. Initiation of nutrition was similar in both the groups. Enteral route was the most preferred route in both the groups. Caloric targets were met approximately in both the groups. The low calorie group received 7.4 kilocalories per kg per day and a protein of 0.2 grams per kg per day, whereas the standard group received 22 kilocalories per kg per day and a protein of 0.9 grams per kg per day. Coming to the results, 90-day mortality was similar between the two groups. However, time to readiness to ICU discharge was significantly lower in the low calorie group. Among the secondary outcomes, duration of invasive mechanical ventilation was lower in the low calorie group. Also, the incidence of gastrointestinal complications was significantly lower in the low calorie group. Coming to the importance of this trial, this was a large, pragmatic, well-designed trial which has strict protocol adherence. It was well-defined, representative of heterogeneous ICU population, and it clearly demonstrated that early calorie and protein restriction during acute phase of critical illness does not increase mortality, enhances recovery, and results in fewer complications. In one of the earlier trials, the Eden randomized trial, where initial trophic versus full enteral feeding was given in patients with acute lung injury, this was an open-label, multi-centered RCT done in USA, including 1,000 patients within 48 hours of developing acute lung injury. A 6-day regimen of low-dose trophic feeding targeting 400 kilocalories per day versus a full enteral tube feeding of 1300 kilocalories per day was given. No difference was seen in ventilator-free days, 60-day mortality, or infectious complications, and more gastrointestinal intolerance was seen in the full feeding group. This trial too demonstrated that initial trophic feeding was safe as compared to full enteral feeding and did not result in more mortality. The INTACT trial, which compared intensive nutrition therapy in acute lung injury, recruiting 78 patients within 24 hours of diagnosis, provided 75% of estimated energy requirements and protein to patients in the intensive group versus standard nutrition. The receipt of nutrition was significantly different among the two groups, 84% of target versus around 50% of the target. However, the trial had to be stopped early due to significantly higher mortality in the intensive nutrition group. We have seen that early enteral nutrition is associated with gastrointestinal complications. However, does early supplemental parenteral nutrition help? This has been addressed in the EPANIC trial, where early versus late parenteral nutrition was assessed in critically ill patients. Early supplemental parenteral nutrition instituted within 48 hours was compared to late parenteral nutrition at day 8 in patients with a Nutric score of more than 3. Patients in the late initiation group had a relative increase in 6.3% percent points in the likelihood of being discharged earlier from the ICU, had fewer deaths, fewer ICU-acquired infectious complications, and shorter duration of mechanical ventilation. Therefore, this benefit was probably due to the prevention of overfeeding in the late initiation group by supplemental parenteral nutrition. In a nested cohort analysis of an international multi-centered clinical trial, the EFFORT trial, early versus delayed enteral nutrition was studied in mechanically ventilated patients with circulatory failure. This included 626 patients from 52 ICUs of 14 countries, majority having septic shock and were on non-epinephrine. In the unadjusted analysis, early enteral nutrition was associated with improvement in the primary outcome, that is persistent organ failure and day 28 mortality, but after adjusting for factors like age, modified Nutric score, Apache 2 score, and sepsis, this association became insignificant. Also, it was found that patients with higher modified Nutric score receiving early enteral nutrition had a higher 60-day mortality and a higher persistent organ dysfunction and day 28 mortality. This was in contrast to the traditional belief that patients who had higher risk of malnutrition, as evidenced by the higher mNutric score, would benefit from early enteral nutrition. So from our session, we can conclude that anorexia during acute phase is protective, endogenous energy production during acute phase of critical illness is substantial, and therefore future research needs to be done to estimate energy needs in the different phases of critical illness accurately. From the studies that we have discussed, it is clear that permissive underfeeding or trophic feeding in the acute phase of critical illness is safe and may have improved outcome. This is in contrast to the current prevailing concepts and the current guidelines that advocate for enteral nutrition early within 48 hours and targeting hypocaloric or isocaloric goals within the acute phase of critical illness. And the future holds place for accurate biomarkers to individualize nutrition targets, which can ultimately lead to improved patient outcomes. Thank you, best wishes and season's greetings, and a happy HICS 8.
Thank you, Dr. Sulagna, for expressing your views on early feeding causing more harm. But now we have heard for the view, counter view. Now we should go for a balanced view. So the next thing is, views are going to be expressed by Dr. Shrikant Sahasrabudhe on optimum feeding strategy in critical illness. Dr. Shrikant is the Director and Head of Department of Pulmonology and Critical Care Medicine at Medicover Hospital, Hyderabad, Aurangabad. Welcome, Dr. Shrikant. You can start.
Hello, everyone. I'll be talking on optimum feeding strategy in critical illness. At the outset, I would like to thank the organizers of HICS8, especially my friend Dr. Srinivas. And earlier to this, you must have heard my friend Dr. Tapas, who talked about early nutrition, and also Dr. Sulagna, who actually embarked upon the late nutrition. And I am here as a responsibility to deliberate upon the kind of a balanced view on how optimal the feeding should be in the various aspects of the feeding. So, talking about the route at the outset, every one of us know that EN is the most preferred one than the PN, with the exception that we need to be careful about the GI complications, especially vomiting, bowel ischemia, pseudo-obstruction, which has been given in Nutriria 2 trial. And of course, it is with the help of nasogastric and the nasojejunal, as well as the PEG in specific situations. And the guideline recommends the trophic or the minimal enteral nutrition and to start with, and then ramping it up. Especially in post-surgical patients, post-pyloric feed has been kind of instituted in few situations for the problems of delayed gastric emptying and poor intestinal motility. As far as the combination of EN and PN is concerned for specific indication, there has been found no difference when we have both combined in the early course of the illness in ICU. And after a few days, of course, it can be a supplementary, as we all know. PN is definitely has the advantage of less vomiting and avoidance of hypoglycemia. But the early PN in the first week, we need to be very, very careful about the problems of infection, the prolonged organ support, weakness, cost, etc. And there are various guidelines which embark upon the duration of the start of PN right from the third day to even seventh day. I think the pragmatic approach would be later than early for PN, and remember it as a practical approach. There has to be individualized approach for the patients, and remember to have thought of PN after we actually optimize or all the strategies to maximize the EN tolerance has been taken care of. As far as the dose of the energy is concerned, more progressive and a slower buildup of the energy, very small volumes of even 5 to 10 ml. And in the first week, 12 to 20 kilocalories per kg per day has been recommended. There has been non-nutritional calories in the form of propofol or trisodium citrate and glucose, which constitutes to the tune of 6 to 18%, and that has to be remembered. Remember that 70% of the energy expenditure in the early course of illness and about 80 to 100% achievement of the energy expenditure after the third day has to be kind of thought of. 500 kilocalories per day, or the 25% of the total target calories, has been recommended in NICE guidelines. As far as proteins are concerned, a low dose of 0.8 grams per kg per day in the early phase and increased up to 1.2 grams per kg per day later. In specific situation, as you could see in polytrauma and burns, we can go up to 2 grams per kg. So important thing is there's a significant muscle mass loss and the weight loss of even up to 1 kg per day in the first 10 days, which is responsible for the ICU acquired weaknesses. And there's been no meaningful clinical outcomes, especially for the patients who have been provided with high protein in critical ill patients. So remember that. As far as timing is concerned, and that is the most vital thing, almost all the guidelines recommend the start of EN between 24 to 48 hours, and that is EEN, that is early enteral nutrition. And there was a questionable benefit of EEN as far as the impact on mortality is concerned, but certainly there could be decrease in the infectious complications. And of course, we start them after ruling out the contraindications. As far as access is concerned, when the nutrition is expected as a short term within 4 weeks, of course, nasogastric tube and the nasojejunal in few situations can be thought of. When it is a long term plan of more than 4 weeks, then of course pegs and things like that would be definitely recommended. As far as the post-pyloric feeding is concerned, in the form of a nasojejunal feeding, where we suspect GI intolerance even after use of prokinetics or delayed gastric emptying, and we need to actually prevent the risk of aspiration, and these are the various ways by which we can put a nasojejunal tube in ICU. Of course, it is for the reduction of pneumonia, and in few patients with delayed gastric emptying, deep jejunal access has also been recommended. There has been no specific recommendation as far as energy dense formulas are concerned, especially in the patients whom we need to have volume restriction or the transition from nasogastric feeds to the oral nutrition. A very important subset of hemodynamically unstable patients, especially in ICU, and we the intensivist encounter these problems with the patients of more than two vasopressors or inotropes, especially in the setting of hypoxemia, acidosis, where we need to be very, very careful about the gut ischemia. And as far as the timing is concerned, it has been recommended that they have to be in a declining or a stable doses of the inotropes, usually the 2 of them. And after the adequate fluid resuscitation with the enteral route starting in a very small dose of 10 to 20 ml per hour, within the first 24 to 48 hours of the stability on the vasopressor, and that is what is being recommended, with gradual advancements and looking for the GI intolerance. So remember the very small volumes and 24 to 48 hours after the stabilization of the patient. The threat of bowel ischemia always remains, and we have to be very careful about it. Refeeding syndrome is a metabolic response to introduction of the nutrients after the starvation, which amounts for the morbidity and mortality. Beware of hypophosphatemia and supplement phosphates accordingly. IV thiamine in the dose of 100 to 200 milligram per day for the first 3 days with monitoring of potassium, magnesium, and phosphates. GI intolerance clinically is in the form of vomiting, pain, distension, and raised intra-abdominal pressure with absent bowel sounds, like a dynamic ileus. And the enteral feeding intolerance, where we have a GI dysfunction, we need to actually discontinue the EN. The gastric residual volume in the volume of more than 500 ml at one time, or 150 to 500 ml twice, has been kind of as a cutoff. There was no difference in permissive underfeeding and the standard feeding, which is a famous NEJM article in the year 20 15. And of course, supplementation of micronutrients along with vitamin D, antioxidants, selenium, zinc has been also recommended in few of the guidelines which is seen. We'll talk about the optimum nutrition in specific diseases. Talking about the renal diseases, the EN route is preferred, and we need to be a little more careful about supplementation of a higher quantity of amino acids and electrolytes as well as vitamins and trace elements, and potassium needs to get monitored. As far as liver diseases and other abdominal and GI ailments are concerned, EN is the preferred route, even in the cases of liver failure or acute pancreatitis, and even after the surgeries like enteric fistulas or open abdomen. And we need an interdisciplinary team for devising the strategy. As far as respiratory diseases are concerned, Aspen actually avoids hyperalimentation and beware of life-threatening hypoxia, hypercapnia, and acidosis, where EN has to be instituted or started very, very cautiously. Energy-dense formulation with a quantity of 1.5 to 2 kilocalories per ml with avoidance of hypophosphatemia. And in prone position, we can still give early enteral nutrition that is been recommended. For cardiac diseases, as we know, there are heterogeneous population, and MNT, that is medical nutrition therapy, is usually instituted because of increased risk of malnutrition, and EN route is preferred, but with a special attention on hemodynamic stability and the fluid status. As far as neurological diseases are concerned, as we know, they have a prolonged ICU stay and a high risk of malnutrition. Again, EN is preferred over PN, and beware of paralytic alias and the increased risk of aspiration. As we have already talked of trauma and burns with a high protein requirement to the tune of 2 grams per kg, again, the EN route is preferred. So my take-home messages, and I'm sure that it was a very, very vast topic, but I have tried to make it as easy as possible with inclusion of majority of the guidelines. So there are more controversies than the consensus, and the further studies are required. EN, no doubt, is preferred over PN, and there is a pragmatic approach for the same. It is based on the Cochrane database, which included about 7 big RCTs, stating very low quality evidence, but in practicality, EN is the preferred choice for nutrition in critically ill patients, which is started early, about 48 hours of the admission to the ICU, and start as a hypocaloric feeds. Of course, there is no doubt that it decreases the infectious complications. PN, as we know, that we give it because there is a macronutrient targets which may not be reached with EN, and a few guidelines which has been already stated. Aspen gives the criteria of 7 days, whereas the European guidelines give the guidelines gives the criteria of about 3 to 7 days. And there are ongoing intent trial as well as the upcoming Nutriria 3 trial, which actually compares the early low energy, low protein content versus the standard formulation in critically ill patients, especially the ventilated and the shock patients. And these are the few articles which actually I took help of as far as collecting the literature for this talk is concerned. And thank you very much for the patient listening. Thank you.
Unmute, sir, please.
Yeah. Thank you, Dr. Shrikant. Thank you for such a nice talk. I have one question for you. In this, because of the dynamic nature of critical illness, instead of having fixed goal, should you have personal nutrition strategy for the patients?
Yeah, if I think if you remember during my talk, I said the same thing, that the personalized approach for almost each and every case is required. And as we know that in critical care, no one cap fits all. So definitely there has to be approach depending on the which of the clinical situation you are encountering. But as far as the route is concerned, and the basics of starting of the hypocaloric diet,
and the targets which we usually use, the indirect calorimetry and the Nutrix score is concerned. These are fairly clear ideas which has been kind of given. But yes, I agree to your point of personalized selection.
You mentioned regarding the nasojejunal feeds. What are the clinical situations where would you like to go for nasojejunal feeds, and is there any study has demonstrated that any better than gastrojejunal feeds?
Right. So it's also called as post-pyloric feeding, as we know.
Yeah.
And there are certain gadgets and the procedures with which we do. Either it is endoscopic, which is the most common, and it's a very classical situation of the gastric residual volume, which is usually high in the dynamic ileus situation in course of sepsis. This is what practically, which I feel is the most commonly encountered situation by any intensivist. Of course, if there is any obstruction or if there is a surgical or a gastrointestinal pathology where you definitely have to bypass the pylorus. But as far as we, the physician intensivists are concerned, I think the dynamic ileus situation, the pseudo obstruction condition which we encounter, we would actually go and few cases of pancreatitis, I think we would definitely prefer nasojejunal feeding. I'm not aware of what was your another question?
No, this is the same question actually. Is there like any has it shown to be superior to nasogastric feeding, or that was any evidence about that, or is almost the same?
Yeah, that is the articles which I showed you.
It is not shown to be beneficial. Nasojejunal feeds.
If I may add, Mithilesh, as of now, we do not have any data which suggests that nasogastric feeding is better than nasojejunal feeding is better than nasogastric.
Yeah, because in pancreatitis also they have shown it to be similar.
Only in those patients where there is a probable high risk of aspiration, or in those patients where feeding intolerance is high, their nasogastric feed have shown to have a better delivery in terms of calorie and protein, and marginal decrease in the risk of aspiration. Otherwise, the overall outcomes, NJ versus NG, is pretty much not much of difference.
Same,
including patients with acute pancreatitis.
Yes, sir. My next question is for Dr. Sulagna. What I wanted to ask is that early feeding, because we'll start with hypocaloric feeding. No, so if we hypocaloric feeding we start, that should be better, no, because that will keep the mucosal gastric mucosal and the intestinal mucosa intact, and the translocation of the microorganisms may be reduced. So what I wanted to suggest is early feeding, but hypocaloric feeding should be beneficial in these patients, no?
So hypocaloric feeding is classically described as about 70 to 80% of the measured energy expenditure or estimated energy expenditure by the different equations that we use. But this also is and versus trophic feeding, which is described as less than 40%, that is 25, somewhere around 25 to 30% of measured required energy expenditure, required energies. Now it has, the trials that I have discussed, the studies that I have discussed, this has shown that trophic feeding is as good as hypocaloric or standard feeding. So with a lower target of less than 40% of the required energies, we can achieve this gut mucosal integrity. So we do not need a hypocaloric target of about 70 to 80% of estimated energy needs. Secondly, this even 70 to 80% of estimated energy and a protein of around 1 gram can lead to complications, can lead to reduction in the protective mechanisms like autophagy. Gluconeogenesis is not prevented, so it leads to hyperglycemia, and the delivery of proteins at this stage is not beneficial for the patient because the body is not assimilating this protein. The body is into a gluconeogenesis mode. It is taking the amino acids and making glucose. So even if we deliver macronutrients at this stage, it is not able to utilize them. Unnecessary, it is causing to overfeeding and the extra burden of calories that we are adding to the already heightened energy production with glucose. So therefore, not even hypocaloric feeding during the acute phase
probably trophic feeding is going to improve outcomes, as evidenced by the Nutria trial, as evidenced by the one of the effort, the nested cohort analysis of the effort trial that we have mentioned. Also, the latest effort trial, which has compared high protein delivery versus standard protein delivery early in critical illness. They have found worse outcomes with high protein delivery, especially in patients with acute kidney injury. So the evidence is going towards giving a protective.
What is your suggestion on this?
So protective trophic feeding to maintain gut mucosal integrity, but not to achieve targets of hypocaloric or isocaloric feeding, and also to keep a lower protein goals during this time, so that the body does not, the excessive loads of protein and calorie do not lead to overfeeding and increase mortality.
Thank you, Dr. Sulagna.
I think when we always say this in this times that less is more, but I always have that thought in my mind as a caution that less should not be very less also. So I think we should
to define what is very less, because already the body is producing so much of calories at the acute phase, and if you give calories, it may not be able to assimilate them. So the less has to be defined. If a patient can be in 3 days of acute early period of acute illness, maybe in 5 days. So every individual have different time points of shifting from catabolism to anabolism. So we have to identify when the patient shifts to an anabolic phase, where our given energy and proteins will be able, the patient can be able to utilize it. So that is why individualized targets and use of biomarkers is very, very important. And this is the future of nutritional therapy in ICU.
Perfect.
Thank you, Dr. Shrikant. Thank you, Dr. Sulagna.
Thank you so much.
Yeah.
I thank all the organizers for this wonderful opportunity. Thank you so much.
So now after this, session, view, counter view, and consensus, we come across the next session, which is a panel discussion. Panel discussion is on ARDS, and it is going to be moderated by Dr. Kaladhar, who is the Senior Consultant and Head of the Department of Critical Care at Yashoda Hospital. And the panelists are Dr. Rajesh Pandey, Senior Director and Head of the Critical Care in Max Super Specialty Hospital. Dr. Reshu is a Senior Consultant Critical Care Medicine in Guwahati Health City Hospital. And Dr. Anand Nikalji, who is the Director of MCRI ICU MGM College in Aurangabad. I would request Dr. Kaladhar to take the proceedings further.
Good evening, all. Welcome to the Hyderabad Intensive Care Symposium 8th edition. So I am Dr. Kaladhar. I am Senior Consultant Head of the Department at Yashoda Hospitals, Malakpet. So we are having the topic Acute Respiratory Distress Syndrome. So for this, I would like to invite Dr. Rajesh Pandey, sir, who is the Senior Consultant and Head of the Department from BLK Max Hospital, Delhi. And I would like to invite, good evening, sir. Good evening. Invite Dr. Anand Nikalji, sir. He is from MGM Hospital, Aurangabad. And Dr. Reshu Gupta is also there. Because of some personal reason, she is not going to join. So we will carry on forward with the discussion, sir. So for this, acute respiratory distress syndrome is a severe entity that we day in and day out we see in our ICUs. So acute inflammatory process which will be leading to severe hypoxemia. The patients who are having severe ARDS have the mortality up to 40 to 50%. And during COVID pandemic, we had seen a lot of patients suffering with it, and a lot of prone ventilations, ECMOs were being done. So to discuss this, we open up the discussion with Dr. Rajesh Pandey, sir. So we'll go into start with the definition of ARDS, sir. So Berlin and Kigali modification, and then we'll go on with the further discussions, sir. Rajesh,
sure. Thank you for giving me the opportunity. Just to bring some visual effect, I'll be sharing my screen, and so that the audience they can see what we are discussing. Are my slides visible to you?
Yes, sir. They are visible, sir.
Okay. So
The current definitions, which are likely to be changed soon, are Berlin definition of ARDS. And you can see on your screen comparison between the last 1994 American European consensus definitions and the 2012 Berlin definitions. The criteria are essentially the same, but the terminology like acute lung injury has been removed. It's no longer in use. So if you look at the timing now, ARDS is classified as anything that is causing respiratory insult maximum within a week after the trigger stimuli. And on X-ray or CT scan, it should show as bilateral infiltrates, which cannot be fully explained by effusion, lung collapse, or nodules. And of course, there has to be a non-cardiogenic source of edema. So the new definition gives us freedom to do an echo and rule out any cardiac cause so that we know that for sure it's because of the lung and not due to excessive volume loading or cardiac failure. And then based on the PF ratio, like before, it's divided into 3 categories: mild, moderate, severe. But the change is now it is mandatory to have a PEEP of more than equal to 5 centimeter of water. So mild is defined as the PaO2 between 201 to 300, moderate between 101 to 200, and severe less than 100, equal to 100. Now, if you see here, the inclusion of PEEP criteria have been made mandatory. Now, oftentimes if patient is on oxygen or on lower levels of, or on say HFNV, the system may not really be developing a PEEP of or CPAP of 5 centimeter. So how do we tackle those situations? Are they not ARDS? So this issue has been addressed by that hospital from Rwanda. That's from the town of Kigali. Now, the reason were different because they also were enthusiastic. They wanted to participate in the ARDS, network studies and all those newer things that were going on across the globe. I said we are resource limited, so we cannot have, ABG all the time. So they suggested that, let us forego the requirement of PEEP as a mandatory requirement. And instead they suggested that we can take a hypoxia threshold of SpO2 divided by FiO2. So this SF ratio, if it is less than 315, then these should be included. And of course, in addition, bilateral opacities either on X-ray or on lung ultrasound to make it very, very simple. I think there is a lot of merit, a lot of hospitals across India in smaller towns may not have ABG available or interpretation of ABG available all the time. And this is and saturation, everybody knows how to monitor. So this is a very good suggestion. And I think it helps us whenever the patient is on oxygen source, where we do not know what is the exact PEEP, like HFNO. Now, if you see the current surviving sepsis guideline recommends HFNO over NIV in, hypoxemic respiratory failure because of sepsis and septic shock. So we cannot call it ARDS unless there is, as per the Berlin definition, at least 5 centimeter of PEEP applied. But we are never sure with HFNO what is the extent of PEEP applied. We know the maximum CPAP could be 5, but then if there is mouth is open or the flow is not very high, this could be less. It could be 0.8 per 10 liters of the gas flow that is going on. So I think it's a fair point. Dr. Kaladar?
Sir. Yes, sir. Thank you for that definition, sir. I think you have been totally comprehensively, elaborately told. And we will proceed to the next question, what is the pathophysiology? What exactly happens in the lung when a patient gets severe ARDS or he suffers with acute respiratory distress syndrome?
Sure, thank you. I think that's a very important question. Now, this is a very old cartoon taken from a study by Gattinoni, who we know for the first time subjected these patients to frequent CT scans, and you can see then they were recreated using a software which used the Hounsfield unit, the gray-white marker to reconstruct the images.
And he showed that in ARDS lungs, there are three distinct zones that can be identified: normally aerated, poorly aerated, and non-aerated. And when we apply PEEP, there is extension of the normally aerated zone. Also, there is more recruitment of poorly aerated. As a result, the non-aerated gets reduced. So he showed it conclusively, and it was also shown in some animal models that, the alveoli behave differently. So they identified three different types of alveoli, and you can see here the alveoli on the left-hand side here. So at peak inspiration and peak expiration, there is little change in the size. This is the normal inspiration, normal expiration. But if you look at the severe ARDS alveoli, they open up during inspiration, but they're completely collapsing during exhalation. So these alveoli with the next breath will have to first get recruited, get opened up. So there is a lot of stress and strain because of this, and a lot of cytokine release. And as a result, we know that, the classically three phases have been described. So we have the initial exudative or edematous phase, followed by a proliferative phase. And if the body's natural defenses and whatever we are doing helps and the ARDS recovers, so it's because of the proliferative phase. If that doesn't happen, then goes into the fibrotic phase. And the same can be seen here in this cartoon. So here, this is a normal lung. So this is a normal lung filled with air. You have healthy bronchial epithelium, and there is a fine layer of surfactant, as you can see, and there are alveolar epithelium cells type 1 and type 2. And there are limited number of alveolar macrophages, and the capillary, as you can see, is all good. The endothelium, the wall lining is good. The interstitium is healthy with few fibroblasts. But what happens when the ARDS sets in? So you can see there is denudation of the bronchial epithelium. There's damage here. You can see that there is a damage to the pneumocytes as well. There is loss of surfactant. The lung alveoli gets filled up with fluid, which is rich in inflammatory markers, proteinaceous material. And there is complete breakdown, the leakage. There's interstitial edema as well, the widening of the space, interstitial space. Plus, you can see that there is leaky capillary as well. So there is damage to the endothelium, and there are platelet activation, etc. So this whole thing leads to a diffusion defect, and it's difficult for the oxygen to go into the blood capillaries and carbon dioxide to go out, which is, also the logic why there is a difference between end-tidal CO2 and the PaCO2 in these patients. So, like I said, they can recover. So you can see healthy epithelium, and the alveolar cells are being regenerated. The edema is getting reduced, and the fibroblasts are being regrouped. Endothelium is becoming healthy, or it continues to be, and there is a thick membrane. This is the stage when we find that CO2 starts increasing gradually, and then there is significant hypercapnia along with hypoxia. So that shows that the patient is not doing very well. And when we ventilate these lungs, there are different forces that are applied, and these cause different kind of trauma. So you can see when suppose we are keeping the ventilation volume, tidal volume less, but no PEEP, then there is significant damage, and this can lead to the atelectrauma, because repeated opening and closing will lead to damage and also cytokine release. If we are using high volumes, that can cause volume trauma, that is hyperinflation. And of course, because the pressure is high, there is barotrauma. And so what happens is, repeatedly, if these things are happening with each inflation and deflation, that leads to a lot of cytokine release. And these cytokines eventually, cause significant amount of damage. And if there is also sepsis, if there is gram-negative septicemia, there are bacteria also, then the apoptosis is further increased, and finally there could be multi-organ dysfunction and death. So in a nutshell, I would say that is the problem that we see in ARDS. So early identification and early management has been emphasized for this particular reason, because
If it is lays, for example, for ECMO, we say that initial 7 days is good, as early as possible is good. Beyond 14 days, steroids are bad, they kill more. And so I think early identification, early management, protocolized management is the key. Dr. Kaladhar.
Sir, so with this background, I think the regarding etiology also, sir, like most of the times it is direct or indirect type of ARDS. Most of the people generally they discuss like a possibility, like especially most of the forums, the discussion happens between direct versus indirect. So, and the prognosis depends upon that. So what is your opinion on that, sir?
If you look at all the studies that have been done, whether they are from ARDS network or they have been, lung safe studies and other studies which had large database, pneumonia remains the most common and most important cause of ARDS, which is a direct injury to the alveoli. So that is the, compared to this, the other less common causes would be when the source is exogenous or, it is coming through bloodstream, for example, in acute pancreatitis, in thermal injuries, in trauma, etc. The injury is not affecting the lung initially. So that starts from the interstitium, then goes into the alveoli. Whereas with pneumonia, it is the alveoli that are directly affected. There is a relationship to the, impact of treatment. For example, PEEP, the indirect or the indirect ARDS or extrapulmonary ARDS is said to behave much better with application of PEEP. The recovery is better, the mortality is less compared to, when the lung itself is affected first, like in pneumonias. We have seen what happens in viral pneumonias.
Yes. Yes, sir. Yeah. So with this background, I would like to ask Dr. Anand Nikhalji sir to chip in and discuss about the ventilatory management strategies and even non-ventilatory management strategies. So probably targeting on much evidence-based low tidal volume ventilation, PEEP strategies, and all other concepts. Sir. Thank you, Anand sir, to chip in.
Yeah, thank you, Dr. Kal.
Yes, sir. We'll proceed with your presentation, sir. So I would like to ask the next questions like how to like the guided ventilation. We are until now we are most of the times targeting on the plateau pressure and all. The driving pressure has come into the picture, and then transpulmonary pressure, esophageal pressure. All those things are already there. So recently we have a concept of mechanical power. So just I would like you to touch upon all these things. Just
okay.
Yeah.
So ARDS ARMA trial showed us two things that were definitely associated with improvement in the outcome, almost 8 to 9% improvement in the mortality or decrease in the mortality. They were a tidal volume of 6 ml per kg of ideal body weight and a P-plat of less than equal to 30 centimeter of water. So that remained the strategy for almost 15-20 years. And until Amato then started relooking at the data. So Marcelo Amato from Brazil did not do a new study. He looked at the old published study because he hypothesized that the difference between the plateau pressure and the PEEP, which he called as the driving pressure, which is the static pressure, would be a determinant like the low tidal volume as well as the plateau pressure in terms of reduction in mortality. So he wanted to see this, and he relooked at the previously published studies, and then he got very interesting data. So if you see, what he showed was here that this is the risk of death in the hospital. If the driving pressure kept on increasing linearly, but the PEEP remained constant, the mortality was also high. As you can see, the mortality also increased. Whereas if the PEEP was increasing, but the driving pressure remained constant, the mortality also did not change. It remained more or less constant. And conversely, if the PEEP was rising,
but the driving pressure was reducing, the mortality also significantly reduced. So he successfully showed that, a reduction in the driving pressure, once again, P-plat minus the PEEP, is also responsible for reduction in mortality. He did not say that, this is better. He said that in addition to what we already know, that is limiting the P-plat and limiting the tidal volume, this may be another determinant that reduces the mortality. And he identified a cutoff, which all of us now believe that if it is driving pressure, we can keep below 15 centimeter of water, then the mortality is less compared to when it is high. So this was the concept of driving pressure, which, now is being widely used to reduce the stress and strain. Whereas the concept of transpulmonary pressure is different, because here the proponents believe that the driving pressure is a static pressure. It doesn't take the pleural pressure into consideration, which is one of the very important pressures. So the issue was, how to measure the pleural pressure. So a surrogate for pleural pressure would be an esophageal catheter, which is placed close to the pleura. There are ways of, fine-tuning the placement, and then the pressure that we get, they closely reflect the changes in the pleural pressure. So the plateau pressure minus the pleural pressure was called the transpulmonary pressure, and pleural pressure was substituted with esophageal pressure, which is a surrogate for this. So this concept was highlighted in one of the seminal papers in New England Journal of Medicine, where they showed clearly that transpulmonary pressure does not really change much between spontaneous breathing and intermittent positive pressure ventilation when the lungs are healthy. As you can see here, it remained +8 in both the situations. Whereas when we have a stiff chest wall, so for example, there is a massive pleural effusion, or there's a massive ascites, or for some reason the pleural pressure is high. Now we know that when the pleural pressure is high, the alveolar pressure is also high, but look at the transpulmonary pressure. This is only 5 centimeter of water. So from here, we got a hint that possibly these lungs, if we continue using a plateau pressure limit of 30, may not be adequately ventilated. So there may be a lot of atelectasis. So these lungs would require a high acceptance of a higher peak plateau pressure, because the transpulmonary pressure is low. So the inflation will be a problem here. That is why when we measure it, we always try to keep the plateau pressure on the positive side. So that is the idea comes from here. And they also highlighted, that even when the plateau pressure increases significantly, as is seen in trumpet players when they are playing a high note, their lungs do not burst, they do not get barotrauma, because there is commensurate increase in the pleural pressure. So the net transpulmonary pressure remains within acceptable limits. So this concept has also been accepted to prevent the lung injury. And most ventilators, even those who are more than a decade old, they also have, a port where we can connect the esophageal catheter to monitor the pressure. The newer ones will have the algorithm inside in the software, so they will give us directly the transpulmonary pressure. Whereas in the older generation, we have to calculate it. So this is again very important, because we can directly measure the stress, etc. And this is also very important to understand. It's been said that patients who are breathing very deeply, generating much higher negative pressure, high tidal volumes, they may cause self-inflicted lung injury, PCL, patient self-inflicted lung injury, which we can understand, because when these patients are on NIV, we are only looking at the higher pressures. We do not know how much negative pressure they are generating. So as has been highlighted here, the alveolar pressure is only 10, but the pleural pressure that they are generating is -15. So the net transpulmonary pressure becomes extremely high, 25 centimeter of water, which may be causing significant damage. So whatever we did during COVID-1 and COVID-2, if we continued like this, we may have caused significant harm to our patients. So this is, this makes our understanding much better. The problem at present is the good esophageal catheters are not available in the market. The triple lumen ones are not available. So the technology is there, the machines are there, but the disposables are a problem because when they were available, everybody was using them. So this is something which can be used to fine tune the ventilation. Your last part was the mechanical power. Now, PCLI gives a hint about the mechanical power because the overall ventilation is more. So far, as you have seen here, that we learned about barotrauma way back in 73, then about volutrauma in experiments, that it's the volume that kills or that causes damage rather than the pressure. And then we knew about the atelic trauma and the resultant biotrauma because of repeated opening and closing of alveoli. And then we realized that there is also the mechanical power which can cause something called ergotrauma. So that brings into focus the question that what is this mechanical power? Now, there are excellent papers again written by Gattinoni, which highlight that essentially the ventilator-induced lung injury may be based on the tidal volume, PEEP, transpulmonary pressure, driving pressure. So far we were fixated with the pressures and the volume only based on whatever data we had. So now what they are saying is it is the inspiratory flow and respiratory rate which are also responsible for causing villi. So in addition to the tidal volume and the PEEP and the transpulmonary and driving pressures, we have to look at the minute ventilation, the inspiratory flow and the frequency as well. So all these, when they are combined, it's basically the amount of energy that is being transferred from the ventilator to the lungs that causes the injury. This energy has been called the mechanical power. And the mechanical power is basically the energy which is delivered to the respiratory system over time and is a product of absolute proximal airway pressure and recent changes in the volume and the respiratory rate. And it's a variable which has been, shown here, as you can see. Depends, it takes into consideration the tidal volume, driving pressure, flow rate, PEEP, etc. And there was one very nice study that I would like to mention here, which looked at its impact on mortality, mechanical power in ICU care in ARDS patients. And what essentially, I'll just give the summary. What it showed that as such the mechanical power and transpulmonary, they calculated transpulmonary mechanical power also does not influence the ICU mortality when there was same amount of PEEP and two other components of mechanical power like respiratory system elastance and airway resistance. They were not different in determining intensive care mortality, but when mechanical power was normalized to the well-inflated tissue compliance, and it was then independently associated to ICU mortality in patients who were otherwise similar in terms of ARDS severity, in terms of age, in terms of their severity of illness. So transpulmonary mechanical power when normalized to well-aerated tissue was a better predictor for outcome compared to mechanical power, which was normalized to respiratory system compliance only. So this is, a concept that is emerging. Now, we understand that there are a lot more things. Whatever is causing significant inflation is also causing significant damage. So possibly tachypnea would be causing more damage. Higher tidal volume or higher inflation with NIV will be causing more damage because the mechanical power is more. Now, how to get this in the ventilator? Possibly the newer machines may have something. The machines that I'm using do not give me mechanical power directly. I have to calculate it. So, but these are for the youngsters who are listening to this, discussion. These are emerging concepts because we are trying to go beyond the conventional low tidal volume and the P-plat. Now, whether this can be put into practice, whether this can in a large randomized controlled trial show reduction in mortality in ARDS patients is we have yet to see, because these are smaller studies, one of the study that I showed. So I hope that throws some light on the subject.
Yes, sir. Yes, sir. Yeah, as the ARDS progresses, we'll land up in situation like refractory hypoxemia will be there. So where we have limited options most of the times, and everybody knows the role of prone ventilation. Now more and more people are using it. But a few centers, they use ECMO and extracorporeal carbon dioxide removal. I would like to ask you to just throw a light on these prone ventilation, ECOR and even ECMO strategies, how they will be helpful in tackling the refractory hypoxemia patients, sir.
Sure. Proning, I don't need to go into the details. It is very well established among Indian ICUs. We know the benefits of proning. The heterogeneity across the lung is significantly reduced. It itself recruits the lung. And we know for sure that the change in the position from dorsal to ventral and ventral to dorsal does not cause so much change in the vasculature or the blood flow as it does in terms of ventilation, which has a beneficial effect. The net effect is a gain in oxygenation. So proning for 16 hours and beyond was shown very, very clearly by Guerin et al., the French group, to show mortality benefit. And if you look at the current surviving sepsis guidelines, even in sepsis-induced ARDS, they are suggesting moderate to severe ARDS, they are suggesting at least 12 hours of proning. So proning is a well-established thing. So one important issue here is we should try proning, because that is a definitive treatment before jumping the gun and moving to ECMO directly. Unless the proning trial fails to improve the condition, so that all the speakers, including Gattinoni, who has been working on extracorporeal system for more than 40 years now, so they all said very, very clearly when they came to India that proning must be done, then only we should move to ECMO. So coming to the next part, which is ECMO, it's very good and very exciting, and majority of the Indian ICU tertiary level ICUs are using ECMO. Some are using on a large level. I mean, the numbers are more, but it's being used everywhere across India. Now, to the students and to the listeners, when we look at the evidence, whether it saves lives, the first study that was done was a British study. This was Caesar trial. And here what they did was they divided the severe ARDS patients into either they would receive only conventional ventilation or they would be subjected to ECMO. And for ECMO, they were moved to one center, one specialized ECMO center at Leicester. And they also did an economic analysis, and they showed that there was significant mortality benefit in the group that underwent ECMO. But there were a lot of issues with this study because they did not standardize the ventilation arm. They did not give directions. It was left to the discretion of the clinicians. So that did not bring uniformity in ventilating these patients. And because patients had to be transported for ECMO to the specialty ECMO center, so some patients improved by the time they reached, there. So ECMO was not given. Some patients died en route, so ECMO could not be given. So essentially about 25% of the patient in the ECMO arm could not be given ECMO actually. And the study, what they did was the analysis was not by intention to treat. So that again, per protocol analysis is not as robust as the intention to treat analysis. So that is why there was a need, that was felt by the French counterparts. We know there is a, British-French rivalry. So they thought they could do a better job, and they planned under the leadership of Alan Coombs another trial where they said we will standardize the ventilation as per the ARDS protocol, and we will do early application of ECMO. So they sort of made it into a very good trial, but and they were expecting about 5% mortality. At least 5% mortality benefit should have been there, although their expectation was much higher. And again, as you can see, the most common cause they could get in their series was pneumonia. Surprisingly, they could not show, let me remove this from here. They could not show a mortality benefit as per their expectation. But for ethical reasons, patients who were in the controlled ventilation arms, when they reached a stage where they would otherwise have died if they were continued on mechanical ventilation, they were shifted to ECMO. So among the group of patients that crossed over to ECMO because they were doing very badly in the mechanical ventilator, there was quite significant improvement in the mortality. A lot of these patients improved. So although statistically, as per science, this was a negative trial, but it definitely showed a mortality benefit in the most sick patients who were on mechanical ventilation. So I think the lesson that we can draw is, and that's what the current surviving sepsis guidelines also recommend, that in patients who are otherwise not improving or are deteriorating on mechanical ventilation, ARDS patients, we should consider veno-venous ECMO, but they say that it should be done in centers which have the experience and which are doing more number of ECMOs. So that is the story of ECMO, and now I think you and I and everybody is doing ECMO. So the other thing that you mentioned was about ECOR.
Yes.
We know a couple of companies are going to launch ECOR in next 2-3 months now in India. So ECOR basically is, I would say, a partial extracorporeal technique. The advantage is one can use a hemodialysis machine, which will have a software for ECMO, and using the same cannula, a double lumen catheter, we can, and using lower flows, using a smaller medium-sized oxygenator, we can attempt to remove the carbon dioxide. Now, this has definite indication in severe COPD patients, where the CO2 we are not able to remove even after intubation and mechanical ventilation. But it will have a role even in ECMO patients, because oftentimes when you do not have full ECMO available, or ECMO, you have one ECMO that is utilized, you have more patients, there comes a stage when the CO2 starts rising and it exceeds and starts causing respiratory acidosis. I think we can maintain the patient with a lower PaO2 of say 58, 60, but when the CO2 goes up causing severe respiratory acidosis, we need to wash out that CO2. So that's where, in my opinion, we can use ECOR even in ARDS. So I think this will be adopted by the Indian ICUs very well once it's launched, because your machine has a dual use. It can be used for CRRT as well as you can do ECOR. So it will be considered less invasive, so the management would be easier. I think the acceptability across units which are doing less number of ECMO would be quite high for this technique. Dr. Kaladhar.
Yes, sir. Thank you, sir, for your insights. It covers overall. So, Dr. Anand, sir? Yes, sir.
I think Dr. Pandey has very well discussed about the etiology and pathogenesis and pathology or pathophysiology of ARDS. And when we talk about the ventilator management, Dr. Pandey has already told you that ventilator is a mainstay of treatment. Actually, it's life-saving. But at the same time, there's a high risk of ventilator-induced lung injury by multiple mechanisms, as Dr. Pandey sir has out.
Sir.
So as I told you, mechanical ventilation and supportive therapies are the mainstay of treatment. Though mechanical ventilation is life-saving, and over a period of time, we could have a better mechanical ventilation and mortality is definitely reduced with the ventilator use. But always you have to remember that it can cause a secondary injury, that is ventilator-induced lung injury. So choice of modality of ventilator is very important. It matters whether we should use non-invasive ventilator, HFNC, or we should intubate. So right decision at right time is actually a key in managing a patient with ARDS. So just I wanted to make a comment on patients who are hypoxic and admitted in ICU with ARDS. There is a study in a patient with hypoxic failure, particularly ARDS patient. They reported increased mortality in association with NIV when compared with patient treated with high flow nasal cannula. So there are multiple studies shown that NIV is not a good choice, particularly patients who have got severe kind of ARDS when PF ratio is less than 150. So if PF ratio is less than 150 is an independent predictor of mortality in ARDS patients. Another thing is that when we are thinking of using NIV, particularly in mild kind of or probably extrapulmonary kind of ARDS, the type of mask also very important. So there are a lot of new data coming in with the helmet mask, which has got better outcome as compared to the mask which we are routinely using, that is orofacial, nasofacial mask. Then, as I told you, and as I'll discuss that the etiology of ARDS is also important, whether it is a pulmonary or extrapulmonary, and definitely extrapulmonary ARDS has got better prognosis, and you can probably try HFNC and NIV in this kind of patients. But definitely in severe ARDS, NIV is not a good choice. The lung safe study, which sir also has mentioned, the subset analysis of the lung safe study actually mentioned that the severe ARDS, that is PF ratio less than 150, is an independent predictor of mortality if we use a non-invasive ventilator. So I just wanted to make everybody caution about using HFNC and NIV in severe ARDS, particularly when PF ratio is 150. Clearly high mortality in patients with NIV, and what happened after COVID probably, many people, many intensivists and residents are started using NIV in high flow as a initial choice of therapy. Then most of the patients with severe ARDS require intubation and ventilation. And sir has already told you that there are heterogeneous involvement of lung in ARDS, where some lung is normal, some part of the lung is edematous, some is consolidated, and some part of the lung is collapsed. The principle of ventilation is to prevent over-distension or overstretching of a normal lung. At the same time, we wanted to prevent atelectotrauma of a collapsed lung. So that actually makes the concept of low tidal volume minute ventilation in patients of ARDS. Next slide. So we all know that the landmark trial, which is published in NAGM in 2000, actually changed the practice of mechanical ventilation. This trial, which is a randomized controlled trial, compared low tidal volume, that is 6 ml per kg of predicted body weight, compared to 12 ml of predicted body weight. And if you see, there's a significant mortality benefit in a patient receiving low tidal volume as compared to traditional volume of 12 ml. And there is a more number of patients are having ventilator-free days as compared to the traditional tidal volume patient. So after this trial, we actually started using low tidal volume ventilation, that to around initially with 6 ml per kg of body weight. Next slide. So this is called as lung protective ventilation after this ARDS NET or ARMA trial. So how we can ventilate this patient? So patient should be actually calculated on predicted body weight. There's a standard formula. I'm not going into detail of that. And this trial actually used a volume assist control mode. And initial tidal volume they targeted as 6 ml per kg of predicted body weight. And the respiratory rate was kept slightly high to match the baseline mechanical ventilation, baseline minute ventilation. That you all know that patients with ARDS, they are having high respiratory rate. And once we intubate them and keep them a controlled ventilation with sedation paralysis, a minute ventilation grossly comes down and patient has chances of getting hypercarbia or CO2 retention. So another important part of this low tidal volume or lung protective ventilation is to keep plateau pressure less than 30. So initially volume assist mode with 6 ml per kg of penetrated body weight, respiratory rate which probably matched to the baseline minute ventilation, and keeping plateau pressure less than 30 was the initial target of mechanical ventilation. Just continue with the previous slide. So subsequent adjustment, once you intubate and started with 6 ml per kg of body weight, and your goal is to have plateau pressure less than 30. If your plateau pressure is more than 30, I think everybody knows how to calculate a plateau pressure. You have an inspiratory hold button on all of the good ventilators, and you keep inspiratory hold for few seconds, 5 to 10 seconds, and there is no flow, and then you calculate plateau pressure. If plateau pressure is more than 30, so decrease the tidal volume by 1 ml per kg. So you may go down to 5 ml or 4 ml to keep plateau pressure more than 30. And if your plateau pressure is less than 25 and your tidal volume less than 6 ml per kg of body weight, you can increase tidal volume by 1 ml per kg. There is a chance of auto PEEP or breath stacking with a low tidal volume ventilation. Then probably you will have to slightly increase the tidal volume to 1 ml per kg, keeping your plateau pressure less than 30. So this is the way you calculate the plateau pressure by inspiratory hold alarm, and you can see there is a plateau pressure of 31 in these patients. Next slide. So this low tidal volume ventilation has definitely shown mortality benefit not only in ARDS patient, in multiple etiologies of respiratory failure, and there is a multiple trials even after ARDS trial showed a benefit of low tidal volume ventilation. But this low tidal volume ventilation may cause permissive hypercapnia. As you all know, the hypercapnia, that is respiratory acidosis, when your pH is less than 7.35 and PCO2 is more than 45. Usually this is well tolerated and we should accept this respiratory acidosis, and that's why it is called as permissive hypercapnia. If pH is less than probably 7.2 in respect of PCO2, the only way by which you can improve the minute ventilation by increasing RR. Increasing RR to be actually increased with keeping an eye on an I ratio. There is a high chance that if there is a less expiry time because of increase in the respiratory rate, there may be generation of autopy. Then another issue is work of breathing and patient ventilator dystonia. So in patients who are having a low tidal volume ventilation, work of breathing and patient is quite tachypneic. So probably in such patients, you may try to keep a tidal volume around 7 ml per penetrated body weight. And this patient require increased sedation soon after the initiation of low tidal volume ventilation. And need of this sedation and probably muscle relaxation does not appear persist, depends on patient to patient. Another issue with low tidal volume ventilation is bed stacking, which is a manifestation of dyssynchrony between patient and ventilator. And if there is a frequent breath stacking, so more than 3 stacked breaths per minute, and so you may have to slightly increase the tidal volume and keeping a watch on plateau pressure. So this is the way we can actually initiate the mechanical ventilation, invasive mechanical ventilation in ARDS patient. And the oxygen targets are not like you have to keep a target of around more than 95 or 97, 98. But you can have a reasonable oxygen target that you should target a saturation of 88 to 90 and PO2 between 55 to 80. And the next important goal in the management of mechanical ventilation in ARDS patient is to setting a PEEP. So there is a chart which is given in the ARDS net trial with a standard PEEP of titrating PEEP on the basis of FiO2 and saturation. You can have a low PEEP and high PEEP trials depending on this chart. So PEEP actually prevents the alveolar collapse during exhalation. PEEP decreases mortality by increasing end expiratory lung volume. It increases lung compliance, respiratory lung compliance, and it reduces driving pressure. The driving pressure is one of the important factor which is now studied in multiple studies. And if driving pressure is more than 15, probably mortality is very high in multiple retrospective observational studies. So keeping driving pressure less than 15 by increasing PEEP is another important aspect of titrating PEEP. What PEEP can cause harm, that it can reduce the cardiac output, it increases pulmonary vascular resistance, and it increases alveolar dead space. As I told you, it can cause sometimes our aim of giving PEEP is to recruit the lung and prevent the recruitment, but sometimes it can cause overinflation if you have more than required PEEP. Multiple studies actually evaluated the mortality benefit of the PEEP in ARDS patient, the mortality was lower with higher PEEP in severe ARDS. So if ARDS is severe, the mortality benefit is high. But there is no much significant difference in the mortality with high PEEP in a mild kind of ARDS. And there are multiple ways by which you can titrate the PEEP. The particular 1, 2, or 3, 4 method is not superior over other. There are a lot of conflicting study about the method of PEEP titration. You can use PEEP FIO2 table, which is given by ARDS net trial, to titrate the PEEP. Then you can use pressure volume curve. This is very important. You can use inspiratory curve. Inspiratory curve when there is a lower inflection point, which actually tells us that you are actually giving PEEP more than a where lung can get collapsed. Then you can actually titrate the PEEP depending on the stress index. Then expiratory curve is also important. The point of de-recruitment, best compliance on expiratory curve, and point of maximum hysteresis. They are the very good options by which you can titrate the PEEP. Then esophageal manometry by assessing pleural pressure. Then lung volume and expiratory lung volume, and you can use imaging like bedside ultrasound, CT scan, which is not very possible in ICU patients, or X-ray to titrate the PEEP. So these are the way by which you can titrate the PEEP. Another way is having a using PEEP and recruitment and respiratory compliance. If you increase the PEEP and your compliance is improving, till that point you can increase the PEEP so that you can have less driving pressure and a better compliance of the lung. This is another randomized clinical trial which compared esophageal pressure guided strategy versus empirical high PEEP FIO2 strategy, and there is no significant difference which was found with using of esophageal guided PEEP titration as compared to your PEEP FIO2 strategy. Next slide. So driving pressure, I think Dr. Pandey has covered. Yeah. So this is about initial ventilation, lung protective ventilation, titration of PEEP. Another asked me about the recruitment maneuvers. Another important point in a ventilation lung ARDS patient. These recruitment maneuvers are they are transiently and sustainedly increase the transpulmonary pressure, designing to open up the collapsed alveoli. So recruitment maneuver used to open up the collapsed lung, and PEEP then used to prevent the cyclical collapse as a part of open lung approach. So this recruitment maneuver actually increases the end expiratory lung volume, improves the gas exchange, particularly oxygenation, and actually decreases the lung ventilator-induced lung injury. So this is the way you can see the homogeneity of lung can be achieved with recruitment maneuver. So continue with the previous slide. So from A to D, if you do an incremental pressure and you infect the lung with incremental pressure, you can actually have better lung recruitment. And if you add PEEP to this, you can prevent the de-recruitment of the lung. So the recruitment actually improves the lung compliance, improves the oxygenation, and prevent the lung injury. So that is what importance of recruitment maneuver. And there are various methods by which you can actually achieve recruitment, or you can do the recruitment maneuver. If patient is having underlying disease like patient having removal of oxygen by taking out the mucus plug, diuresis or treatment of infection can actually cause recruitment. Then sustained inflation followed by decremental PEEP is another way of recruitment. Stepwise recruitment with incremental PEEP, airway pressure release ventilation, high frequency oscillation, sigh breaths, and prone positioning. These are the methods of achieving recruitment. So this is about a recruitment maneuver. So far, the recruitment maneuver definitely improves the oxygenation, but most of the study has not even showed mortality benefit by recruitment maneuver. So over to Dr. Kaladhar.
Sir, so I think as of now we discussed mostly about the ventilatory management of the ARDS. I think probably discuss about the non-ventilatory management or any like pharmacological interventions that can also help in achieving better oxygenation.
Yeah, please go to the next slide. Yeah. So there is no proven pharmacological therapy effective so far in patients of ARDS. Multiple drugs like steroids, inhaled nitric oxide, surfactants, some novel agents, fluid management have been tried, like N-acetylcysteine, antifungal, everything has been tried, but no pharmacological therapy so far seems to be effective in ARDS management. About fluid management is very important and quite controversial topic in management of ARDS, whether we should give a conservative fluid or liberal fluid. The patients with ARDS having a increased risk of pulmonary edema because of the increased vascular permeability. So there is a definite challenge between balancing on one side a tissue perfusion and oxygenation compared with the fluid overload and pulmonary edema. So this is quite challenging. So overall goal is to minimize and eliminate the positive fluid balance. Next slide. So this is a landmark study published in NAGM 2006, and they compared two strategies. One is liberal fluid and one is a conservative fluid management. It is a large prospective randomized control trial about the conservative and liberal fluid management in almost 1,000 patients, and they use central venous pressure, pulmonary artery wedge pressure, whether there is a shock or not, oliguria, and ineffective circulation is a marker of their fluid management. Fluid diuresis inotropic agents were used to achieve desired variables. As compared with the liberal strategy, conservative strategy has improved the oxygenation index, lung injury scores, and number of free ventilator-free days. So in this study, in a quite good study of 1,000 patients, they show that definitely the conservative fluid management scores over the liberal fluid management. So in ARDS patient, positive fluid balance has been associated with prolonged mechanical ventilation, longer ICU and hospital stay, and higher mortality. So definitely we have to have a conservative approach in management of fluid. We should not have positive fluid balance, rather than we should have a negative fluid balance. Fluid management may require different approaches depending on the course of the ARDS. So probably in early ARDS there is a high risk of pulmonary edema, and in late ARDS there may be change in the fluid requirement. So depending on the stage of or time of ARDS, we have to optimize our fluid therapy, and it again depends on the phenotype of the ARDS. Then about the inhaled nitric oxide, it is a powerful vasodilator, improve the ventilation perfusion mismatching with dose dependent improvement in the oxygenation. Its use in ARDS is evaluated in multiple clinical trials. The results are consistent with the improvement in oxygenation. There is no firm effect on the mortality. So inhaled nitric oxide may be considered in patients with refractory hypoxemia, keeping in mind that potential for its side effects and fact that the benefit is limited and time limited effect we may get. So not very good option so far, not very proven option. Then steroid, one of the most controversial topic in ARDS since last almost 20 years. Steroids have been tried in early ARDS, late ARDS, and even they are tried to prevent ARDS in few of the condition. So in early ARDS, it's characterized by, we know that it is an inflammatory process, strong inflammatory process, and it is logically thought that anti-inflammatory drug like steroid may be beneficial at this initial stage. Over the last few decades, studies have reached out different conclusions when assessing the effect of steroid on the mortality. Recent guidelines from SCCM and ESICM suggest that the use in patients with early, moderate to severe ARDS when PF ratio is less than 200 can be used within 14 days of onset. So this is a recent kind of a comment, but this recommendation is conditional and with a moderate quality of evidence. Remember, steroids can have multiple side effects. It can cause hyperglycemia, fluid retention, electrolyte imbalance. It can cause pancreatitis, infection rate, which is very common in ARDS patient. Even if patient is having non-infective ARDS like pancreatitis or trauma or even a dengue, malaria, this patient can get secondary bacterial infection with steroids. Then with neuromuscular weakness, is very high when we use steroids, and that we are actually seen in patients with COVID also, and GI bleed. So considering these multiple side effects and very minimal benefit in early ARDS, we have to really judge whether this patient of ARDS requires steroids or not. Next slide. There are a few trials. There are 9 trials evaluating the role of corticosteroids in the management of ARDS in various stages. Out of 9, 4 trials evaluated the steroids in prevention of ARDS, while other 5 focused on the treatment of ARDS on variable period of onset of ARDS. Trials with preventive steroids, mostly using high dose of methylprednisolone, showed negative results, with the patient in the treatment arm showing higher mortality and rate of ARDS development. So there's no role in prevention of ARDS. In fact, it causes higher mortality. Previous slide, please. Then early ARDS showed a variable results, somewhat favoring use of steroids to reduce the morbidities. And then late ARDS, this drug has no benefit and associated with higher outcome. So far, we can just say that in early ARDS, there is some role of steroids in the ARDS, considering multiple side effects. This one randomized controlled trial published in Chase 2007 about a methylprednisolone infusion in early severe ARDS. The prolonged corticosteroid use in early ARDS was associated with significant decrease in the ICU mortality, 20% as compared to 42%. But the problem with this study actually shows a positive trial about the steroid, but it is a poor matching between the two groups, and it's an open label trial, so there is a bias about this trial. Next slide. Then, as you asked me about some novel agents, recently this vasoactive intestinal peptide, that is VIP, is marketed by Juventus as the name of avectidil, is used in patients of ARDS. Initially they used in COVID, now they recommended in ARDS of any kind. It has got multiple effects like preservation of pulmonary tissue, inhibits alveolar epithelial cell and apoptosis. VIP decreases the pulmonary inflammation. This vasoactive internal peptide promotes synthesis of pulmonary surfactants. So by this, it has got multiple beneficial effects, and in very few trials, it has shown that there is a benefit of giving these drugs. This has now been approved by Central Drug Standard Control Organization in India for treatment of ARDS in patients with COVID-19 from April 22. So I don't have much of an experience of using this drug. I use in a couple of patients, but I think this small experience is not enough to comment on this drug. But this is a recent novel drug, is available in the market. Over to Dr. Kaladhar.
Sir. Okay, sir. Thank you, sir. Thank you, Rajesh Pandey, sir. And thank you, Anand, sir, for giving your valuable insights and sharing your clinical knowledge pertaining to ARDS topic as such. And I thank Dr. Srinivas Samvedam, sir, and its team for giving the opportunity to moderate on the session of ARDS. Any final thoughts from you, sir, Rajesh Pandey, sir, and Anand, sir?
No, I think this has been very nicely summarized. The session by Dr. Anand Nikalji was very informative. So he has covered virtually everything, which highlights, one of the things that we see, if you look at the trend in the randomized control trials, they show a consistent reduction in the ARDS related mortality. But if you see in our day-to-day practice and in one of the large observational trials by Jason Pua et al., it's more or less remained unchanged between 30 to 40%. And our clinical things, because we are not in a position to exclude any patients like the ARDS network trials, we know for sure the pregnant females were excluded and many other patients were excluded just to bring uniformity to the trial. So our clinical practice resembles more like the results, the mortality results of the seen in the observation studies, which still are the same. So whether this vasoactive intestinal peptide will make a dent, I'm not too sure. Our limited experience, very limited exposure has not shown that this is a wonder drug, but I think I agree with Dr. Anand that we need
large study to look at the impact. And unless the Western world shows interest and does a large-scale study, we'll still be using it, based on anecdotal experience. But this is one of the only rays of hope as far as pharmacological treatment is concerned. So I think Dr. Anand has amply highlighted. One thing I would like to tell the viewers that, he said about recruitment. So now the new surviving sepsis guidelines clearly say that the recruitment done like in the ART trial where you are going for incremental PEEP is not to be done because there was high mortality associated. So we are back to from where we started. The conventional way of doing recruitment, 30 centimeter for the CPAP for 30 seconds, 40 for 40, 50 for 50. So that is what the surviving sepsis recommends. And I think all said and done, ARDS continues to remain a very difficult clinical situation, and early intervention, early proning, early identification, early ECMO would be the key to patient survival.
Thank you, sir.
I just wanted to add for everybody, I think I thank Dr. Rajesh Pandey sir for giving a very concise and brief overview about the driving pressure, mechanical power, and all other modalities of the treatment in ARDS. Probably we need to intubate this patient at right time. A delay in intubation is clearly a risk factor. And another thing which I think Dr. Pandey can highlight that with a pleural pressure monitoring is going to help us in titrating PEEP, which probably most of the ICUs are not having right now.
Well,
patients with obesity and high abdominal pressure patients.
I understand your question because when we demonstrate in the mechanical ventilation workshop, we show the lung very, very clearly that it is not fully inflating, it remains atelectatic. And when we take it to the positive side, the transpulmonary pressure, the lung inflates. So atelect trauma can be significantly reduced. But to answer your question, whether that translates into significant mortality benefit, I think we need to have a large-scale study looking at this. These are physiologically sound, logics for using this to titrate at least. Rather than looking at the direct impact on mortality reduction, this will definitely cause reduction in the lung stress and strain. So I think it will reduce the villi. So possibly this is fine-tuning the ventilation a bit more precisely, because otherwise, we are just groping in the dark. That's how I would put it. And looking at a significant mortality reduction would possibly require, more studies, bigger studies.
Yes. Yes, sir.
So, your comment on use of steroids?
Steroids, again, very, very controversial. So we in India we saw what happened to COVID patients and the kind of mucormycosis that we saw, including rhinocerebral, because the sugar was very poorly controlled in these patients. I think it calls for a word of caution because these steroids are like the AK-47, they kill indiscriminately. So there is generalized immunosuppression. And if you look at the precision medicine, the way we are going now, people are looking at very specific, targets and identifying those targets and then targeting those targets is the way the scientists are proceeding as far as sepsis is concerned. ARDS, I do not know because the pathophysiology of sepsis ARDS more or less, looks similar, but to follow those kind of treatments, targeted treatments, we need to identify. So are there enough markers which are immediately available? I don't think we have anything. Yes. The concept of phenotype is in infancy. We know there is a hyperinflammatory and there is a hyperinflammatory, group. And the hyperinflammatory, everything is very serious and compared to hypo. So possibly there's an attempt. I think this will have larger implication for research. So maybe you select out and you choose the hyperinflammatory group and then see the impact of these therapies whether it makes a difference rather than clubbing both group of patients together and then seeing the benefit. So I think the research will refine more, and possibly the researchers can provide more answers in the future.
Okay, I think with the interest of the time, probably, your final comments will take, sir, and close the sessions.
I think overall this was an informative session, and thank you, Dr. Kaladhar, for asking the right questions and the pertinent questions. And I thank you for this, and I also congratulate my good friend Dr. Srinivas Samavedam for organizing this HICS. Because I know these are difficult times. So congratulations to him and the entire team. Thank you very much.
Anand sir?
Yeah, thank you. I think we left with 6 ml per kg of minimum tidal volume treated body weight, a titration of PEEP, proven ventilation, and ECMO probably. These are the probably evidence-based guidelines for the management of ARDS. Very well conducted panel discussion, Dr. Kaladhar. I think Dr. Pandey we know that he is a very senior and very good speaker and orator with a very good knowledge on the ARDS. He has given a very good insight to all of us. And thank you, team HICS and Dr. Srinivas. Thank you.
Thank you, both of you, sir. It is very much useful to the students overall. And thanks HICS team for providing the opportunity to moderate this. Thank you, sir.
Thank you, sir.
Yeah, it has been a very nice discussion, panel discussion. Thank you, Dr. Rajesh sir, Anand sir, and Dr. Kaladhar for conducting it. Rajesh sir, would you like to add anything else?
I think most of the things have been covered. It's just that, whenever I see students attending the workshops, they are very enthusiastic, and whatever they learn, they try to correlate it to reduction in mortality. And unfortunately, when that doesn't happen, they are disappointed. So, but at least they are practicing the right form of science. So they should not get disheartened. And that's the way we have also learned, 20, 30 years back. So I think ARDS is still a very exciting field for the researchers. So in next coming few years, I think a lot of information will flow, and we would know how to further fine tune. And from protocolized, we have moved to personalized, and now we are moving to precision medicine. So I think the science will provide us the answers. And thank you very much, Dr. Mithilesh.
Thank you, sir. Dr. Kaladhar, would you like to say something?
Hi, good evening, Dr. Mithilesh. Good evening, sir. Rajesh Pandey, sir. I think it was a very good session. Really, everything was enumerated and everything was put forward, and even including recent literature, especially Pandey sir was stressing upon and telling in detail about the mechanical power. Anand sir explained in detail about ventilatory and non-ventilatory management, even the recent drug like aviptadil. But yeah, still there is a lot of research that has to go especially using this drug, and any improvements with her and any good outcomes with the drug we have to see. So probably it was a very good discussion. Yeah, I also thoroughly enjoyed, and everything was touched upon. Nothing much to add from my side as such. Thank you.
Thank you so much. Now we move to the last panel discussion for the day, and it is on weaning. It will be moderated by my dear friend Dr. Manindra and Dr. Arif Pasha, Ram Gopal sir, and Dr. Rekha. They will be the panelists, and we'll discuss about weaning of the patient. Over to you, Dr. Manindra.
A 30-year-old asthmatic who was last admitted at the hospital 1 year back, presented with cough and expectoration since 2 days, shortness of breath since this morning. At presentation to the ER, his respiratory rate was almost 30 per minute with high anion gap metabolic acidosis and a lactate of 5. He was intubated in the ER, ventilated for almost a week. During the course, he received steroids and muscle relaxants as any kind of trigger was precipitating bronchospasm. After 9 days, clinical condition improved. Primary physician was contemplating extubation. So, we'll start with you, Rekha ma'am. So, what is process of getting the patient out of the ventilator called, and what is its clinical significance?
So this is what we have been seeing in this patient who has not been liberated from the ventilation for almost more than 9 days. So this process is very much essential because you have to have a patient normally breathing out of the ventilator, and that process is called as weaning. And whenever we put a patient on a ventilator, we must always have a goal of taking the patient out of the ventilator, for which case we must devote at least 30 to 40 or sometimes 50% of the time should be dedicated to this process of weaning those conditions. So basically it is weaning, successful weaning, weaning in progress, or weaning failure, as you can divide it into 3 types.
Wonderful. So as rightly told by Rekha ma'am, weaning is the process of getting the patient off the extubation. So Ram sir, any specific weaning criteria which you look into when you are planning to liberate the patient from mechanical ventilator?
We look into the subjective as well as the objective measures. We will see how both the biochemical part as well as the clinical part are important in this maneuver, which will allow us to come to a diagnosis as how much weaning can be done in the next 2 hours, after that maybe around the next 10 hours. And ultimately by another 30 to 40 hours, as Dr. Rekha has said, how we are going to extubate. So you have a respiratory rate of less than 35. We also have a PaO2 and PCO2 of around 60. We have a tidal volume of around about more than 6 ml per kg, and vital capacity more than about 10 ml per kg. All these things are taken care of.
Yeah, thank you, Dr. Manindra. At the outset, I thank the organizers, Dr. Srinivas sir, for giving me this opportunity, and I'll welcome all viewers, delegates, and my colleagues. And coming to this question regarding the indices, along with this objective and subjective criteria, these predictive indices are used in order to determine the success of ventilator liberation. These indices range from simple ventilator parameters like respiratory rate, tidal volume, forced vital capacity, and minute ventilation to the integrated indices like CROP index, which is a product of dynamic compliance, respiratory rate, oxygenation, and maximum respiratory capacity. If this is more than 13, it will consider as a good predictor. The other integrated index is P.1 by the Pi max. If it is more than 0.3, it is also considered as a good predictor. What exactly is P.1? It's nothing but it's in a simple non-invasive test which is available on all the advanced ventilator. It predicts the central respiratory drive. How you're going to calculate is, it's nothing but it's a airway occlusion pressure which is measured at the end of the inspiration after occluding for 0.1 seconds. So likewise, this maximum inspiratory capacity assesses the muscle strength. If it can generate more than minus 30 centimeters of water, it is considered as a good predictor. And most commonly used integrated indices is rapid shallow breathing index or Tobin index. How you're going to calculate this? So at the bedside, it is nothing but it's a ratio of respiratory rate by tidal volume in liters. Kindly concentrate here. It is in liters. If it is less than 105, this is considered as a good predictor. So for example, if the patient is already passed the spontaneous breathing trial and he has been kept on the lowest pressure support and his respiratory rate is generating around 30 per minute with a tidal volume of 500 ml, then our respiratory rate by tidal volume is, that is rapid shallow breathing index is around 30 by 0.5. It comes around 60. With this, the sensitivity comes around 97% to specificity is around 64%. So none of these indices only has a sufficient sensitivity and specificity. So that's why integrated indices are very truly helpful at the bedside.
Arif sir?
Yeah. Yes, sure.
So for every patient, like you and Ram sir have clearly told that this process may take variable time, sometimes almost 40 to 50% of the duration of the hospital stay. So based on the duration which is required, is there any kind of classification for weaning?
Yes, to simplify things, especially for people who are new into the ICU. So they might think that how long they have to be in the weaning process, whether they are in the right direction. So there has been a guideline, international consensus rather, the confidence on weaning according to the number of SPT that you are giving, the duration, and the results of STB, that is spontaneous breathing trial, and extubation outcome. So based on this, they have divided it as a simple, or it is difficult, or as a prolonged extubation or weaning. Okay. So patients who are weaned from who proceed from the initiation of weaning to a successful extubation in the first attempt without any difficulty, we would call them as simple weaning. Okay. So patient who achieve a successful weaning after 3 spontaneous breathing trial or with 3 spontaneous breathing trial, and may take more than a day up to maximum 7 days from the first SVT. That is, they have failed in the initial weaning and they have required at least 3 spontaneous breathing trial and have required up to 7 days for weaning. So those are patients who would categorize as difficult weaning. And patients who fail to this 3 spontaneous breathing trial or require more than 7 days from the first attempt of spontaneous breathing trial, we would call them as prolonged weaning. Attempt results in a termination of the weaning in the first day itself, or whether the first attempt results in the termination of the weaning process after 1 day but before 7 days, or the separation, or it is a prolonged weaning where the separation has not resulted in the termination of weaning even after 7 days. So this is a much easier to follow, and it can be applied in a larger population of ventilated patients. So this is how we have categorized or classified for a better understanding and management of weaning. So this is in a nutshell. There is much more to explain, but we have also limitation of time.
Excellent. So Rekha ma'am has clearly told the importance of weaning and what is spontaneous breathing trial. So moving to you, Ram sir, whenever you are planning to do a spontaneous breathing trial, how do you practice in your ICU? Whether you do a TP's trial, whether you do a conventional mode whether you go for a conventional mode like a pressure support ventilation, or do you use advanced modes? So what mode do you follow, and is there any clinical evidence which says that one is superior to other?
Well, I work in a neurocritical care, sir, basically. It is not a regular medical intensive care unit. So most of these patients are given the spontaneous breathing trial without any type of support. But if the patient is having probably some latent ischemia, some other cardiac problem, all these patients, we start weaning at what Dr. Rekha has already said, that with an inspiratory pressure support around 6 and then PEEP of around 2. In a regular pressure support ventilation mode, that has been done. And you have, as the artificial intelligence is being incorporated into the ventilators, we see now significant number of improvements, probably still to be decided and accepted clinically. They may be helpful for weaning these type of patients further. We have adaptive support ventilation, we have assist proportional ventilation, then you have non-invasive positive pressure ventilation, we have neural assisted module ventilation. All this definitely has not been shown very clinically. Not enough studies have come to say that, okay, this particular mode of ventilation is superior to this particular mode in a particular type of disease.
So what should be the frequency of spontaneous awakening trials? You already told that within 24 to 48 hours of intubation, you should start thinking about weaning. So how frequently should you do? And is it compulsory that you should stop the complete sedation whenever you are planning for weaning? Rekha.
Actually, what happens, you can start to decrease the sedation whenever, as soon as when a patient of acute respiratory failure, as I've already told you, enters into the ICU and has been put on a mechanical ventilation, you should contemplate also reducing the sedation after 24 hours. This is a thumb rule which applies to generally all patients, but need not apply to patients who are in acute respiratory failure or in ARDS, because in those patients we are already, suppose the patient is prone, definitely we would not go for such a quick sedation holiday. So that we would call it as a sedation holiday, as a thumb rule, because at the end of 24 hours we would always like to withhold or withdraw our sedation to see the assess the mental status of the patient. This achieves two things. One thing is you are taking off the opioids or muscle relaxant and you allow the patient to spontaneously breathe. This is very, very important. The force, the inspiratory force also increases once you withhold or you taper off the opioids. And then the communication also becomes easier. So it facilitates the process of weaning. So that is why sedation holiday is a must in all patients. However, if your patient, if you know is a patient is a severely hypoxemic patient who is not going to come out so soon, there is no point in reducing the sedation. The sedation has to be minimized or a little reduced to see what is the ventilatory status of the patient.
We're trying to understand weaning process in so detail. Is there any clinical significance?
Definitely, sir. Not only clinical, financial in many cases. Especially after 3 days or 4 days of staying on the ventilator, many of the patients' attendants they would be seeing when he is going to come out of the ventilator, and when the billing people are going to stop asking for more money. This happens, sir. This is what I regularly
absolutely, sir. Indian context.
And we have to, once we identify it, like what Dr. Redhand, you have been saying, where is the difficult weaning as well as the prolonged weaning, we have to tell them much earlier that this can happen and thereby reduce their tension and let them prepare for the financial expenditure that needs to be done. But a difficult thing for us, for the hospital owners, for the hospital doctors and the hospital, the most important thing is any weaning patient is going to take away 30 to 40% of your entire ICU resources. We need to have a staff nurse, we need to have the duty doctor, we need to have everybody looking at the patient, identifying whether he is going into some sort of problem and how is his cardiac function, and all this is going to take away the resources of the intensive care unit of any particular hospital. And then why is this resources are also going to be looking at the ventilator-induced diastolic dysfunction, ventilator-associated pneumonia, and VILI, that is the ventilator-induced lung injury, are quite common as the days progresses on a ventilator. As the number of days are increasing, the one after other, each problem comes in, and that complicates the weaning. And probably when it has to play a role, it will come and complicate the weaning. And
Rekha ma'am was already telling about NIV. Arif sir.
Yeah, coming to the role of non-venous ventilation in the weaning. Yeah, obviously the evidence suggests that this will be helpful in the patients who are having high risk of weaning failure. Coming to the evidence, there is a Canadian studies which was done by Burns et al. What they have done, they have compared, it's a meta-analysis, they have compared the 12 RCTs where they have considered 530 patients who have failed in the initial spontaneous breathing trial, and they have continued, they are supported with NIV, and they have compared with the patients who have been continued over the invasive mechanical ventilation. What they found was the mortality, coming to the mortality, the mortality is significantly less, as well as the increased, as well as the ventilator associated pneumonia component is significantly less, and also the duration of patient on mechanical ventilation as well as length of stay in the ICU is also less, and the need of tracheostomies is also less in the group of patients. So finally what they conclude was these patients, with the patient who are at risk of weaning failure like COPD patient, this will be helpful, NIV helpful. When compared to the mixed ICU population, there is relatively less certain. So finally, this American Thoracic Society strongly suggests that these high-risk patients like COPD as well as congestive heart failure to be extubated over to the NIV.
So moving to the case, the patient's sensorium was better, proximal power was adequate, oxygenation improved, there was no acidosis after 10 minutes. So spontaneous breathing trial was attempted, and within 10 minutes of SBT with a CPAP of 8, patient became tachypnic, and his ventilator support had to increase from pressure support to pressure control mode. Rekha ma'am.
Yes.
Ram sir, what could be the cause of difficult weaning in this patient?
Many times it is the bronchospasm that is already present, which will in turn produce autopsy, sir. That is the most worrying factor in this group of patients. And many times the other ventilator issues like associated by at the 3rd day or 4th day or 10th day, the ventilator associated pneumonia starts in, and you are going to have a trouble weaning the patient out of the ventilator. Once the VAP starts in, we are having the problems. And the first diagnosis of any VAP, as you very well know, is the hypoxia. And the moment there is some hypoxia, the staff nurse goes and increases the oxygen to 100%, so that the saturation stays around 93 or 97%. So repeatedly we continue to tell them that 90% is adequate enough. And these are the major problems with bronchoconstriction, that is the production of autocue. This is the basic problem of any patient. And this is why one reason this patient will not come out of the ventilator or might be given a chance with NIV before we say, okay, this is a good patient and he is going to come out. And 60% of the patients do come out with NIV ventilation.
Wonderful. Arif sir, what are all?
Yeah, coming to this causes of difficult weaning, as Dr. Rekha ma'am expresses that the patients who needs up to 3 days of 3 attempts of spontaneous breathing trial or up to 7 days of spontaneous breathing trial, they'll be considered as difficult weaning. Because 20 to 30% of the patient who has been ventilated will come under this category. These are the real patients who will be giving a challenging to the intensivists in day-to-day practice. Coming to the causes, we can group these causes under like respiratory, neuromuscular, neuropsychiatric, metabolic, as well as cardiac causes. Coming to this respiratory, so where in the patients with respiratory problem, like where there is a decrease in the lung complex, as we are going to see in the pulmonary edema patients, pneumonia patients, ARDS patients, as well as in the fibrosis and atelectasis patients, they'll be having a difficulty in weaning. And also where there is a poor chest compliance, which can be seen in the patients where we are having a massive pleural effusion as well as a massive abdominal distension. This can contribute for the difficult weaning. And also where the patient in which they are having an increased resistive loads, like in case of the patient with bronchoconstriction, the patient with dynamic hyperinflation in COPD patient, as well as the patient with the airway obstruction, all these things can also be contribute for the difficult weaning. As in our case, we are having a bronchoconstriction, that the presence of wheeze will identify that. And also coming to the neuromuscular, this can contribute to the difficult weaning. And what are the metabolic or electrolyte parameters which are responsible for the difficult weaning is most commonly it is potassium as well as magnesium. And also the other electrolyte is the phosphate we have to consider when the patient is not able to wean. Okay, so coming to this other thing is neuropsychiatric causes. When the patient is in delirious stage, anxious stage, we have to take some time and we have to evaluate the reason for the delirious before weaning the patient. And also the most important factors in the elderly patient, COPD patient, is the coronary component, the cardiac causes. Whenever you are placing the patient on the spontaneous breathing trial, when the patient is going into the pulmonary congestion, you have to consider that this patient is having a cardiac factor which is contributing for this difficult weaning. And also as this patient will be present on the ventilator in the ICU from the long standing, we have to be considered regarding this their nutrition status as well as the hemoglobin status in order to consider the difficult weaning. So in weaning analysis, weaning protocol, in the analysis of the weaning protocol, LA has suggested one mnemonic as most of
all the causes of difficult weaning.
Look at the central level.
Wonderful, ma'am. Ram sir, so do the ventilator settings or ventilator parameters and various auxiliary equipment which you use to connect between the patient and the ventilator influence your weaning process, sir?
Yes, sir, definitely. Anything right from the circuit right up to the ventilator, anything that is wrongly set or wrongly put to the patient, or sometimes not understanding the disease perfectly well and putting the patient on certain set mechanisms, all this can increase the patient's weaning time, especially the equipment dead space, as well as the circuit compliance, whether the circuit that we are attaching is it compliant. And compliance is one of the most important things when we are weaning, as well as in the regular ventilator time. And any dysfunction at the exhalation valve is going to worsen the patient's condition. And you also have seen any increase in resistance, like what people have already said, like because of the secretions that have not been sucked out, or because of the atelectasis that is already present. All these things are going to increase the time of weaning period. When you come to the ventilator time, when we are coming to the ventilator, this thing is basically if there is a ventilator dysynchrony, especially there is an inadequate inspiratory flow or a flow rate or a flow trigger that is not adequate, then we are something not doing a great favor to the patient. The lead time between the onset of the inspiratory effort and the onset of the flow delivery is also important. That needs to be corrected if it is not already corrected. And then respiratory effort at the end of after the onset of the expiration is another important point from the ventilatory command. And mostly important we are looking at is triggering, which is very, very ineffective. And that is not allowing the patient and to go for a spontaneous breathing effort. And thereby it continues to ventilate. And we all know what problems.
Prolonged weaning, and how will you diagnose it and how will you treat it?
When the patient develops intrinsic PEEP, the patient doesn't recoil and it takes a long time to get the triggers. So for that reason, we need to first identify whether there is an intrinsic PEEP or not. And there are various methods of identifying. We should first have a high index of suspicion. Okay. And then we should identify that the patient is having high PEEP, intrinsic PEEP. There are various methods. One method is we equilibrate the alveolar pressure and airway with the airway pressure by the inspiratory hold maneuver. You just give an inspiratory hold maneuver, you pause it for 3 to 5 seconds, and then you see that it goes above the plateau. It goes above the PEEP. That curve, it goes above the PEEP. So that is how you come to know that the patient has developed an intrinsic PEEP. At the same time, if this is not away or you are not able to do this, you can hold the expiratory circuit. You can just remove it and occlude the expiratory circuit also for 3 to 5 seconds also. Then you will see that it goes above the PEEP. The graph goes straight above the PEEP, and which shows that the difference is the intrinsic PEEP. And the other method is if you have an expiratory flow curve in the flow time curve, you can see that this doesn't come to the baseline. The expiratory flow curve in the flow time curve of the volume control mode, it doesn't reach the baseline. And that part is the spontaneous breathing that takes place, which shows that the patient is developing an intrinsic PEEP. And it is very important to remove this intrinsic PEEP. Either if the patient can tolerate a higher PEEP, then in that case, it is better that you include that in your PEEP. At least 80% or 2/3 of the intrinsic PEEP you include in your PEEP. That is the way you take over.
Does this weaning process cause any myocardial ischemia or I think you have already mentioned in your previous question you were telling about diastolic dysfunction. So, and the importance of cardiology consultation. So does weaning induce any myocardial ischemia?
I would like to say it can cause, but it will be in susceptible individuals, may not be the entire gamut of the patient. So it is, we have to see whether by doing an echocardiogram at least, we will be able to identify whether there is any cardiac dysfunction on the day one itself. So that after 3 days or 4 days, when you are doing it, you can place the same echocardiogram to identify how is the cardiac prevention on third day compared to that of the first day. And in susceptible individuals, definitely there is a problem of having myocardial ischemia during the weaning process, especially with a spontaneous breathing try, especially if somebody has left the patient with only an endotracheal tube with oxygen alone, but not without any pressure support that is being given. And this can definitely happen by basically producing pulmonary edema. Pulmonary edema is the culprit. And the pulmonary edema, it can happen because of 2 reasons: extensive fluid that has been gone into the patient, so the fluid overload, and probably the kidney is not probably functioning at that given moment very effectively. And it is, even if you have reduced the amount of intake, still the patient is in a state of fluid overload, which can once more be diagnosed either by the pool effusion or by seeing any particular ascites with your ultrasound machine. Basically, the latent ischemia, now what happening is, the latent ischemia is there during the spontaneous, it gets worsens. So you see the ischemia is now completely manifest, and then there is a reduction in the compliance of the left ventricle. Once there is a compliance of the left ventricle, the pulmonary edema happens. This is the cycle of the events that happens. And once the pulmonary edema is occurring, it is decreased lung complaints, and then it is increased the workup breathing. And workup breathing, all this will be happening during the spontaneous breathing tract. And
patient was started on steroids. Over the next 3-4 days, bronchospasms settled. Patient's proximal power was pretty good. He tolerated a CPAP of 8 for 30 minutes with a RSBA of 45. Finally, a decision was taken on day 12 and patient was extubated onto face mask. Immediately after extubation, patient became tachypneic and there were harsh breath sounds. What could be the cause, Rekha ma'am? And how do you approach this patient?
If this patient has a harsh breath sound, or the patient is developing, whether the patient is developing a stridor or not, we should be able to identify. That typical wheeze will be there, that sound, grunting sound could be heard, and then if you auscultate, you can find out that the patient expiration is not enough. In those cases, it probably is due to the pressure that has been exerted by the endotracheal tube. It can cause a post extubation stridor, which is a very life-threatening process and can occur in some small percentage of patients. Let's say around 10 to 15% of patients can experience stridor if they have been intubated for a prolonged period, and if the sufficient care has not been taken, if a manometric testing of the inflation balloon has not been taken care of, and if the patient, sometimes we deflate the cup also in between, we reposition the tube from one side to the other. Those small tricks also matter a lot to prevent the post-extubation stridor. It can cause mucosal ischemia, edema, and so many, and sometimes necrosis also. It can be can be sometimes life-threatening also. So it is very much necessary that before, in this group of patients, you should have a strong suspicion index. So if you are already suspecting, then you should always do, or rather mandatorily do in all these patients, a cuff lick test. Okay, 110 to 130 ml in assist control mode after deflating the tube, which will help you the patient who are likely to develop a post-extubation stridor. Okay. And then if you are suspecting them, it is better to give them methylprednisolone before extubation, ideally 2 hours or 1 hour before extubation. But in my patient, I go for simple hydrocortisone. I give them simple hydrocortisone.
There is a possibility, there is one of the study which has done is Outcome Ra group has studied this. What they have concluded was there is an increase in the nosocomial infection, consequently increasing the length of the stay on the mechanical ventilation, in the ICU, in the hospital, by also increasing the cost as well as the increasing the morbidity as well as the mortality. So what are the possible causes is the early extubation failure may be because of upper airway edema and airway collapse, and later extubation failure may be in the COPD cases and CVV cases. So Neer and et al. Has studied that they considered 5 to 20% of the cases of extubation failure are acceptable. If they are more than 20%, we have to think that we are going too early regarding the extubation. If it is less than 5%, we have to think that we are not considering the extubation, we are considering it late. So in order to prevent this decrease in the morbidity as well as cost and mortality, we have to, while extubating patient who have high risk of extubation failure, for example, the patient with advanced stage, the patient with high severity index while admission as well as extubation, and also the patients with chronic respiratory and cardiovascular problems, we have to think of this, and before extubating, we have to treat the possible causes in order to decrease this morbidity, the cost and mortality.
After day 13, patient got reintubated. Methylprednisolone was given for almost 3 days. Then after on day 15, the patient's cuff leak was tested, which was around 100 to 150 ml. But when the patient was asked to lift the hand, he was not able to lift the hand, and he was not able to do the neck folding for more than 2 to 3 seconds. So, Rekha ma'am,
yes.
What could be the cause for this patient where he is facing the difficulty in even doing a neck folding?
Okay. So we would consider about the neuromuscular causes. what are the neuromuscular causes that could give rise to tail weaning. And most often, patient can have a critical illness neuropath. Particularly in a very short span, patients sometimes develop if the patient doesn't have, and the causes are multiple. But nutrition plays a very important role here. The metabolism that takes place in the patient is very important. And so all this total imbalance between the metabolism, the hypercatabolism that is taking place in the patient, and the supply of the nutritional supply that is occurring in the patient, they can be also decreased. You do not have much chances that the patient is not having a good BP, also blood pressure, is in hypertension. You cannot adequately give adequate nutrition to the patient, and parenteral nutrition is not really advocated in all patients, and it doesn't really work out so well. So decreased neuromuscular capacity, critical illness, myopathy. You must look at the electrolyte imbalance in these patients also, whether about the magnesium level, the calcium level, hypomagnesemia, hypocalcemia, hypophosphatemia, hypokalemia. They can all contribute. The drugs, that nebulization that you are giving can give rise to hypokalemia. If you are giving a diuretic, if you are thinking of a diastolic dysfunction, as Sir said, then in that case you need to give some diuretic to the patient. All of this can give rise to hypokalemia to the patient, and hypophosphatemia, which also occurs in certain group of chronically malnourished patients, and chronically ill patients have of difficult weaning. Thyroid, what is the thyroid status? Most often patients are hypothyroid. Adrenal insufficiency, sepsis itself, all of this can give rise to a very weak neuromuscular status of the patient, and therefore can contribute to difficult weaning. And as you all understand, there is also why this is occurring is because of the critical illness oxidative stress that is occurring at the mitochondrial level. The mitochondria is undergoing a lot of changes, the swelling, the damage to the myofibrin, the lipid vacuoles. All this can lead to a poor neuromuscular status of the patient.
Wonderful.
So would you like me to go ahead?
No, ma'am. Ram sir, ma'am clearly told what all could be the causes of difficult weaning, and you clearly told in the initial part of your session that ultrasound is going to replace the stethoscope. So, do you find any role of ultrasound machine in weaning, sir?
Definitely, sir. With the advent of people who are practicing ultrasound in the intensive care units, like all of you, for the last 15 years, I think the prognosis in those intensive care units where ultrasound is used versus the prognosis in ICUs where ultrasound is not used is significant. We are seeing this, and we have to accept that ultrasound is going to really play a dramatic role in the later generations once AI is incorporated into the most of the ultrasound machines that are going to come. And as we all have been saying, the acquired diaphragmatic dysfunction following prolonged mechanical ventilation, we can see that it is the outcome of the weaning is getting affected. And DNO has said that the diaphragmatic dysfunctions, by measuring the difference between the diaphragm thickness at the end of the inspiration and the expiration using ultrasonography to view the diaphragm in the zone of opposition is the most important point that we need to do it. And for the people who have been doing it, they are saying that it is definitely maintained. And I have started doing this. And we have found that there is a difference of 30% to show that whether there will be an extubatory failure or not. And with the sensitivity of around 88%, with the specificity of
extubation, or do you go ahead and do a tracheostomy for weaning this patient? So in this particular patient, is there any role of
coming to the role of tracheostomy in weaning. So as we all know, the tracheostomy decreases the airway resistance, decreases the dead space, thereby leading to decreased work of breathing. And coming to the other benefits of tracheostomy, if the patient is on ventilator, there may be lesser requirement of sedation, or ease of oral care will be better, and also there is better airway toileting. And also, if the patient, the tracheostomy is done, there was the psychological well-being will be better when compared to the patient on the normal intubation. So, And coming to the evidence, the Trackman study has concluded that there is no improvement in the mortality in ICU because of the tracheostomy, and also there is no benefit from any major secondary outcomes also. And there is no difference between the early or late tracheostomy also. So, and probably this tracheostomy probably accelerates the weaning process. And the current evidence, coming to the current evidence, does not suggest or reject the role of tracheostomy to facilitate the weaning.
Tracheostomy, and in general, is there any role of tracheostomy for weaning? Finally, on evaluation, his phosphate was very low, like Rekha ma'am clearly told. Electrolyte, one of the most important cause, his phosphate was 0.8. So after correcting the phosphate, his proximal muscle weakness improved. Eventually, we did a tracheostomy for this patient. And after 26 days of ventilation, we discharged this patient with tracheostomy. And after 1.5 months, we decannulated this patient.
Hello. Hello. Pasha. Yeah, thank you so much. It has been a wonderful discussion. Pasha sir and Ram Gopal sir, you want to add something? Pasha sir, am I audible?
Unmute, sir.
Dr. Pasha has been mute, sir.
Yes. Yes, am I audible?
Yes, sir, now you're audible.
Yes, finally, in order to conclude, in our cases, it has been the right decision to go ahead with the tracheostomy, because even though the studies has not suggested or rejected, but it depends upon the individual cases. The bedside intensivist will have a best decision. Yeah.
Yeah, thank you, sir. Dr. Ram Gopal, you want to add something? Dr. Manindra, your closing remarks on the discussion. Am I audible?
Yeah, you're audible.
Dr. Manindra.
Mithilesh, we'll come to a conclusion.
Yes.
I think before we conclude, I think there are two questions from the previous session that I can see in the chat box. If it's okay. One, do we check gastric residual volumes daily in all patients at least once? Once a day is okay, but routine, regularly checking gastric residual volumes every 4th hourly or 6th hourly is not recommended. And basically, for multiple reasons, they are not reliable in predicting the risk of aspiration. You don't know what is the exact cutoff volume where the risk of aspiration increases. There are multiple technical compounding factors when you're looking at gastric residual volume, depending upon the position of the tube, depending upon the gauge of the tube, depending on whether you're just leaving it to gravity or kind of actively using suction to aspirate it. So there are multiple confounding factors because of which using of gastric residual volumes is not recommended. And when you have a patient with ileus, it's always better that you look at the factors which are contributing to ileus. Post-operative surgical ileus is very, very common, and one of the best stimulus is to start early trophic fits. That's the best stimulus that you can get the gut moving. However, keep a watch on what's happening with your electrolytes because they're very, very common, especially potassium and magnesium. Look at your opioid usage. Opioids, we all know, have a negative effect on the bowel motility. So minimize your usage of opioids if you have patients with ileus. And yes, you can continue with small amounts of feeds, but if you have high gastric intolerance, then it's better that you wait, and until the ileus is corrected, looking at all the reversible factors. If not, you can look at use of neostigmine as one of the gut promoting your gut motility. Then you can consider feeding. Otherwise, look at the reversible causes of correcting your ileus.
I think with this question and answers, we'll conclude for the day. Tomorrow we'll meet again at 9 o'clock with topics, and then we can start again.
Thank you, Dr. Arif, Dr. Ramgopal, Manindra. Thank you so much for being there.
Thank you.
Thank you, Dr. Pasha. Thank you, Dr. Manindra. Thank you, Dr. Ramgopal.
Thank you for the great opportunity. Thank you all for the viewers.
And thank you, delegates. We'll meet again tomorrow morning at 9 a.m.
Yeah, so.